Okay, Assalamu alaikum. Good morning, everyone, and thank you for coming to start our day. It is a full day of scientific program, and as it is the case, we normally start our second day with basic science research. It is, of course, very important, and it has been the main gate for the new inventions and developments in the pulmonary hypertension treatment. It is my pleasure this morning to co-chair this session with Dr. May Zayed. The Doctora is a scientist from King Abdulaziz City for Health and Technology, and she worked with our first speaker. So she is going to introduce our first speaker, and then obviously we have two other main talks regarding individualizing pulmonary hypertension treatment, as well as some targeting pathways in the pulmonary hypertension. And we'll end this session with one of our PhD student from UK who is going to present her work as well. So Dr. May, please introduce your first speaker.
Please welcome Dr. Beata Stothard. She's a reader in vascular biology, deputy head in vascular sciences, National Heart Institute and Lung Institute from Imperial College London.
Thank you very much, May. Good morning, everyone. First of all, before I start, I would like to thank the organizers, especially Professor Aldalan, for inviting me to this conference. I'm really enjoying my stay. This is my first time in Saudi Arabia. I would like to thank you for your hospitality. So, as Luke said yesterday, we are not there yet, meaning we don't have a cure for pulmonary hypertension yet. And this may be because drug targets found out, established in preclinical research, fail in clinical trials. So, how do I advance this? How do I advance this? Oh, yeah. Go back. Okay, so we can have a look at the current standard ways of looking at drug targets in preclinical research. What we are using are culture dishes, such as this one, for instance. They have limited relevance to in vivo physiology. You can see that the dishes have rigid structure. They allow culturing of only one cell type under static conditions. So far from relevance to human physiology. Also, there are species differences. So human physiology is different from animal physiology. And animal models don't fully reproduce pathology of human pulmonary hypertension. So the last decade has generated new ideas and brought new technologies that may provide a solution. So we have stem cells, in particular induced pluripotent stem cells. You can derive cells from individual patients. For instance, organoids, patient-based organoids, and organs on chips. So this is what I'm going to focus on today. So let me define for organs on chips. What are they? Organs on chips are microfabricated cell culture devices, three-dimensional microfluidic cell culture devices designed to model the functional units of human organs in vitro. So they are like mini organs in culture dishes. And the overarching idea is to introduce a network of interconnected organs on chips to create a human body on a chip. So you can imagine in future, we won't have to test drugs in clinical trials. Perhaps there will be a body on a chip to test the drug effects. So why are they called chips? It is because we are using the same technologies we use silicon wafers and photolithography and etching in silicon substrate, techniques that are used to microfabricate computer chips. That's why organs on chips. So the first chip was identified, was discovered in 2010 by Professor Donald Ingber, who produced a lung on a chip model. So our chip looks very much like this. It's made of transparent polymer that allows observations of live cells. And inside these chips, there are tiny channels. Chips produced have traveled to space. So it's an expanding field. So our interest was to model small intrapulmonary arteries relevant to pathology of pulmonary hypertension. And as you know, pulmonary hypertension is a multifactorial disease. It's thought to be initiated by a variety of different hits. And it's thought that endothelial injury as a result of a combination of different hits, hypoxia, inflammation, and for instance, BMPR2 loss of function of bone morphogenetic protein receptor 2, which is the most common mutation in pulmonary hypertension. These insults injure the endothelium, and this is what our project was based upon. So this is a part of vasculature modeled by lung on a chip. In our model, we were modeling partially muscular and muscularized arterioles, really. So how did we do that? The most important thing always when you start a new project is to find a dedicated PhD student. So that was my PhD student, Alex Ainsko, who is at the moment in Harvard Institute, in Harvard University, doing his postdoctoral studies. So Alex spent long hours in the clean room producing these chips. So this is the chip looked like. Just trying to find, oh, there is a pointer, that's good. So this is a schematic diagram of a chip, very small, around 1 centimeter long, with 2 channels, each channel separated by a semi-permeable porous membrane. And in this chip, you can see, so this is a cross-section of one of the channels. You can see human pulmonary endothelial cells grown on one side of the membrane and human pulmonary artery smooth muscle cells grown on the other side. These cells can be kept in culture for weeks and observed for weeks. And medium is pumped through the endothelial channel, mimicking blood flow. And it's actuated by a peristaltic pump. We designed pulse dampeners, so you have a steady and laminar flow. We confirm that carefully using software that the flow is laminar, so you can see flow lines here. And it's a physiological level of flow characteristic of small pulmonary arteries. Okay, so this is the setup. We can run around 50 now chips at the same time. Each chip has 2 channels, so you can imagine each chip can have cells from one patient. So you have a system for drug screening. So fortunately, PDMS, this polydimethyl siloxane, the material chip is made of, is transparent, so we can observe cells. Oh, can we go back to the previous one? So we can observe cells, and what we have achieved is alignment of endothelial cells within the direction of flow, like it is in arteries, and smooth muscle cells wrapping around at 90 degrees. So we achieved a physiological arrangement of cells from pulmonary arteries. This is a video. I don't know if I can run it. Can we? Okay. So this is confocal imaging. You can look at these cells live for many weeks. You can apply drugs to the system, and using fluorescent assays, have a readout of cell proliferation and other functions. So this is our model of pulmonary hypertension. We induced BMPR2 knockdown by adenoviral gene transfer, so knocked down BMPR2, and combined this insult with hypoxia. So it's a double hit model. We also validated this system by using endothelial colony forming cells, which are derived from circulating progenitor cells from patients with BMPR2 mutations. So this is an induced BMPR2 deficiency, and this is natural BMPR2 deficiency in this model, and combined it with hypoxia. So this is using ECFC is a very good tool in research. It takes around 28 days to get these cells from blood, but they are an excellent tool in research because they reproduce certain features of the disease. So you can take blood from patients, culture these cells, and then get patient specific responses. So this is what Alex was doing, producing chips, culturing smooth muscle cells, seeding them in a channel, then culturing endothelial cells, knocking down BMPR2, seeding in a channel, and then putting cells under flow. So it's an easy and reproducible kind of system. Very briefly, what we have achieved, we observed that the double hit produces smooth muscle proliferation. It's like in animal models of the disease as well. And that was reproduced also with patient cells. If we combined hypoxia with cells from patients with BMPR2 mutations, we achieved this kind of remodeling of smooth muscle cells. What we also observed that these responses were inhibited by imatinib, PDGF receptor inhibitor. We performed RNA sequencing of cells from endothelial layer and smooth muscle layer under all conditions. So we obtained a huge amount of information, identified genes that were upregulated and downregulated. And these are heat maps representing in color changes in gene expression. Towards blue is downregulation, towards red is upregulation. And you can observe they illustrate changes in gene expression under all conditions. And this gene set that highlighted here is characteristic for the double hit. So this is like a disease signature on a chip. And we were really pleased to see that we identified a number of different hits already described in human pulmonary hypertension, such as you can see SOX18, SOX17, KLF2, potassium channels, and a downregulation of the whole group of enzymes regulating nitric oxide bioavailability. So the model was validated in a way by publications, existing publications in this area. We then performed a validation of this model, further validation by comparing our data sets with the existing published data sets from pulmonary hypertension. So from cells, for instance, isolated from patients, or the whole lungs from IPAH patients. And there was a high degree of similarity between our model and the published models. So we obtained I can perhaps call it a signature of the disease. One very consistent change that was observed. Oh, sorry, can we go back? Right, just pressing the wrong buttons. So one very consistent change that was down regulation of SOX17, which is a new gene associated with pulmonary hypertension. And SOX17 was down-regulated under conditions of double hit in all systems and also in human databases. So we looked into this further, and we confirmed that so BMPR2 knockdown reduces SOX17 expression in mice carrying BMPR2 mutation. So you can see this is a blood vessel, and in pink is a co-localization of SOX17, which is transcription factor, with nuclei, which completely disappears in these mice with BMPR2 mutation. And here in cultured cells, a double hit removes completely SOX17 from the nucleus. So SOX17 is very strongly downregulated under these conditions. So we performed proteomic analysis to identify targets of SOX17. And interestingly, prostacyclin synthase was the highest, the most significantly upregulated protein. So SOX17 induces prostacyclin synthase. We then proved that this regulation of smooth muscle proliferation under the double hit conditions is likely to depend on this SOX17 prostacyclin signaling because we applied this prostacyclin receptor inhibitor and the effect of SOX17 overexpression, which rescued this BMPR2 induced downregulation, upregulation of smooth muscle proliferation was inhibited. So prostacyclin and SOX17 axes mediate the effects of double hit on smooth muscle proliferation. We then tested the effects of other drugs. Sorry, I'm going too quickly. So we tested in collaboration with AstraZeneca a novel BRD4 inhibitor. BRD4 is a cell cycle regulator. And also ambrisentan was effective in this system. So to summarize, we presented a microfluidic inducible model of vascular dysfunction in PAH. This model informs of functional and transcriptomic effects of endothelial BMPR2 deficiency and hypoxia. And smooth muscle proliferation was attenuated by 5 drugs exhibiting different modes of action. So this model offers an economic use of cells because we only use 10,000 cells per channel. So you can have very few cells from a patient and perform a number of different assays on it. It's a short experimental time. The device is cheap to produce. And basically, it's perhaps a viable alternative to animal experimentation. I should mention another model of PAH, which utilized a different device. There's no time to talk about this, but this is a device that has all cells in one plane, and cells contact each other through these little posts. So this model doesn't really offer, is not suitable for drug testing, and you cannot measure endothelial permeability in this system, for instance. So are we there yet? Can we create a human body on a chip? Unfortunately, not yet. It's a big challenge, but we have to remember that we are all working with models. So all models are wrong, but some are useful. And I'm really hoping that our model is useful for certain purposes and can provide some useful information. And the best material model of a cat is another, of preferably the same cat. So we understand what pulmonary hypertension is, but the image of it will vary from patient to patient. So with this, I would like to finish, acknowledge my group, and this is May when she was doing her PhD in my group. So there's no time to talk about her research, which was really fantastic. And this is my current group, and Rehab is going to give a talk later in this session. Thank you very much.
Thank you so much, and please join us here in the panel. Yeah, so the question and answer will be at the end of the session. Thank you so much. So it is my pleasure to introduce the second speaker for this morning's session, Professor Mark Homber, who couldn't make it, so his talk is actually recorded, but he will join us at the end of the session for a question and answer. Professor Mark Homber has been a friend for SAPH for many years. He is one of the international figures for pulmonary hypertension. I just learned yesterday that he was also elected as a dean for his university. So Mark is going to talk about the new, PDGF pathway, a possibly new target for pulmonary arterial hypertension treatment.
Hello, my name is Marc Imbert. I'm the director of the French Pulmonary Hypertension Reference Center at Université Paris-Saclay, Hôpital Bicêtre, Assistance Publique Hôpitaux de Paris in France. I'm delighted to contribute once again to the Saudi Association for Pulmonary Hypertension. Many thanks to Professor Abdullah Al-Dalan and his colleagues for the very kind invitation to contribute. Well, today I've been asked to discuss the platelet-derived growth factor pathway, the PDGF pathway. Is it a new target in pulmonary arterial hypertension? As you can see here, I have some disclosures to report. And I would like to start by a broad comment that there are many drivers of pulmonary arterial hypertension pathology. And the way from a healthy, normal vascular lumen to a remodeled vascular lumen characteristic of PH is extremely complex. There are many, many abnormalities which lead to pulmonary vascular obstruction. And clearly, there are some vasoactive mediators, genetic drivers, mediators like growth factors, inflammatory reaction, metabolic pathways, neurohumoral pathways, and oxidative stress, all contributing to pulmonary arterial hypertension. And this very complex network has to be better understood in order to develop drugs and advanced science. There are many, many possibilities to interfere with pathogenic pathways in PAH, and you can consider the genetic background. I did cover that many times with you in recent years, but you can also target other contributors to PAH, including growth factors. And in fact, there is no shortage of drug targets. Regarding PDGF, platelet-derived growth factor, there are different options. And as you will see later on, there are novel drugs which have been developed specifically for the purpose of treating PAH, but there are also repurposed drugs which have been successfully developed in other indications and which might be of interest in PAH. So let's go a little bit further in PDGF receptor signaling, which plays a really important role in lung development. So platelet-derived growth factor receptor, they are cell surface tyrosine kinase receptors. And the signal transduction occurs via two main pathways. One pathway is PI3K AKT-mTOR, and the other one is the MAP kinase cascade. And these two pathways lead to signals which induce the proliferation and migration of smooth muscle cells and fibroblasts. So it is certainly an important trigger for remodeling in many organs, including the lungs and including the pulmonary vessels. When you look at the disease we are experts in, pulmonary arterial hypertension, there is a clear abnormal PDGF signaling. So an aberrant PDGF signaling occurs in PAH. In PAH, there is an increased expression of PDGF A and B and of the PDGF receptors which are important in the transduction of the signal led by PDGF. So in patients with PAH, and you can see that at the bottom of this slide, there is an important expression of PDGF and PDGF receptor, which is certainly a contributor to pulmonary vascular remodeling. And it is important to bear in mind that this target, PDGF and PDGF receptor, can be certainly assessed, addressed by could be PDGF receptor tyrosine kinase inhibitor. When you look at a very well-known PDGF receptor tyrosine kinase inhibitor, imatinib, which is very well known by all of you because it has been a game changer in the treatment of chronic myelogenous leukemia, and imatinib or Gleevec has been really very successful in that indication. But imatinib is also a very strong kinase inhibitor of the receptor for PDGF. And you can see here on this slide that it is clear that imatinib reduces PDGF-induced smooth muscle cell proliferation. And this is dose dependent. And this can be really very important for future drug discoveries in PAH. So after discovering that imatinib was certainly a good treatment for reducing PDGF receptor tyrosine kinase stimulation in PAH, some colleagues have either treated patients because they had comorbid chronic myelogenous leukemia and PAH, and they have reported positive outcomes in these patients. Some very rare case reports have also shown that imatinib could have an action in patients with advanced PAH, but there was a full program led by colleagues in Germany, like Ardi Gofrani, and I'm going to show you some data from the phase 2 randomized controlled trial of imatinib in PAH patients who have not been treated successfully with established therapies. So you see here on this slide that 59 patients with PAH received imatinib at doses ranging from 200 and 400 milligrams or placebo. And after 6 months, it was possible to measure the primary endpoint 6-minute walk distance. And you see here that there was an improvement in walk distance with imatinib versus no response with placebo. And in terms of pulmonary vascular resistance, there was a pronounced reduction in PVR as compared to what was observed with placebo. A post-hoc analysis focused on the patients with the most severe PVR elevation. And as you can see here, both in terms of walk distance and in PVR reduction, there was more effect in patients with more elevation in PVR with treatment with imatinib. Based on that, Marius Hopper and his colleagues have developed a phase 3 trial, namely IMPRESS, which has recruited 202 patients with PH, and these patients either received imatinib 200 to 400 milligram per day or placebo as an add-on therapy on top of 2 PH drugs. After 6 months, the primary endpoint was the change in 6-minute walk distance, and as you can see here, there was an effect in terms of walk distance. However, as you can see at the bottom of this slide, there were less patients tolerating imatinib than placebo, and there was, of course, an issue related to the tolerability of this treatment. And as you can see here, because of that difficulty, there were multiple imputations performed, and these multiple imputations all led to a better improvement of 6-minute walk distance with imatinib versus placebo. So the take-home message here is that the drug certainly has an effect. The drug had also side effects, and this was an issue to consider for future development. And this is very clearly showed here. Time to clinical worsening was worst with imatinib versus placebo. So this is an important message. And among the side effects, there were some bleeding with subdural hematoma, and these bleeding were considered as, of course, severe. In the same lane of thinking, some colleagues also try to develop more active multi-kinase inhibitors, such as sorafenib, which is used in cancer, and such as kidney cancer. And sorafenib targets, of course, PDGF, but also VEGF and multiple targets. And in experimental models, clearly, sorafenib as imatinib has an effect in experimental model of pulmonary hypertension. And PAH and experimental PH are characterized by abnormal proliferation of components of the pulmonary artery wall. And with sorafenib, you could observe decreased proliferation and increased apoptosis of the pulmonary artery smooth muscle cells. In a small 16-week phase 1b single-center open-label trial of sorafenib, Mardi Gomberg-Maitland reported the outcome of 12 patients with PAH on parenteral prostacyclin. And what she observed was that the drug was not well tolerated because of skin reaction, alopecia, and other side effects. And there was also no change in pulmonary vascular resistance, a reduction in cardiac output, but an improvement which was not significant in 6-minute walk distance. So multi-kinase angiogenesis inhibitors such as sorafenib are maybe excessive in terms of drug development, and thus most of the colleagues considered that drugs resembling imatinib should be developed, maybe administered by inhalation in order to reduce the systemic side effects. And seralutinib has been developed by the company Gossamer as a tyrosine kinase inhibitor acting on PDGF receptor, c-KIT, and also a marker of inflammation, CSF1R. And inhibiting these three targets could modulate not only remodeling, but also recruitment of cells and inflammation, all pathways involved in remodeling in PH. And therefore, seralutinib has been proposed as a possible treatment for PAH. In addition, it could increase indirectly BMPR2 expression. So this is really interesting. And recently, TORREY, which is the study of seralutinib administered by inhalation in PAH patients, has been concluded. This is a phase 2 double-blind multi-center randomized controlled trial evaluating several doses, of seralutinib administered by dry powder inhalation from 55 to 90 milligram BID versus placebo in patients with PAH. The patients had to be in functional class 2 or 3 PAH on standard background therapy, including background triple, and they need to have more than 400 dynes PVR, and the primary endpoint was PVR, and the key secondary was 6-minute walk distance. The dosing regimen was dose titration in range of 45 to 90 milligram BID by inhalation. Once again, this inhalation approach is interesting. They were, of course, exploratory endpoint. And in the recent weeks, you have seen that TORREY data have been announced. It is only a press release, so I have no access to detailed information. The PVR change at 24 weeks was changed, and it was positive in terms of endpoint. We need to know more in terms of magnitude of effect and subcategories of patients who might benefit more of this option. But it is certainly a promising first step, and we need to know more about the data in order to better understand what kind of phase 3 trial should be performed. But I know that my colleagues and the sponsor are working very, very hard on that. There are other approaches, and IMPACT is another randomized controlled trial which is developed by the company Aerovate. It is a phase 2b/3 adaptive continuous trial of a compound AV101, which is in fact inhaled imatinib. And this drug has, of course, been evaluated by our colleagues. And we currently have recruitment in the phase 2b branch of period 1 of the trial. And it is very likely that after completing period 1, the target dose by inhalation will be known. And after period 1, period 2, and period 3 will be possible in order to be seamless developing a treatment option by inhaled imatinib, first in phase 2b with a primary endpoint of PVR, and then in phase 3 with a primary endpoint of 6-minute walk distance. So clearly, phase 3 enrollment begins immediately upon completion of phase 2b enrollment, and the dose selected in phase 2b will be used in phase 3. So this is, once again, a very promising approach. And as you can see, targeting the PDGF path
are an approach to trying to take your patient's individual characteristics into account. And in fact, if we look very carefully at the guidelines, over to the side, they say, when you have somebody with comorbidities, before you jump into going with double upfront combination therapy, regular follow-up assessment, individualized therapy is recommended. So we do that in that setting. And one of the reasons for that, and we've seen this from some of the presentations from meta registry, it's compiling registries from a number of different countries. This is data from the UK national audit that I think sort of shows us a little bit of the direction and way maybe going in that. So what they've done here is they've taken really very careful genotyping and very careful phenotyping and linked the two together to see what they might tell us about our individual patients. And if we zoom in a little bit closer, I just think to pick on a few, BMP is a gene present throughout the different phenotypes of pulmonary hypertension. If we've heard a little bit over the last 24 hours about SAPH2023, and it lines up with the younger patient population. If we look at our marker for PVOD, for example, IKEA over here, it links up with patients with lower diffusion capacity. But also, I'd like just to highlight that picking out one that we hadn't thought about before is this KDR mutation, which is linked up with low diffusion capacity in older male patients. And in fact, it links up with a nice gene encoding for a VEGF receptor. So by doing this very close genotyping and phenotyping linking together, I think we'll make significant progress in understanding the disease, but then being able to target therapies better. But to do that properly, I think we're going to need something else. And I think that as we learn more about each individual patient, their health status, their nutritional status, how much exercise they do, where they live, everything else, if we do that, we're going to need artificial intelligence to crunch that and be able to come up with suggestions for us. We're going to get into the era very, very shortly where we just got too much data to deal with. And we're going to need some help to understand that better so it can help us with our decision making, not only to tell us what drugs patients need, but how much exercise they might require, how they might need to change their lifestyle and their nutrition. And I thought one thing over the whole time of COVID, we learned some interesting things about how we might monitor how our response to therapies are going. In a very basic level, one of the questions, and this is work from the group in Sheffield, Professor David Kiley's group, looking at how can you monitor patients and their responses even more carefully, even from home. And they were looking at BMP measurements. You can do a BMP test at home and send it in and have it measured. But you can also do shuttle tests and walk tests at home and see if they're as good as they are while you're in the hospital getting them checked. And here's a simple 1 minute sit to stand test that they were doing that actually correlated nicely with risk as well. So there are ways that you can have patients at home and analyzing how they're getting on. But ultimately, we're heading towards a time when we'll have average daily counts from patients with their watches and their smartphones. We'll have measures of their sleep disturbance. We'll have their heart rate based on implantable heart rate monitors and so on. And ultimately, that's just more and more data about how patients are doing. And again, you're going to need some degree of artificial intelligence to tell us, well, what does all that mean? And is that telling us that we're making progress or we're not? So just to bear that in the back of our minds for a moment as we think forward. But another interesting way of doing that, and this is again some work from the group in Sheffield, they had an implantable cardiac monitor which give you a measure of heart rate reserve. They also had measures of walk distance. They also had placed in the cardio-MIMS device. This is a little device put into the pulmonary artery that can measure pulmonary artery pressure. And using a combination of the total pulmonary resistance, heart rate reserve, and activity levels, they were able to come up with a risk score for patient outcome and patient survival. But what's interesting about that is we may be able to use this in the future when it comes to picking individualized therapies for patients. Here's an example that they have of a patient they had with sildenafil and ambrisentan, and they were looking at their overall functional class, their emphasis 10 assessment of patient well-being and quality of life, and NT-proBNP. They also were able to measure the total pulmonary resistance and heart rate. And when we look at what the cardiac MIMS was telling us, we could see that in response to a trial drug that they were adding in, they could see this nice drop in TPR and drop again and going back up when it was stopped. But ultimately, patients were shifting from intermediate to low to intermediate high to low in response to therapies. And so it may be possible to do clinical trials in the future on individuals and then using AI to compile that data. And you could go between different drugs in patients and say, well, I'm going to target the imatinib pathway on this occasion, but next week I might target the serotonin pathway, and I'll continue to watch and measure their risk based on implantable monitors, both cardio-MIMS, for example, type devices, or heart rate reactivity and activity monitors. So ultimately, our goal is to get the right drug for the right patient. And we saw this figure from with Professor Malcolm Baer showing us that we're in a very good place in that we have and a number of mechanisms to go after. We have a number of targets, and we have lots of different therapies that are really out there. Some are being repurposed, some are brand new. But we're going to need a lot more drugs if we're going to take this individualized therapy to the next level. On 3 pathways alone, it doesn't entirely make sense. But when you start looking at what's out there, you begin to realize we're going to need a lot more help to make that much more individual. I think all of the trials now increasingly using biomarker studies in those trials to see, is there something characteristic about that individual patient that we might be able to decide that this is a drug that will work better in them. So I'll go back to my original figure, and I'd suggest to you that from the Museum of the Future, that maybe therapy of the future, we might consider that up here on the screen, we'll phenotype patients that maybe we'll give our pulmonary artery on a chip and have a look at how our signals and how they're responding. We'll know better the genotypes of our individual patients, like we do now in lung cancer, for example. We'll have lots of drugs sitting there in those particular devices, not perfume, and ultimately come up with bespoke treatment for each individual patient. It's not there yet, but I think it's coming. Thank you.
Thank you. As usual, an amazing talk. Thank you so much. May, you want to introduce the next speaker, please? So the
Please
question and
welcome
answer will be
our
at the end of the
next
session,
speaker,
please.
Rehab Al-Halbi, who's doing her PhD final year with Dr. Stathard. Please welcome. The floor is yours.
Good morning, everyone. Thank you so much for inviting me today. And as May said, I'm a final year PhD student at Imperial College London. And today I will be talking to you about the role of CALF6 signaling in endothelial dysfunction in pulmonary arterial hypertension. Yeah, but it doesn't work. No, no, I need to go to the next slide. This is okay. Okay. So I believe I don't need to introduce the pathology of pulmonary arterial hypertension, as you're already familiar with it. But the key point is that endothelial dysfunction is the key in initiation of the disease. Krabbe-like factor are a family of zinc finger transcription factor, and recent studies have shown that KLF2 and 4 play a role in endothelial dysfunction, and they are downregulated in the disease, and they are a flow-induced transcription factor that have been implicated in regulation of endothelial dysfunction. All KLF share zinc finger DNA binding domain. So the focus of my project is on KLF6. KLF6 is a novel transcription factor. It has not been studied in the context of pulmonary arterial hypertension. And our novel observations show that KLF6 is downregulated in organ and shape model. Sorry. An organ and shape model of PAH, as well as in mouse model PAH. KLF6 is implicated in the regulation of cell proliferation. Sorry. Is implicated in the regulation of cell proliferation and differentiation. It's also considered an injury response factor. It's acts as a tumor suppressor and regulates angiogenesis. So our working hypothesis is that the KLF6 is downregulated in pulmonary arterial hypertension like KLF2 and 4, but we don't know how it contributes to endothelial dysfunction. Our aim, we have 4 aims. The first aim is to determine the effects of factors involved in PAH pathogenesis, such as shear stress, hypoxia, PNPR2 knockdown, and inflammation on the expression of KLF6 in pulmonary artery endothelial cell. The second aim was to identify KLF6 specific effectors in hitchback and verify their role in endothelial dysfunction, in endothelial function. And the third aim was to validate observations with endothelial colony forming cells and tissue from lysates and histological sections from BAH. And now I'm going to talk about my result. In the first part of the result, we wanted to know if KLF6 expressions is affected by factors involved in BAH pathogenesis, such as shear stress, hypoxia, and inflammation. So we saw that KLF6 shear stress induces KLF6 expressions, as you can see here, and that was confirmed by in silico analysis of publicly available RNA-seq data. And we found that also KLF6 hypoxia has no effect on KLF6 expressions at different time point, as you can see here under hypoxia condition. While inflammations induces KLF6 expressions, and interestingly, we saw that the double hit conditions, which is where we combined TNF alpha plus hypoxia, had a much prominent effect. To summarize the first, we found that shear stress and inflammation induce KLF6 expression, while hypoxia has no effect on KLF6. In the second part, we want to know the effects of changes of KLF6 expression on endothelial function. And so we offer express KLF6 using adenovirus gene transfer, and then we look at the following endothelial responses. In terms of manipulation of KLF6 expression, KLF6 was often expressed and localized to cell nuclei as a transcription factor, as you can see here in this mirror image. And then KLF6 also offer expressions had a protective effect on TNF alpha and hypoxia induced NF-kappa B activation. We also saw that KLF6 enhanced endothelial barrier functions, and it reduces the effect of thrombin and TNF alpha and the double hit condition where we combine TNF alpha plus hypoxia. And that, consistent with this observation, we also observed that KLF6 increased the expressions of junctional protein, peak adhering, and BCAM1. KLF6 also stimulates endothelial angiogenesis, and this was measured by tube formation assay. And you can see here, we saw an increase in the tube formations with KLF6 overexpression compared with the control. And also, we confirmed this by utilizing another assay, which is we used the explant of a human pulmonary artery, and we saw an excessive increase in endothelial sprouting with KLF6. And this was combined by an increase in junctional, markers of angiogenesis, such as TI2 and KDR. And also, interestingly, we saw an increase, a threefold increase in SOX17. And this SOX17 is the endothelial identity marker. And recent study shows that SOX17, endothelial SOX17 mutations and loss of functions contributes to endothelial dysfunction as well as pathogenesis of PAH. Like KLF2 and 4, KLF6 inhibited endothelial cell proliferation. And it also increased endothelial migrations, and this measure under normal conditions. As you can see here, KLF6 stimulated wound healing. And also it's increased endothelial cell migration under stress conditions where we used surfactant medium. To summarize this part, while KLF2 and 4 are anti-inflammatory and anti-proliferative, they are also anti-angiogenic, whereas KLF6 is a pro-angiogenic. And we are carrying RNA-seq analysis to compare the effects of these three transcription factors and also to identify the uniquely differentially expressed genes for KLF6. In the third part, KLF6 expression, we want to know the effect of KLF6 expressions or the changes of KLF6 in ACFCs from PAH patients with disabling PMPR2 mutations, as well in a mouse model, which is oxygen hypoxia and MCT rat models of PAH. So interestingly, in contrast to what we see in animal model in the end stage of the disease, ACFCs shows an increase in KLF6 expression under normoxia and hypoxia condition. We also looked at the changes of KLF6 in animal models. So in rat, in surgeon hypoxia rat, KLF6 is downregulated. It's also downregulated in MCT rat, as you can see here. And interestingly, we saw an increase, a slight increase in early stage of the disease. In terms of result, KLF6 promotes endothelial repair. It also inhibits endothelial proliferation, enhances endothelial barrier functions, and decrease inflammatory activation in HPAC. In terms of future direction, we would like we are planning to look at the effect of KLF6 in endothelial apoptosis linking to PMPR2, and further analyze RNA-seq, and finally validate with the human lung tissues. And at the end, I would like to thank my supervisor, Dr. Beata, and all the members of my group. Thank you so much.
Thank you, Rehab, so much. And please join us here. Come here. So now it's time for questions and answers. And the podium is, please use the mics in the middle if you want to have any answer. Let me ask you, Beata, a question. You know, to develop a drug these days, it probably take a decade to have basic science research, animal model, phase 1, phase 2, phase 3, until you get the drug approved. You think human on chip or organ chip will somehow shorten this in the future? And how far would this be?
So it's a very good question. I think we are not there yet. Like Luke said yesterday about treatment. So in terms of chips, we are working on introducing a more complex system, more closely resembling pulmonary artery. So we are making an alveolus on a chip connected with vessel on a chip, which will be more reflective of the drug effects. And I mean, it's a good question. There are some limitations in this technology. For instance, we need, I think, production of these chips being upscaled. At the moment, different laboratories are producing these chips, but there is variation between, you know, among different laboratories, and the only company that sells these chips, Emulate, sells them at very high prices, so laboratories can't afford it. So there are many obstacles, I think, but it's the right direction.
Thank you. Let's welcome Mark. Good morning, Mark. Thank you for joining us. Faiz, you have a question? Please go ahead.
Yeah, really great talks. So my question for Prof. Sean Gain about the remote assessment of pulmonary hypertension patients. We all know that CardioMEMS been well studied in heart failure patients, and it's widely being used now. Do you think the use of CardioMEMS in pulmonary hypertension patients, especially with a cardiac pulmonary hypertension patient with cardiac phenotypes, do you think it will be useful in the future?
Thank you so much. It's a question really about the cardio-MIMS, and I have to say, I think the example I gave was one example where it might have a role in the future in that it's in a very in an expert center doing new drug studies and looking at individual responses. I think a widespread use in the community, I think I would have reservations about. And I think the data that we get from it, one, it's too much for where we're at the moment in any of our clinical practices. We saw from my data too that we're not getting nowhere near to 100% of people on double upfront combination therapy, and all of a sudden we're going to, put in devices in everybody before we've taken the first steps. But I also wonder, in patients beyond those with left heart, patients who have pure group 1, looking at the data that you get from cardio-MIMS, it's with TPR and pressure, it's questionable what value that has in comparison to, for example, what we already get from a walk test, BMP, and functional class, and an examination of the patient, and day-to-day changes and things may not have a bigger impact longer term of where patients go. So I think in the future, I see it, for now at least, I see it in expert centers, and I would be cautious about going anywhere beyond that.
Thank you.
Luke, please.
Thank you very much. I've got a question for Beata, but just before that, I'd like to congratulate Mark on his position that we heard about. And it's sorry you can't be here to celebrate, but many congratulations, Mark. So Beata, I'm interested in these ECFCs. I'm also interested in the fact that you said that this is a very easy model to produce. And I know back in the days when I was doing research, ECFCs were quite painful. But the ECFCs and their phenotype, I'm just wondering if there is, when you've been looking at RNA-seq, that whether or not they look similar to HPECs, but when you put them into your organ on a chip and you start exposing them to laminar flow, do they change?
The entry criteria are often different between it, but it is possible to do that, and some people have tried and have it's ongoing. But I think that's probably where we'll go in the future more as we get better at AI in general.
Thank you. My second question is regarding the KLF6, because I got excited when you mentioned the KLF6 and that it has the zinc finger in it. And I know that the zinc is an essential element, and zinc is important for the progenitor function of the stem cells and many of the cells. So what's the link between what you found and actually the zinc itself in the progenitor function of the endothelial cells and in preventing and repairing the damage in the cells? Thank you.
I think you're maybe referring to the ZIP12 study and zinc.
Yeah.
So a lot of transcription factors are dependent on zinc. Yes. So I think it would be too simplistic to regulate the levels of zinc, hoping that it will specifically target KLF6. So I think we need to go deeper into the regulation of KLF6 activity to understand, at which point we can intervene and how it works. I think it does depend on zinc alongside with many other transcription factors.
Thank you.
I think Mark is still with us. Mark, are you still there? Is Professor Umber still with us? Mark? I think he's muted somehow. Anyway, may you have a question? And I think we have to have 1 or 2 questions so we can break for 15 minutes or so. Okay, go ahead.
I have a question for Beata. Yeah, regarding your system, the organ on chip, it's a very small one. So I'm wondering, the number of cells that you started with will be low. So with the flow, would you see some of the cells will be washed out during the flow system? And is there any plan to make it bigger, or is there any reason for make it small? So I'm just wondering about the size of the chip. Thank you.
Okay, I think we want it smaller, as small as possible, to minimize the usage of cells. So we are quite lucky, sort of, that we are not losing many cells. I think when you apply flow, you start from very low levels and allow cells to adapt. So we are not losing them. So we have around 10,000 cells in that chip, and we can do RNA-seq on those. It's quite all right, actually working.
So can we ask Mark? Mark, are you? Yeah, I think now he. Now, what do you think the reason behind having different outcomes with different tyrosine kinase inhibitors? And what do you think the inhaled imatinib will have a different impact and avoiding the side effects of the Empress trial?
Discussed that it has some difficulties with development. Right now, some of the invalid formulations have great interest. Of course, it's very early in the development. Phase 2 completed, and some phase 2, 3 trials. The right dose to have a strong effect. So it's developed pathway.
So I have a question for you as well. Hi, Mark. So tyrosine kinase inhibitors seem to have some off-target effects. For instance, they seem to have vasodilatory effects. Can you comment on this? What's mechanistically, how can you explain this?
Yeah, that's a good point. Off-target and that's we mentioned and it's quite important in the tight relationship between the two cells. That's maybe less reduced inhibition. So it allows certain but also doing externalization. So I think the most difficult side effects are with less on top of mediated kinase. With imagining you are more focused of so hopefully if there is a target effect relaxation of the vessel, it can be if it was more than that, I think you have to be careful. But clearly I think all these drugs in development have to be evaluated data on the most focused imagining orally, not very safe, age, these are the good we use in people with treatment, associated treatment of ambulance. They are more, let's say, more focused treatments like inhalation, and in that case, it's
Thank you.
Thank you. Stephen, last question, please.
Hi, Mark. Welcome here from Saudi Arabia. Good to see you. One question also related to the oncology field. We have learned in the oncology field that sometimes with tyrosine kinases that you have over time when you treat patients, you have counter-regulation of tyrosine kinases themselves, but also their downstream targets. It's probably a different scenario because there, in the oncology field, you have certain mutations that are associated with cancers. But here, this could be an important information that we at least have to be cautious about, is counter-regulation over time. Do you have any idea of that in the field of pH?
Very rare. It doesn't get but if one of the formulations is approved therapy, all the patients will receive background surveillance and the loss of efficacy. That means that if you know thousand for example, out the airways, these people with severe asthma. So efficacy and safety and loss. Right now, I don't have data to share with you on that.
Thank you so much, Mark, and thanks for the speakers and my co-chair. And I know we're about only 15 minutes late, but the good news, we have the second break is about 2.5 hours break, so you can have a lunch and prayer and everything. Now we'll break for 10 minutes early, and the exhibition hall is that side. We can have also refreshments and coffee, and we'll be back here by 10, please. Thank you so much.
No, hold it. Hold it. Will you please stop it? Wait, we did not start yet. So you can rewind. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good morning, everyone. It's our pleasure to start our second session for the morning. First of all, thanks for SAPH for hosting this interesting year conference in Al Khobar, and welcome all to our session. Now we are talking about probably one of the most important clinically relevant sessions. My name is Hussam Sakkijha. I'm one of the pulmonary hypertension people in the Kingdom of Saudi Arabia, and with me is Dr. Nasser Bousaidi from Oman. And we would like to welcome you into our session about the new updated guidelines from the definition to the risk stratification to the impact on the treatment algorithm.
Thank you, Hussam. It's my pleasure to introduce first speaker, well known for everyone, Prof. Nazarino Gale. He is a professor of cardiology, and he is director of postgraduate school of cardiology disease in Alma Master Studium. He's going to talk about the best and impact of new guide of pH hemodynamic and differential classification. Thank you.
Good morning. The topic of this presentation the basis. Good evening. So I will start presenting my point of view about switching or adding treatment in the low intermediate risk PAH patients, and I will defend the adding treatments, the combination, and not shifting. These are the randomized control studies were Good evening. So I will start presenting my point of view about switching or adding treatment in the low intermediate risk PAH patients, and I will defend the adding treatments, the combination, and not shifting. These are the randomized control studies were about 46, which were performed in the past 20 years or so, and leading to the approval of 12 compounds were effective in patients with pulmonary arterial hypertension, interacting with the three pathways, the endothelin pathway, the nitric oxide pathway, and the prostacyclin, risk-oriented treatment strategy. And these are the new guidelines of 2022 of the European Society of Cardiology and the European Respiratory Society. And this is the treatment algorithm, the evidence-based pulmonary arterial hypertension treatment algorithm for patients with idiopathic, heritable, drug-associated, and connective tissue disease-associated pulmonary. Good morning. The topic. So since then, not evaluation at that time included the analysis of right heart catheterization, in this case 21,727 from VA registry, including patients with left heart disease, we found more than 50 clinics, more than 5 groups, 5 logical definition of pulmonary hypertension, of pathophysiological definition of pulmonary hypertension. At the Sixth World Symposium, then the proposal was to reduce the threshold for the definition of pulmonary hypertension to more than 20 millimeters of mercury, and precapillary included wedge pressure less than 15, and PVR more than 3 Wood units. For isolated postcapillary pulmonary hypertension, then the values of mean PAP and wedge pressure were similar, but the PVR was less than 3 Wood unit. And the definition on combined pre- and post-capillary pulmonary hypertension was the mean PAP more than 20, wedge pressure more than 15, and PVR more or equal to 3 Wood units. And let's arrive to the new guidelines, the recent 2022 guidelines. In this case, the definition was modified in particular for what concern pulmonary vascular resistance. So the definition of pulmonary arterial pressure, mean pulmonary arterial pressure was more than 20, and wedge pressure less than equal to 15 for precapillary. And the PVR at this point was reduced into the definition at more than 2 Wood unit. For isolated postcapillary pH, wedge and mean PAP was similar, and the pulmonary vascular resistance were less or equal to 2 Wood units. For combined post and precapillary pulmonary hypertension, the difference was an increase of PVR more than 2 Wood units. In this case, there was also the definition of exercise pulmonary hypertension based on the slope of the relationship of the increase of mean PAP slash cardiac output. And this slope should be more than 3 millimeters of mercury per liter per minute. And this is the clinical classification of the recent guidelines, very similar to the previous structure. The only minor difference was a better distinction of patients according to vascular activity, the introduction of hyperventilation syndromes, more clear distinction of group 5 with unclear or multifactorial mechanisms, so systemic disorders, metabolic, chronic renal failure, pulmonary tumor, thrombotic microangiopathy, and fibrosing mediastinitis. The group of patients with complex congenital heart disease were not included. So we analyze our database of close than 4,000 right heart catheterization to analyze a possible impact of the different classification. For the traditional one in our registry, we identified, according to the traditional definition, 2,486 patients with pulmonary hypertension, which is 64%. For the 6th World Symposium definition, I remind you that already we had a mean PAP more than 20 as definition, with PVR more than 3. The increase of patients with the definition of pulmonary hypertension was minimal. Only 1.8% more were defined with pulmonary hypertension. And this is the definition of the new guidelines with the threshold for PVR more than 2. In this case, the 71% of the right heart cath showed the pulmonary hypertension, and the increase was 7.3%. So overall, we have increased the patient with pulmonary hypertension, but with not a very big percentage. Which is the impact then of this novel hemodynamic definition on treatment of precapillary pulmonary hypertension? Today is not prime time to treat PAH with pre-PAH drugs, PAH patients with mean PAP between 21 and 24 and PVR more than 2, because these patients have not been included in randomized control studies. In the only trial, which is the early study, having included the symptomatic functional class 2 PAH patients at inclusion, the mean PAP was 52 millimeters of mercury and PVR 10 Wood units, so very elevated, also for mildly symptomatic patients. Actually, in this disease, you may have almost 50% of the pulmonary circulation obstructed and only a mild increase of mean pulmonary arterial pressure and pulmonary vascular resistance. A single cohort of 86 patients with systemic sclerosis with mean PAP at baseline between 21 and 24 were followed up. Of these, 38 underwent a second right heart catheterization during the follow-up, and 16, so 42%, developed overt pulmonary hypertension based on the old classification. And these are the data at baseline and at follow-up of the patients who received 2 right heart cath. There is a mild increase. Patients with so-called borderline mean pulmonary arterial pressure at baseline were more likely to develop overt pulmonary arterial hypertension than patients with mean PAP less than or equal to 20 millimeters of mercury. 5 patients died during the follow-up. These are additional data of 2018. In 2018, an Austrian group reported a cohort of 547 patients with unexplained dyspnea and or at risk of PH who underwent right heart catheterization. 290 had manifest PH, defined as mean PAP more or equal to 25, 64 borderline with mean PAP between 21 and 24, 137 normal with a mean PAP less than or equal to 15 millimeters of mercury. The median follow-up was 46 months, and in multivariate analysis, both manifest and borderline PH had a significant worse survival than normal group, with an hazard ratio of 5.05 and 2.37 respectively. Both were statistically significant. So at baseline, the median PVR in the borderline group was 2.7 Wood units. In conclusion, patients with PAH due to limited scleroderma with a mean PAP ranging from 21 to 24 have a 40% chance to develop to a mean PAP more or equal to 25 millimeters of mercury. Pulmonary arterial hypertension patients with a mean PAP ranging from 21 to 24 are usually mildly symptomatic and identified mainly by screening programs. They represent less than 10% of patients receiving right heart catheterization. The increase of mortality in patients with group 2 PH due to left heart disease and group 3 PH due to lung disease starts with a mean PAP more than 20 millimeters of mercury. However, mortality may be simply linked to the severity of the underlying disease and not to pulmonary hypertension per se. Finally, patients with PAH with mean PAP ranging from 21 to 24 and PVR more than 2 Wood units, about 7.3% of right heart catheterization series, should not be treated with PAH drugs because the approval and demonstration efficacy is achieved only in subject with mean PAP more or equal to 25 millimeters of mercury and PVR more or equal to 3. Thank you.
Thanks for Nazarino. I think he will join us at the end of the session. It's my pleasure now to introduce and invite Dr. Stefan Rosenkranz to the podium, where he will take us through the journey of the risk stratification, specifically talking about the 4-strata model in the follow-up in PH patients. Stefan?
Thank you very much. And first of all, thank you very much for the invitation to SAPH again. It's an honor and pleasure to be here with you. And following the very nice presentation of Nazareno, we will now, within the next few minutes, talk about risk assessment in PAH. And the title you gave me was Wisdom Behind the 4-strata, but you put a question mark behind it. So let's see how we can tackle that. So first of all, Nazareno has already pointed out it's been 7 years between the 2015 version of the guidelines and this updated version that we have seen recently. And if we look back at the 2015 version, you're all very much aware of this table that hadn't really been validated at the time when it was put into the guidelines in 2015. I also want to mention that, of course, we have other tools for risk assessment, Reveal and Reveal 2.0 in particular. I want to focus here on the ESC-ERS approach as we will think about the 4-strata. And if we look back, it's quite interesting. This table was put in the guidelines, but it was used in different ways by different centers and by different registries. So I call it the French methodology here, was to look at the number of low-risk criteria. This approach turned out to identify patients at very low mortality risk. Then other registries that have validated this risk assessment strategy have used a different methodology, and SPAR and Compara in particular. They did the multimodal assessment and then did the calculations and came up with low, intermediate, and high risk. And you have all seen these previous validation studies, the low-risk criteria approach that was published by the French registry, showing that if you consider only 3 non-invasive measures, namely functional class, 6-minute walking distance, and BNP or NT-proBNP, that enables you to identify patients that are at very low mortality risk if all of these 3 are in the green zone, so to speak. And when this paper was developed, it's quite interesting that the inclusion of BNP or NT-proBNP beat the invasive hemodynamics at the time because they were not statistically significantly associated with mortality anymore when BNP or NT-proBNP was considered. Then there was validation from the Swedish registry SPAR, showing that the risk stratification works both at baseline and during follow-up. And perhaps the most important finding of this study was that if you are able to improve the risk status once you initiate PAH therapy, you also improve survival. But then there was another study showing that age and comorbidities seem to be important for the treatment response, at least if you consider improvement of these patients to the low-risk group. And what was shown here is the older the patients were, the less likely it was for them to reach the green low-risk zone. On the other hand, we looked back in our Compara registry, and at the time these patients were called typical or atypical IPAH. The atypical were the patients with multiple comorbidities. And when we looked here, it seems like, well, these patients do actually respond to therapy if you look at the change in 6-minute walking distance, but the baseline value in the patients with comorbidities were much lower in this context. We also saw similar improvements in functional class and changes in BNP or NT-proBNP. But if you put this into perspective with the 3-strata risk assessment, and you look at the baseline values that are shown here, then you see that the baseline values in the patients with comorbidities were much lower. So even if there's the same level of improvement, for these patients, it's much more difficult and challenging to reach the green zone. So we have to keep that in mind, and we'll come back to that later on. Now we have seen the updated guidelines, and we will hear Marius Höper speaking about the treatment algorithm in detail in the next talk. I just want to highlight here related to risk, we have proposed to use the 3 strata for the initial treatment decision and then use the new 4 strata for further treatment escalation and guidance about that. So this is the table from the new guidelines that is very similar to the one that we have seen in the previous version, but there have been some important updates. Number 1 is the numbers for the estimated 1-year mortality have been updated because the validation studies have shown that patients at high risk face a mortality, 1-year mortality risk of more than 20 and not more than 10%. So it's even more severe, and the likelihood to die is higher as was previously thought. Then there were a couple of changes. The TAPSE over SPAP ratio as a surrogate of RV to PA coupling was shown to be prognostic in PAH and was included. Furthermore, MRI measures of RV function that are known to be prognostic are also now included. And finally, as stroke volume index was shown to be prognostic and actually the best prognostic hemodynamic measure during repeat right heart catheterization, we also included this amongst the invasive hemodynamic measures. The reasons for that was multiple studies. I'll just show you briefly a couple of examples here. A meta-analysis of CMR studies highlighting the prognostic relevance of measures derived from cardiac MRI. Then this French study that has highlighted the importance of stroke volume index as a prognostic marker in patients with PAH who are on targeted therapy. And finally, the TAPSE over SPAP ratio had been validated as a surrogate marker of RV to PA coupling in patients with pulmonary arterial hypertension in direct comparison to conductance catheterization, showing the correlation with specific measures of conductance cath and also showing the prognostic impact of integrating RV function and RV afterload, if you wish. And then after the guidelines have been published, this very nice paper was recently published from the French registry looking at the TAPSE over SPAP ratio in the context of a 4-strata risk assessment. And what was shown here is that if you consider functional class BNP or NT-proBNP and you replace 6-minute walking distance by TAPSE over SPAP with these value that's very close to the one that's suggested in the guidelines, it seems to work very well. So here in this study it was shown that the TAPSE over PAPSE correlates well with clinical measures and also with invasive hemodynamics and is of prognostic value. So this study pretty much confirmed this change in the guidelines, and the conclusion here is that the 3 following dichotomized low-risk criteria, TAPSE over SPAP, using a cutoff of 0.33, and then the other 2 that you're very well aware of, allow to identify low-risk patients at follow-up. So another caveat with the previous version that was published in 2015 was that it turned out that both at baseline, but particularly also after initiation of PAH therapy, the majority of the patients remained in the yellow zone, in the intermediate group, which turned out to be too large. So we needed more granularity in this context. For that reason, and we started here in Compara, called it Compara 2.0, we tried to come up with a new approach that would enable us to give more granularity in terms of risk assessment. So as compared to the established 3-strata model, we now subdivided the intermediate group into intermediate low and intermediate high. You see here how this was done. You see the patients that were included from the Compare registry at the time. And if you just look at the capturing of treatment responses from baseline to first follow-up, this image depicts that the four-strata approach enables us to capture more treatment effects as opposed to the previous three-strata approach. And the question was, is this relevant for outcome? The answer to that is yes. You see the prognostic value at baseline on the left and then during follow-up on the right. And particularly during follow-up, we saw a nice separation between intermediate low and intermediate high risk in this context. And then to be able to include such information in the guidelines, data from one registry would not be enough. So we contacted our friends in Paris and in France, and they did a fascinating job in doing an external cross-validation study using the same approach. This was published then as back-to-back papers in the European Respiratory Journal. And they found pretty much the same thing, although the analysis here has been done a bit differently. You can also see here that, yes, that approach also here enabled to capture more changes upon treatment initiation, and also here, very nice separation between intermediate low and intermediate high risk. So then we had data from two large registries showing that this approach, number one, works. Number two, is predictive of outcome, particularly during early follow-up. So a limitation here is that for this analysis, we had to go with what was available in the registries. So this can be used and should be used as it was proposed in the guidelines to estimate the mortality risk, but the guidelines also point out that for treatment decisions in individual patients, you may consider additional measures as well. In another comparator analysis, we have looked at the impact of the four-strata versus three-strata concept in estimating the survival probability, and saw here that the four-strata does even work better. So now we're back to this image. This approach, the French approach, is still feasible, of course. Now we are able to subdivide the intermediate group into intermediate high and intermediate low, but we should also consider this as work in progress. We have now seen that, yes, TAPSI over PAPSI ratio may help us in addition to these measures that we have used as of now. So we may be able to adjust this further in the future. This is the table in the guidelines that depicts the four-strata risk stratification. And it's important to highlight again that thresholds instead of absolute or relative changes help us better to define the risk status of the patient. One could ask whether changes in risk status also predict outcome. Since they do this, are they potential study endpoints as well? And the specific recommendation in the guidelines for the use of the four-strata is shown here, and I want to elaborate on the last part of the sentence here, with additional variables taken into account as necessary. So we don't need to stick with those three non-invasive measures necessarily, but overall they give us a good estimate of the survival probability. So it's a bit complicated because we had to propose to use the three-strata, a very comprehensive multimodal assessment at the time of diagnosis, and to use this for the initial treatment decision, and then to switch to the four-strata for the escalation, and we'll hear about what that means later on. In the last few slides, I want to focus on the patients with comorbidities. So this was a change in the guidelines that we consider the different phenotypes that has caused a lot of discussions, also some confusion. So I just want to highlight here that risk assessment is not proposed here because it wasn't really, it hasn't really been properly investigated in this context. So these patients, by our definitions, do have PAH. They should be treated, but we don't have the same evidence. So what about risk in these patients? And there also, after the guidelines, before the next guidelines, we should say, so after the guidelines, an additional manuscript from Compara has been published where we used now the Compara 2.0, so the force strata, specifically in patients with comorbidities, and we asked the question whether we should better capture the treatment response in patients with comorbidities, because here they have a low likelihood to reach the green zone, and they may improve from dark yellow to light yellow if you use the 3 strata, but you don't capture this. So this is one of the figures from this manuscript. And if you just look here in the 6-minute walk distance, we come back to what I have shown you earlier on. Patients with 1 or 2 or 3 comorbidities at the time of baseline have far worse values. So for them, it's almost impossible to get into the green zone. It's different for these patients without comorbidities, higher baseline values. There is a likelihood to reach the green zone. But what we see here, yes, we do see improvement in basically all of these measures, but they don't reach the green zone. What they do reach is the lighter yellow zone. So this seems to be a realistic and feasible treatment goal for these patients. And the question is that relevant for the patients with comorbidities? Also here, all patients without 1 to 2 or 3 to 4 comorbidities, we see that we're able to capture treatment responses using the 3 strata, particularly in these patients. With the previous version, they would all have remained in the intermediate yellow zone. So is it important for survival? And the answer is yes. So these are the patients without comorbidities. These are the patients with 1 or 2 or 3 or 4 comorbidities. And as you can see here, patients who reach an intermediate low risk at early follow-up have a better survival. So for these patients, that could be important information. So what are the take-home messages here? I want to start with the 3 strata that had been validated in large registries, the original version from the 2015 guidelines. Based on new evidence, additional measures have been added to this 3 strata table. It's recommended for guidance of the initial treatment strategy, and a caveat is that the intermediate risk group is too large at baseline and also during follow-up. The 4 strata is a refined risk assessment tool that has been developed from 2 large registries, and it provides more granularity in predicting long-term survival, and is recommended to guide treatment decisions during follow-up. And again, we should consider this work in progress. I again want to highlight that you may need to consider additional variables when you make your treatment decisions in the individual patients. Also, potentially in the future, additional measures may be integrated from imaging, TAPSI, PAPSI, but we need proper evidence for it. And when we collect this evidence, we have to show that whatever we want to add is superior to what we have now. And potentially in the future, we should work on an integrated approach and for harmonized approach to risk assessment using the different methodologies that are applied for risk assessment in Europe, but also REVEAL in the US and further tools that may help us in the individual patient. And how does risk assessment compare with other outcomes in clinical trials? If we look at time to clinical worsening, I guess by definition this highlights the limitations in PAH therapy that we're facing. More recently, we have looked at multi-component improvement, or MCI, considering clinically meaningful changes, which is associated with better long-term survival, and potentially multi-component risk assessment utilizing thresholds to define risk is also predictive of outcome and may therefore also serve as endpoint in clinical trials. And with that, I thank you very much for your attention.
Thank you, Stefan, so much for this detailed presentation. Please join us in the podium. It's my pleasure now to introduce our longtime friend of the SAPH, professor and the famous Marius Huper from Hanover, Germany. He's a respirologist and intensivist, and he will take us through the changes in the treatment algorithm based on the new guidelines. And he will be joining us through the, the recorded Zoom meeting. He's live. Okay, go. Marius.
Hello and good morning. Ist deaktiviert. Also wir get no feedback whatsoever from the organizers, from the technical team.
Can he share his slides?
No, it's still activated and deactivated on your side. So screen tells me
Will you please
has deactivated this option.
Can you give him the functionality? Yes.
That would be greatly appreciated. Here we go.
Okay.
So I very much hope that you're getting now the signal that we can start. I start with my disclosures. I think it's usually the most interesting part of the talk. Hope that's not the case. So the guidelines, topic of the day, of course, and I will focus on the treatment.
Marius, sorry, we don't see your slides yet. Could you double check?
I have shared them. It's probably on something that needs to be changed in your side because I'm sharing now and it confirms it's shared.
Can you stop and reshare, please?
I do. So I'm sharing and I can see that it is being shared. I'm waiting for some feedback on your side to decide how to proceed.
Now we can see the first slide. Proceed, Marius, please.
Unbelievable. So let's try that. So here are the disclosures and then just do the But the class of recommendation is one level of evidence according to ESC and also toward the EU, which is one randomized controlled study. We have made some specific recommendations here for drugs for which evidence has been generated. And of course, there is from the ENVISION trial and the recommendations for ambrisentan and tadalafil's initial combination therapy is the 1B. But also, and there's some controversy about this, we have raised the combination of macitentan and tadalafil to the same levels, also 1B. For other ERAs, the inhibitors is it too early because we have less evidence. We would certainly suggest this only when ambrisentan and tadalafil are not available, not reimbursed, or not tolerated. And then we also made a class 3 recommendation for initial triple combination therapy with macitentan and tadalafil with SAPH, which is not recommended. This is what class 3 means. It's not recommended based on the data. Try this out. We will show you this in safety. Of course, the strong recommendation to use the upfront initial combination therapy with an ERA and PDE5 inhibitor comes from the ambitious study, which also landmark study in the field, and third order as well in this study showed very nicely, very convincingly that patients who, as initial therapy after PH had been diagnosed, received combination treatment with ambrisentan, tadalafil, and better long-term outcomes, but also better clinical improvements in terms of 6-minute walk distance changes and changes in the NT-proBNP with this combination therapy and with any of the two monotherapy approaches, so tadalafil or ambrisentan alone. And then, more recently, we have the Trumpet study, and the Trumpet wanted to take this a step further. They took this ERA-PDE5 inhibitor combination now as the baseline. So this was all patients, newly diagnosed patients received, and that was macitentan and tadalafil, and the patients were then randomized to receive either SAPH already available prostacyclin agonist or placebo. And the primary endpoint of this study was change in the PDR from baseline to week 26. And the study was negative because there was no change, or no difference in the change in PDR. And there was also no difference in the change in 6-minute walk distance and NT-proBNP. But what the study showed and confirmed is once again the tremendous improvements that we see with the initial ERA-PDE5 inhibitor combination therapy with the 50% reduction in the PDR, more than 50 meters improvement in 6-minute walk distance, and a 75% reduction in NT-proBNP. This is unheard of.
We never see this with any monotherapy, not even with intravenous prostacyclin. Again, there was no additional effect of selexipag at week 26. There was during the long-term duration of the study, there was a hint of a perhaps declined or a reduced risk of clinical worsening over the long period, but that was not statistically significant. It needs to be considered exploratory because the primary endpoint failed. And it's certainly not sufficient evidence to go ahead and say that now these patients should all be treated with upfront triple, which some people are saying, but this is very clear that's not the case. And this, I go back one slide here, this is the reason why this is really a red and no-go zone here for the time being. For patients presenting at the time of diagnosis at a high risk of death, the recommendation is basically the same as in the 2015 guidelines. It's upfront combination therapy, also with an ERA and a PDE5 inhibitor, plus an intravenous or subcutaneous prostacyclin analog, so epoprostenol or treprostinil. The evidence for this is, even 7 years later, still is at a level of C, which is we don't have any evidence from randomized placebo-controlled trials. And I think I don't want to go into any details here because I'm sure that Olivier Sidbon has discussed this in depth with you yesterday. at the end of the day, I still believe that that is something that makes a lot of sense. This is why it receives a strong recommendation here, to a recommendation, despite the lack of evidence. But we have to be careful not to overinterpret the data that have been generated recently, because retrospective data always have many pitfalls. And at the end of the day, we need prospective data to be sure that this is the best possible approach for patients like that. I think it's very straightforward now to start treatment of patients newly diagnosed with PAH. The treatment decisions during the course of the disease, I think, are much more complicated, and still the evidence that we have here, it is much less strong than for the initial therapy. Stefan has already pointed out that the guidelines recommend that we use the 4-stratum model to define risk as follow-up, for the reasons that have already been explained, and then base treatment recommendations or treatment strategies based on this risk assessment. For patients who are on the initial therapy at low risk, it is, I think, safe and clear, at least for the time being, to continue initial therapy. On the other hand, we have patients at high risk, and here we included patients at intermediate high risk because they also have a very high mortality risk. And for these patients, we recommend as first choice the addition of an intravenous or subcutaneous prostacyclin analogs, plus the evaluation for lung transplant where feasible. And then there is the intermediate low risk patient population. And remember, once more, we're talking about patients with the classical PAH phenotype. And while these patients do reasonably well, they probably do need more in order to improve quality of life, but also probably in order to improve their long-term outcome. What we don't have yet is any data showing us that with the treatment approach that we have, we do improve the long-term outcomes, at least when we define outcome as death. Of course, we can improve progression-free survival or event-free survival, but we don't have any evidence that we can improve the mortality of these patients by the treatment approaches that are recommended here. And what you see is that for those patients, the recommendation is either the addition of a prostacyclin receptor agonist, which of course for the time being would be Selexipag, and this is the class 2A recommendation. Or the alternative is to switch from a PDE5 inhibitor to an SGC stimulator, which is riociguat, which is a class B recommendation. So there's a slight difference here. The difference is based on the evidence that we have, because for Selexipag, we have the evidence from the Griffin study, which was the largest study ever performed in our field with more than 1,150 patients. And this study had a fairly large cohort of almost 400 patients who started that study being on the ERA PDE5 inhibitor combination background therapy. And even in those patients, the addition of Selexipag was associated with better long-term outcome. Outcome meaning event-free or progression-free survival. There was no difference in survival here. This is important to keep in mind. And also, the patients had no improvement in symptoms and exercise capacity or in quality of life. Still, it's very strong evidence. And then on the other hand, the recommendation to consider switching from riociguat to riociguat from a PDE5 inhibitor was based on the REPLACE study. And this was a study that addressed this question in a randomized controlled, but not blinded, but open label fashion. And that study showed that patients who switched from the PDE5 inhibitor therapy to riociguat had a higher chance to have clinical improvement, which was a composite endpoint of improving functional class 6-minute walk distance and NT-proBNP, and also a much lower risk of clinical worsening, including death. Here the risk ratio was 10 to 1. The reason why the recommendation is just a 2B recommendation compared to the 2A recommendation for adding Selexipag is the fact that this study, of course, was much smaller. It was a 6-month study, so not a true long-term study. And most importantly, because it was an open-label design, and the study has been rightfully criticized for that. But nevertheless, the bottom line is that I think there's clear evidence from this and from other studies, including a recently published meta-analysis, that some patients do benefit from this approach. But I see on the program that there will be a pro-con session on this again, so I don't want to say anything more about that. What I want to do instead is go for a couple of minutes to this side. We discuss extensively what I've been discussing just now, how we treat patients with the classical PAH phenotype. The reality, at least the reality what we see here in Europe, in the United States, but also probably in many of your countries, is that most of the patients we do see now diagnosed with PAH are older patients who have cardiac or pulmonary or cardiopulmonary comorbidities, and there are many important differences that need to be considered. And still, if many things are yet unknown, I think it's very important that these guidelines highlight these differences, because we cannot take this aggressive combination therapy approach as it is and transfer it to these patients, because in these patients we would probably do a lot of harm if we took that path. So when we talk about patients with PAH and comorbidities, I think there's one problem in the guidelines, as with all guidelines. If you just look at the tables and the figures, you probably get a misunderstanding. And I think this is happening in many of our colleagues. And we understand that most of us don't read these long guidelines in depth, but just look at the key facts. So I think this is something we have to work on, we need to improve. So when we talk about comorbidities, at the end of the day, we talk about disease phenotypes or PAH phenotypes. And we do have, and we all know these patients, the classical PAH phenotype. So the typical, relatively young, mostly female patient who has no major comorbidities. However, you may also have like a 42-year-old hypertensive, obese patient with type 2 diabetes and a PVR of let's say 12 Wood units, so about 1,000 dynes. And on echo, you see a small left ventricle, a small left atrium. This patient may also have a classical PAH phenotype, despite having comorbidities. So it's something that we need to grasp as physicians. We have to come up with better definitions in order to make sure that people get the right understanding. But then, however, when you have, for instance, an elderly lady with a long-term history of hypertension, and you perform an echo, you see the thickened left ventricle, you see a dilated left atrium, maybe she's in permanent atrial fibrillation already, but she has signs of pulmonary hypertension, and you perform a CAS, you see it's even precapillary pulmonary hypertension despite of that, with a PVR of 4, 5, 6 Wood units. This is what we mean with the left heart phenotype. That's different from the other patient I just outlined. And then with the lung phenotype, I think this is something that becomes very clear now, because when you look at order guidelines, when you look at the recommendations from the last World Symposium, you see the description of these patients who present with precapillary pulmonary hypertension, lung function is normal or near normal, CT findings are normal and near normal, but they have a low diffusion capacity. They're mostly elderly smokers and usually heavy smokers, and they have severe precapillary pulmonary hypertension. And they have been defined according to the current or previous definitions as idiopathic PAH, because we found that the severity of lung disease does not explain severe pulmonary hypertension. This is why we said this is PAH. And this is what was wrong. I think that we made this very clear in a paper we recently published together with our colleagues from Sheffield and the Lancet Respiratory Medicine. These patients do have group B pulmonary hypertension. We have to be very clear about this, and we have to treat them accordingly, and we need further study. So I think the picture is becoming a bit clearer, but at the end of the day, still we have these patients where it's sometimes very difficult to make a clear diagnostic classification. So for these patients, the recommendation is quite clear. It's monotherapy. That's the only recommendation we can make. And even this is not fully evidence-based, because most of these patients have not been represented well in the clinical trials. And when I say monotherapy, the guidelines say PDE5 inhibitor or ERA. I think it should be mostly a PDE5 inhibitor for these patients. And then everything is individualized. So you have to look at the patients. You can do a trial and error approach, or you can say, for instance, this patient has a DLCO of 20% and a PO2 of 40. This patient is definitely not a candidate for an ERA or a prostacyclin. But this is, again, there's no guidance for this. This is where we need physicians for, and especially experienced physicians. So, summary, take-home message, very easy, straightforward. We have as recommendations for patients with PAH, idiopathic or connective tissue disease associated without relevant cardiopulmonary comorbidities, so the classical phenotypes, it's initial combination therapy, double or triple per risk stratification based on the 3-strata model, and further treatment decisions also per risk stratification here with the use of the 4-strata model. And for those patients who present with the cardiopulmonary or cardiac or pulmonary phenotype, it is initial monotherapy, mostly with the PDE5 inhibitor, followed by individual treatment decisions during follow-up. With that, I thank you very much, and I'm happy to discuss further. Thank you.
Thank you very much. Thank you very much, Mario. Stay with us for questions. Now the session is open for questions. May I ask start with the question, Stephen, including SAPH aspiration in the stratification. It does correlate with the severity of the disease, i.e., if it is 0.4, is less than severe than when you have 0.8, for example. Is there any stratification for the level of the ratio?
Now it's on. That's a very good and important question. So I guess what we have to do is we have to, your specific question is, does it correlate with the severity of the disease? I guess that depends on how you define severity of the disease. Are we talking about severity of pulmonary vascular disease, or are we talking about severity of right ventricular dysfunction? So I guess what we do here from a pathophysiological point of view, we integrate RV function and RV afterload. Or in other words, how good can the right ventricle cope with an increased afterload? And we have learned that this is of utmost importance for outcome. At the same time, we define pulmonary hypertension by an increase in pressure and precapillary by an increase in resistance. At the same time, we have learned that pressure by itself is not a good prognostic marker. And the reason for that most likely is that the pressure declines when the right ventricle fails. So we have a pseudo improvement. So pressure alone, not good. Right ventricular function, obviously important. We have learned this in multiple studies. So to me, it makes sense to integrate this. And we have validation. I have shown this from a direct comparison of these measures with conductance catheterization. And now we also have very nice data from the French registry showing the feasibility to use this for risk stratification. Now, whether we should replace 6-minute walk by this, I don't know. One issue in risk stratification to me is keep things as simple as possible, but on the other hand, be as precise as possible when you make your treatment decisions. And we would all agree that during follow-up in our patients, if we only consider those 3 non-invasive, we would like to see what the right heart looks like and how the right heart functions. So to get some additional information is probably a good idea, but it's work in progress. And I also want to highlight that we have specific cutoffs defining high risk, then the distinction between intermediate and low. It's not been utilized yet for intermediate low versus intermediate high. That's probably some homework that we should do. But it's also been shown to be important in other contexts, for instance, in tricuspid regurgitation and TR interventions. There is a cutoff of 0.406 that is beyond the low risk cutoff that we use in PAH, but patients who are below 0.406 have a poor outcome after tricuspid valve intervention. So it's also important in different contexts.
Thank you. Prof. Ghale, welcome to the show. Abdullah, go ahead, please.
Thank you, Chair, and thank welcome Naz and Marius again to SAP, and I enjoyed your talk. Question to Naz: you said in your fourth conclusion, last message, take-home message. Last one, you said patients who are having a mean of between 20 and 24 should not be treated. Did I get this right, or just because there are no studies on these patients? Because most of the studies that have been done in field of PAH were done for patients with mean more than 25 millimeter mercury. So did I get it right, or this is what you meant truly by having not to treat this patient with a borderline pulmonary hypertension, so-called borderline?
Yes, so first of all, I think that this group of patients is very small. Maybe it's larger, but it's difficult to be diagnosed early. Second, we do not have data. And anytime you prescribe a medication, you have to check about the risk and benefit ratio. In this case, we have not information about benefit, and we take only possible side effects. I don't know if this will change in the future. I don't think so, because it's very complicated to perform studies in this group of patients, because they are not many. I don't know if my colleagues are different experience, but only mainly in patients who are following systematic screening, like scleroderma patients, we may encounter patients like that.
But I think we have many young colleagues here. I don't want them to go with a confusing message here. So we have now a new definition of a mean more than 20 and PVR more than 2. And these patients now, based on the new guidelines, should be treated as PAH patients. We know that there's no data for this patient in terms of having no of these patients have been included in the previous trials. But since they are now defined as PAH patients and the treatment algorithm is very clear, yes, they are minority, but I think once we diagnose them, we should be treated.
Well, perhaps Abdullah, I can comment on that as well, because there's a clear statement in the guidelines to not treat those patients. And I guess what the reason behind that is the trials, as Nazarino has pointed out in his presentation, have been performed with the former cutoffs. So we have evidence in that scenario. We cannot, as a guideline task force, just change the definition now and thereby also change the rules on how to treat such patients. We realize they're sick. This, for the younger colleagues as well, is a certain problem, because we also have to communicate that with patients. They read their letters and they see written, you have pulmonary arterial hypertension. They go to the net, they see, oh, severe disease. Why am I not treated? So we have to properly explain that. At the same time, I agree with Nazarino, it will be difficult to find enough patients to do a separate trial on such patients. However, over time, if we change the inclusion criteria to allow such patients in randomized controlled trials, we will get at least some information on them. So I realize this is a certain problem, but I want to emphasize in the guidelines, for the reasons we have just mentioned, there is a clear statement about the treatment indication that should be kept by a cutoff of 25 and a cutoff of 3.
So, Stephen, is there any ongoing trial including these patients?
I guess that steering committees have to be aware, and they are aware of this change in definition. There are some thoughts on how to capture data on this, but in the end, I mean, that's obviously a task for specific steering committees of ongoing and future randomized trials. What I do want to mention, though, is that the change in definition has been based on mortality data. And we have seen that up from these new cutoffs that we have used, we have an increase in mortality. So we may understand even a moderately elevated pressure and a moderately elevated PVR as a marker of increased mortality. And Nazarino also had mentioned that in group 2, for instance, that can be a marker for the severity of the underlying left heart disease. And I totally agree, and it is. But we do have tools to lower pressure by
treatment of, for instance, heart failure and volume status in this context.
Ongoing study in which these patients are enrolled, and this is the comparison with 2 doses of macitentan, the traditional 10 milligrams and then 70 milligrams. In this case, if I'm not wrong, because I'm not in the steering committee, they included patients with mean PAP more than 20.
Okay, thank you. Luke?
Thank you very much. This is a question for Stefan and
Marius, because it crosses between the 2 talks. And your title, Stefan, had the word wisdom in it. And so it opens up the philosophical side of, have we really moved from 3 to 4 risk strata? Because you have the 3 at baseline, and then at follow-up, well, we still have 3 treatment options. Do nothing, or switch or change, or go to intravenous. So we still have 3 strata. So effectively, we're mixing in intermediate high with high. I can see the wisdom in the way it's done differently, because with the intermediate risk at baseline, you give the opportunity for a good response to dual oral therapy. But then when you get to that second stage, intermediate high and high, you're recommending prostacyclins. Do you see a distinction between those 2 groups necessarily? Because effectively the recommendation is the same, right?
Well, I have talked a lot already, and Marius is the philosophist here, so I give this to him first.
That's new to me. Yeah, in a way you're right. In a way you're right, because we use force greater, but then we have 3 arms for the treatment decisions and follow-up. It was the only way
to combine the intermediate high and the high group in a group where I think everybody who was involved in writing the guidelines believed that these patients are probably best treated with the addition of parenteral prostacyclins. And for that it was important because, as Stefan pointed out earlier during his talk, the problem with the intermediate risk group, especially during follow-up with the original 3 strata model, it has everything and everybody in it. You have patients who are even functional class 2 doing fairly well, and you have patients who are near dead in one group, and this had to be changed. And this I think was one of the important aspects on the guidelines. And of course, we also had in mind future developments which are already visible on the horizon, where I think this distinction also is very important when it comes to making recommendations on how to use treatments that will enter the markets soon.
Thanks, Marius. Good that we got your talk online eventually. Thanks.
Perhaps to add on that quickly, I mean, this is true for the, let's say, pure PAH without comorbidities, that part. And Marius, you very nicely presented also the other part, and you mentioned that at least in Europe, this is the majority of the patients that have comorbidities. So here, this new analysis that I've shown also gives us some idea on the usability of the 4 strata risk in this context. And Marius mentioned monotherapy first. That's a clear statement in the guidelines. But there is also a gray box below that saying that we should consider individualized treatment afterwards. So this analysis has shown us that intermediate low is a feasible treatment goal for these patients. In these patients, it comes down to tolerability of PAH drugs. So it's not forbidden to escalate such patients to combination therapy if we believe a patient will benefit from that. But it makes sense to start with one drug first, check tolerability, check efficacy, and then add something else. And we should mention that the range of phenotypes in this group is quite broad, And then it's up to us, to the treating physicians, to make proper treatment decisions in this context.
Thank you. تفضلي دكتورة.
Dr. Mahali from Kuwait. I just want to ask for all the speakers, whomever is interested in answering this question. Functional class has been given a 1 prognostic marker. 1 functional class 1 to 2 is 1, 3 is 3, and that would diverge our patients from being, if I have someone who with a low 6-minute walk test between 320 and 440, they will be in the green zone while with functional class 2, but if they are more of functional class 3, they will be in the yellow zone where I have to escalate my therapy. It is a very highly subjective, and we've seen that the new data in heart failure, me being a cardiologist and a heart failure specialist, that NYHA class currently doesn't really correlate well with mortality. We need more objective evidence. So as it's been said, like maybe TAPSI over SPAP can replace 6 minutes. What I'm suggesting, maybe it can be as a composite with 6 minutes, not as pure risk marker or risk factor, plus maybe we should have more objective evidence, because this is highly subjective, especially in our patients in the Middle East where they are highly sedentary and they will not even report a class 3, functional class 3, even if they are in functional class 3. So I think maybe this is a very highly subjective, and it's giving a very big way in the forced rata, and I think it should be considered either as integrated with 6-minute walk test, because even our endpoints in trials, it's more on 6-minute walk test or a composite endpoints. It didn't rely much on the functional class. So probably, this is just my suggestion, whomever wants to comment.
Yeah, your point is very well taken, perhaps in terms of the functional class. Marius, do you want to comment on that, related to the forced rate?
Definitely well taken that the functional class has a lot of subjectivity, and perhaps a functional class 3 patient is not the same in Bologna, Cologne, Hanover, or Saudi Arabia. That's for sure. Nevertheless, and we have to go with the evidence. And one thing that came out very clearly from all the large registries, so from Compira, from Revere, from Venge, and this is almost 10,000 patients in total, is that there are the variables that have been tested, 3 variables that are independent predictors of outcomes. And this is 6-minute walk distance, this is NT-proBNP, and this is, despite all limitations, functional class. So we have to acknowledge the limitations, but at the same time, we have the strongest possible confirmation that it works. What I think that we need to do is to make sure that we better define functional class, that we get a better agreement. This is something that will take 5 to 10 years of intensive work to do so, but I think we should work on this because it is important. At the same time, as has been mentioned before, other variables will be introduced, like TAPSI over PAPSI and others, and they will improve our risk stratification. But I think functional class is here to stay.
I agree, because we need, in any case, to outline the limitation of this classification of the risk. For example, the risk stratification at baseline is utilizing the old 3-strata table with the addition of other parameters. And this the table, which was utilized also in the past guidelines, is not perfect because we may have overlap patients with some parameters in the green zone and some parameters in the yellow zone, and we do not have a precise way to classify them. But this is, I think it's difficult to change this problem. We need to understand that these classifications, both at baseline and on follow-up, is an help to the experienced physician. It's not a table in which you make some sum or division and then you get the solution. It's an help. And is limited by the availability of data sometimes, and by prospective data also are important. Having said that, the concept is very important. No treatment changes, no choice of treatment should be performed without risk stratification, knowing the limitations.
Thank you, Naz. Thank you, Marius. I think we have, we're tight on time, but one more last comment or question, please.
Thank you for giving me the opportunity. My name is Khaldun. I'm a cardiologist with the pulmonary hypertension service. My problem is, I think it's ignorance on my side. The dichotomy that has been created by comorbidity, no comorbidity, is really important. And I see that it really diverges the treatment. Now, what is comorbidity? And how is it assessed? Not every diabetic is the same, not every coronary artery is the same, not every heart failure is the same, not every COPD is the same, no interstitial lung disease is the same. Some people would have some parameters. They're absolutely asymptomatic, but they do have an element of obstructive airway disease, or heart failure, like 40% EF with normal BNP, and they are heart failure. They're not the same. But throwing this word comorbidity and making it a dichotomy point that is really ill-defined by any parameter. Anyone can throw anything and put him in that group, or just ignore one part and put him in the other. So it's maybe ignorance on my side, but I'm really, it has, made me irritated. Thank you very much.
Thank you, Khaldun. Thank you, Khaldun. Marius, you want to say something?
Yeah, no, that's a key point. It's definitely not ignorance on your side.
I think we all want to have a very clear description, even perhaps some numbers, to say this is this and this is this. And we cannot do this with the phenotypes, at least not right now. I think we will have better definitions of what's going on. I think eventually we will have a better understanding of what's PAH and what's PAH with what's more group 2, group 3, like for the lung phenotype, which is now clear, it's group 3. I think we will have something similar in the future for patients who have this left heart phenotype, so HFpEF, especially with pulmonary hypertension. But for the time being, and this is at the same time something good, for the time being, it's not Dr. Google. For the time being, this is one of the reasons why we say these patients need to be treated in centers where experience with pulmonary hypertension is. Because personally, I basically never have a problem to determine whether this is a classical phenotype or whether this is one of the left heart or pulmonary phenotypes. This is usually straightforward once you see the patients, once you see the patient comprehensive. And again, we tried as much as possible to put this in the guidelines, especially as the written text, with the concept of disease phenotypes. But there's always a subjective component to that. And Stefan said very rightly, the spectrum, even in these phenotypes, is so broad that there will always be grain zones.
Just a comment.
Yeah, go ahead, Naz.
A comment about that. Given the information we have, I think that we should not consider the patients with comorbidities a different disease, but a patient in which I have doubts about the diagnosis. And this is what happens every day. You have patients with emphysema and so on, not sufficient to justify pulmonary hypertension and so on. I'm not sure about the diagnosis. It's not a disease, maybe a disease phenotype, but mainly I'm not sure if this is group 1 or group 3. It's my feeling about patients with comorbidities.
Yes.
Let me just add, I'd say it's definitely group 3. It's definitely group 3. This is very clear when you look at all the demographics, the response to treatment, the outcome, it's all the same. And I think we've shown this quite convincingly.
But in any case, we utilize drugs.
Yeah, which again, for the PD5 inhibitors may make sense, probably not for the others. And we use drugs because it took us probably 20 years to understand that this is not the same patient population. Even the recommendations from Nice, the 2018 recommendations from the Sixth World Symposium, got it wrong. We all got it wrong. I'm including myself here. I think this is also, it's just something that we are starting to learn right now, that it was a mistake to label them IPAH.
I think Stefan here has a last important point to make on the same topic.
Well, first of all, this discussion highlights how complex this is. And I guess if you look at this from a perspective of a guidelines task force, we could not ignore that. And in a guideline document, you have to go with the evidence that's out there. So just to mention that, where does this issue of comorbidities come from? It came initially from the AMBITION trial, which is the most important trial for promoting dual oral upfront combination therapy. And there, these patients who had multiple comorbidities were actively kicked out because of the reason that Nazareno had just mentioned. Diagnosis wasn't so sure, and the investigators were concerned that a HFpEF-like phenotype contributes to pulmonary hypertension. So it's important to mention it. It's important to go with the evidence. We have clear evidence who were part of the primary analysis set results of AMBITION. So for the time being, we have to realize, yes, this patient has comorbidities. Based on the definitions, we would call it PAH. If we do that, we have an indication for treatment, but we should start with a monotherapy. Marius highlighted that probably in these patients, PDE5 inhibitors are better tolerated. And before we initiate treatment, ideally, even before we assess pulmonary hypertension, if there are comorbidities, they should be optimally controlled before we assess pulmonary hypertension and then make treatment decisions.
Naz, Marius, and Stefan, thank you so much for this session. I know you stuck with us for the longer than what is expected, just simply because this is very important and debatable. Please continue the discussion amongst yourselves and with the, the esteemed members of the scientific committee as well as the speakers. Mr. Hassan has an announcement for the rest of the day.
Thank you very much. Three very important announcements, quick but important. First of all, in the program, it says lunch is 11 to 1:30. It's actually 12:30 to 1:30. So you will have basically 1 hour to rest, pray, and then come back 12:30 for the lunch. We'll resume here at 13:30. 1:30 we'll start here. There will be 2 sessions in here until 5:30, until 5:45. Then you will have half an hour, and all are invited to go to ITHRA. We have 3 huge buses will be parked outside. They will start at 6:20 p.m. All are invited, and the tour, it's a tour actually to ITHRA from 7 till 8:30. Inside ITHRA, 1.5 hour, very important tour. And then followed by dinner at the same spot, at the same venue. There's a restaurant there called Madeline. Everybody is invited. We have reserved so many tables, so all are welcome. Also at 1:30, in the same time with this session, we have a workshop, the 6 minutes walking test, just next door. Thank you very much.
He's here. He's online. So will be different. Yes. So will be more in favor of him.
Well, but it comes down to arguments.
Professor Jean-Luc Vachery, Professor of Cardiology from the University of Bruxelles, Belgium. Thank you very much. And we're looking forward to listen to a talk on pulmonary hypertension secondary to left heart disease, updates in current guidelines.
Thank you very much. Salam alaikum. I'm very glad to be here. Thank you again, Abdullah, and dear colleagues, for your kind invitation. It's always a pleasure to come and visit you to discuss about pulmonary hypertension, and actually, as we did at lunch, for non-pulmonary hypertension related and real-life problems. So the idea here is to present you an update from the current guidelines and maybe have an outlook on what might be the future looking like. I'm going to advance the slide. Okay, so here are my financial disclosures. So what I would like to drive you in the next 20 minutes when the slides will come back is three parts. First, I would discuss very briefly the new definition of pulmonary hypertension, how it pertains to group 2. You've heard from Nazareno that changing the definition is increasing the number of cases, and I will show you how that might have an impact on our field in group 2. Then one of the big problems is to make the difference between group 1 and group 2. This is ongoing. We heard about the comorbidities this morning, what we mean with that, and how it might sometimes be confusing, and surely in the field of cardiology. And then I will close by talking about the management of group 2. One of the things that I believe is nice in this set of guidelines is that we have a lot of pictures that are great for teaching, so you can get in one single figure all the information you need to understand how a disease processed or how a diagnosis is made. And I really like this one on group 2 PH that shows the cause, initial cause, and it's insisting on the fact that in contrast with PH, we have underlying causes and underlying diseases leading to pulmonary hypertension, mostly in heart failure, but also valvular heart disease. Irrespective of the underlying disorder, you will have a sequence of events in which you have a mix between congestion, vasoconstriction, and vascular remodeling at different level and perhaps at different time of development of the disease, leading from a simple increase in left atrial pressure towards right heart strain, which is clearly a net damage that happens in patients who develop a combined post and pre-capillary pulmonary hypertension with a strong pre-capillary component. One of the drivers is right ventricular to pulmonary artery uncoupling. We talked about this this morning, TAPSE over systolic PAP. In fact, it was initially developed in the field of heart failure to illustrate the fact that right ventricular function may be affected without an increase in in afterload, so without pulmonary hypertension. So you have those two clinical phenotype, and I think it's important to move away from, or not move away, but go beyond the simple hemodynamic definition, but recognize that we have different phenotypes in group 2 pulmonary hypertension. One is the pure left heart disease, the patient who would go on pulmonary edema on one side with a lot of comorbidities, and on the other side, you have the patient who looks like a group 1 with it's post-capillary with a pre-capillary component with right ventricular dysfunction. You've seen that this morning quite a few times since the release of the guidelines. There was a lot of discussion around the wedge pressure. Should we change the wedge pressure and the threshold for 15 millimeters of mercury to make the distinction between pre and post capillary? It's been more than 10 years of debate to whether we should change this or not. It was decided to keep it as such. One of the reasons is that most of the trials we've done in PAH set up an upper limit of normal for wedge at 15 millimeters of mercury, and we didn't want to get into trouble. However, if you look at the normal value, you've seen that this morning from Naz, the normal value of wedge pressure is 8. And in most patients with PH, real PH, idiopathic PH or irritable, you will find that they all have a wedge pressure below 10 millimeters of mercury. That said, if you look at the gray zone, so if you take 8 and if you take 12 as being the real upper limit of normal from a physiological point of view, if you take this bunch of patients who are between 13 and 15, you multiply the likelihood that they have heart failure with preserved ejection fraction induce pulmonary hypertension by a factor 5. So you have 5 more chances to have patients with HFpEF when your wedge pressure is closer to the upper limit of normal. And this is important to bear in mind when we're making our treatment decisions. And I just want to highlight that this very famous article from Bat Marin was based and leading to the change in the definition was also based on a very unique population of elderly males. There were very few women in that analysis, and you see the burden of comorbidities in this group, which again suggested that it might not be only the pressure, but also the burden of comorbidities that is important in this setting. And there's also this very nice article reviewing a lot of right heart cath performed at a single center, really emphasizing that even when you have an increased PVR, the presence of an elevated wedge pressure is also associated with a worse prognosis. So it's not only pulmonary vascular disease, it's not only pulmonary hypertension, but also how the heart works well or not well that is important when we want to tackle pulmonary hypertension in the context of left heart disease. Now, the distinction between group 1 and 2 is somehow complicated. You've probably seen this slide quite a few times. There's a couple of questions that we need to ask ourselves when we have at the consultation or in the hospital patient in front of us. We want to be sure that there is no left heart disease being identified. We want to be sure that we have excluded or suspected HFpEF as a potential diagnosis. And then we need to decide which patient should undergo a full workup for pulmonary hypertension. A very caricatural example is the 85-year-old lady with a BMI of 35, an estimated systolic pressure of 50 millimeters of mercury, diabetic, hypertensive, with a normal functioning right ventricle. That patient would not benefit from right heart cath. You take the same patient, but you remove the comorbidities, you decrease the age to 60 with a systemic sclerosis, the story is going to be fairly different. So the first step would be to exclude left heart disease. If you have valvular heart disease, if you have congenital heart disease, pulmonary hypertension plays a role in your prognosis, may play a role in your treatment decision for fixing the underlying condition, not necessarily for the treatment of PH. So one of the difficulties is HFpEF. I think everybody would agree with that. We went from pretty much nowhere to the 3 proposals that would hold, that have held the proof of time to assess or suspect HFpEF as a cause of pulmonary hypertension and simply as an underlying disease. So not only talking about pulmonary hypertension. So it's the H2FPEF score that was developed by Yogesh Reddy, the HFA-PEF algorithm, which is a bit more complicated and rely heavily on some indices picked up by echocardiography, and with a lot of colleagues, Stefan and others, we proposed a table at the World Symposium based on simple clinical tools to suspect whether whether HFpEF or left heart disease could be the cause of pulmonary hypertension. So we would recommend to our junior colleagues to use those tools to start to make their prediction of the probability of having HFpEF as an underlying disorder. And this was brought up in the guidelines by producing this phenotyping, this idea of phenotyping, looking at simple features such as clinical features and routine examination, helping us to determine whether left heart disease is unlikely the cause of pulmonary hypertension, and at the other end of the spectrum, whether left heart disease is likely. Of course, it doesn't mean that you should not catheterize those patients, but it gives you already an idea of the next step and surely what you're going to do in the cath lab. So if you are an elderly person, if you have cardiovascular risk factors, more importantly, if you have atrial fibrillation and a history of atrial fibrillation, you're increasing the likelihood of having left heart disease as a cause of pulmonary hypertension. Any structural abnormalities pointing to the left side is also an addition to, an increase to the likelihood. And you don't need to be a cardiologist to do all these things. You can do that in pneumology, even in general, as a general practitioner, you can pick up those features that would point out the diagnosis in whichever the direction. Of course, echocardiography is totally routine. We have a couple of signs that are put forward and in fact were implemented also in the MRI if you want to have some advanced examinations. Basically, left atrial dilation is almost a signature of left heart disease. This is quite invariable. So if you see a dilated left atrium, especially if a patient is in atrial fibrillation, but even if not, this is increasing your likelihood of having left heart disease. The same can be done by CMR. We introduced also the idea that CPET, cardiopulmonary exercise testing, may be of help in making the diagnostic difference, more by pointing out some typical abnormalities of left heart disease that are exercise oscillatory breathing or exercise oscillatory ventilation that you basically never see in patients with precapillary pulmonary hypertension, whereas this is clearly the signature of HFpEF and heart failure in general. It's very nice to see it in our physiotherapists who are doing the CPET are kind of having kind of fun trying to pick up when there are those exercise oscillatory breathing as a signature also of left heart disease. Now, there are class 1 recommendations. Some of them are level A, some of them, so it means that they've been validated by several studies or meta-analysis. Some of them are level C, which is expert opinion. So the first one I think is important to all of us is that we need to focus when we manage left heart disease or when we suspect pulmonary hypertension in the context of left heart disease, we need to focus on the underlying condition. And Stefan reminded us that even in PAH, it's important to manage those comorbidities prior to consider an assessment for suspicion of pulmonary hypertension. When is right heart cath recommended? Where there's two situations. One is important and new in those guidelines, which is first important for aiding management decisions. So not all patients should go in the cath lab, only those in whom you believe that there will be therapeutic or management consequences. But the new one is that it is also recommended, especially in patients who are undergoing valvular repair and especially severe tricuspid regurgitation. We all see in our centers patients who are referred for a TriClip or whatever the procedure is, or even surgical procedures without proper assessment of the pulmonary circulation, who end up having pulmonary hypertension, and some may have PH. So we would recommend having this procedure being performed. And we want to highlight the fact that those patients who have a significant precapillary component, and that is proposed to be like PVR above 5 Wood units, for example, but also markers of RV dysfunction, those should be sent for a complete workup. One of the reasons is that some of these patients may have CTEPH in association with their underlying left heart disease. Individualized approach is also recommended for those who have high PVRs. And again, there's this group of patients who have borderline increase, 13 to 15 millimeters of mercury of wedge pressure at rest after proper diuresis. Those may benefit from a fluid loading test or an exercise and may be abnormal at that time. But if you want to treat them, if they have normal pressures at rest, irrespective of the response that they have, they may qualify for treatment for PH, but they should be watched with a great level of caution. And I think this is the right-hand part of the algorithm, the comorbidity that we want to point out, especially for those patients with left heart disease. Features of HFpEF, you see it's a 2B level of evidence here, it's a 2B level of a class of recommendation here for free challenge as opposed to exercise. We do prefer this free challenge. It's taking less time. It's easy to do in the cath lab. We start to have normal values, so we would recommend that as the preferred test to uncover heart failure with preserved ejection fraction. Now, let's finish with the management of group 2. You probably also have seen that quite probably 2,000 times, but it's just to highlight the fact that when you deal, and it's the same perhaps with lung diseases, when you want to deal with pulmonary hypertension in the context of left heart disease, you should focus on the volume status, on the underlying disease first, before even thinking of considering assessing pulmonary hypertension. Chasing other causes, and that's the case for CTEPH, is also important. And then it implies also to have advanced therapies in some specific cases. So for example, heart failure with reduced ejection fraction and pulmonary hypertension, patients respond very well to unloading, to persistent unloading of the left heart by putting a left ventricular assist device. Even if you don't want to transplant them, this is one of the good treatment that you may consider. And that's also true for some patients with valvular heart disease. Now, in the process of the guidelines, there was this new methodology, at least for the cardiology folks, the ones who have been working with the ESC for quite a long time. There were one PICO question, that's this methodology that really looks in a very, the constraints to apply this methodology were quite huge, and the question that was asked is, should PDE5 inhibitors be used in patients with combined pre- and post-capillary pulmonary hypertension due to HFpEF? And there was a key narrative question that was broader, looking at the overall drug approved for pulmonary hypertension in the context of group 2 PH, but more specifically pulmonary hypertension due to heart failure, because we consider that we should leave valvular heart disease a little bit aside. So the PICO2 question, the strategy led out of 450 papers that were selected by a literature search by common keywords. There were 36 PubMed articles, 24 Cochrane articles that led us to realize something we knew, which is that there's no recommendation that can be made, because although we had the feeling that it was not recommended, we couldn't find a single study that was looking specifically at CPCPH at the time the guidelines were issued. And although we wanted to give a negative recommendation about it, we were not able to do it. However, what appeared quite clear is that the evidence for IPCPH, so the isolated cases without a precapillary component, the use of PDE5 inhibitors in this context is discouraged. It's a class 3 level of recommendation and a level C of evidence based on this article reviews. The key narrative question, as you can see, there was much more. If I recall well, it was 1,500 articles, out of which we extracted 240 from PubMed and 141 from Cochrane, to end up with a single line that is drug approved for PH are not recommended in pulmonary hypertension due to left heart disease. The level of evidence is A, so this is not insignificant. It's a very strong straight statement. We don't have that much of strong statement against in those guidelines, but this is part of it. Now, you may say, well, we have patients and who can be responsive to treatment, and we have, let's say, non-approved use or empirical use of some of the drugs for PH. I showed this slide last year and the year before and the year before and the year before. It has been implemented with the last two trials, the HELP trial and Dynamic HELP trial with levosimendan. It's a small study. Levosimendan was given intermittently to patients every, I think it was every 3 weeks, and the idea was to see whether the wedge pressure increase induced by exercise would be improved by the administration of levosimendan. The end result was that there was just no change between the placebo and the treated group. The only change was that there was an improved 6-minute walking distance with a huge placebo effect. Nobody knows what to do with this information, and I'm not sure this might be a way forward. More interesting, the Dynamic study with rosiglutat, that was a true randomized control trial with 114 patients who were randomized from placebo to rosiglutat. The primary endpoint was a bit unusual. It was a change in cardiac output. There's a story behind it. We can discuss that, but the change in cardiac output was the primary endpoint. It was a very strict study. You can see here the protocol. Patients were escalated for 0.5 to 1.5 milligrams TID. It was a 1:1 randomization to placebo. At week 26, there was an improvement in cardiac output in the rosiglutat group, as you can see here, by a change of half a liter per minute of cardiac output at rest, which is, it is something that there's a p-value there. But if you take a closer look, you will see the large standard deviation. So there were probably patients who were responding better than the others. Now, if you look down the road at the other secondary endpoint, there was no effect on any of those secondary endpoints. There was no change over NT-proBNP, no clinical improvement, a little bit more drug-related dropouts in the treated group, which really raises the question. And again, this was in mostly isolated post-capillary pulmonary hypertension population. So we're not there yet in terms of getting treatment for those patients, and the future doesn't seem to be looking that well. This is a list of studies that were either stopped before completion because of sponsors' decision, and some of them had some safety issues. That Soprano with macitentan, SAPH, whether ultraprostacyclin and Serenade with macitentan, which is Melody with a run-in period. All these studies were interrupted. Soprano and Serenade were presented, and the results just show that there's basically no benefit. There was a last study that was published recently, Mirabegron, which is a beta-3 agonist. Study that was done by our colleagues in Spain, and unfortunately there was no change in baseline PVR, in PVR at baseline versus 16 weeks of treatment. So this is where we stand right now. But there's hope. There are two studies. One is championed by Stefan, the PASSION study, oral tadalafil, looking at patients with HFpEF, with a true pre-capillary phenotype, so right ventricular phenotype, time to first event study. And another one that is going on called Cadence. It's sotatercept at 3 different doses, so patients are going on placebo, 0.3 and 0.7 subcutaneous sotatercept, looking at change from baseline in PVR. This study is still recruiting, and we hope that by better identifying those patients, we might have some options in the future. Couple of messages to take home. Post-capillary pH is a hemodynamic condition. It's not a disease. I want to echo what Naz and you all pointed out this morning. It's not a disease. It is still defined by wedge pressure above 15 millimeters of mercury. The pre-capillary component, and this is a matter of debate, has been said at 2 Wood units. PVR above 5 Wood units is considered to be clinically meaningful. The distinction between pH and group 2, and mostly pH associated with HFpEF, is critical, challenging, relies on a multidimensional approach and better hemodynamic phenotyping, so we don't want to rely on one single magic number. It's important to put the hemodynamic assessment in the context, general context of the disease. The management of group 2 pH, still based on the underlying condition. We all want to hammer that one. If you invite me for the next 100 years, I would repeat the same thing, although I might be dead at that time. And then finally, last but not least, pH therapies are still not recommended in group 2 pH. Thank you very much.
Thank you so much, and join us here. Elegant as usual, Sean. Thank you so much. Our next speaker is a newcomer to SAPH, this time from United States, Professor Dr. Oksana Sholpin. She is a medical director of pulmonary hypertension program and director of advanced lung disease and transplant in Inova, Fairfax, United States. She's also associate professor of medicine in University of Virginia. So Roxana is going to talk about an update on group 3 pulmonary hypertension management. Roxana?
So thank you for inviting me to the scientific committee. This is my first time in Saudi Arabia, and I just would like to thank you all for your genuine and incredible hospitality. So these are my disclosures, objectives for the talk. So you've heard this morning already that chronic lung disease, group 3 PH, had a newcomer in its classification, and it is hyperventilation syndrome. The patients who belong into that category are patients who have obesity, hyperventilation syndrome, and neuromuscular weakness with hyperventilation. We do not have a whole lot of data on that patient population. And today I am really going to focus on parenchymal lung diseases. So if you think about pathogenesis of parenchymal lung disease-induced pulmonary hypertension, we used to think that it was really just caused by parenchymal destruction and its effect on capillary bed destruction, the periadventitial fibrosis in interstitial lung diseases with decreased vascular capacitance and local hypoxemia, which is caused by increased VQ mismatch. In IPF, there is evidence of pulmonary vena occlusive disease lesions, usually from autopsies or from transplant studies. And more recently, there's been data on neovascularization, again, based on the pathology studies. Now, what we do realize now, and there's more and more data about that, is that there is a real deal vasculopathy that happens in patients with parenchymal lung disease, PH. You heard from Luke yesterday that vasculopathy may be a bit different from IPH. Usually you don't see as many plexiform lesions, but vasculopathy is there. And there is more and more research into cellular and cytokine background or reasons for PH to develop. Now, patients, especially with ILD, are at risk for acute pulmonary emboli, and there have been cases of also chronic pulmonary emboli that have been described. Again, pathology studies show in situ thrombosis in these patients as well. Now, you've heard about comorbidities today, probably more than you wanted to hear, but comorbidities is a real deal for patients with parenchymal lung diseases. They tend to be older. People often have diabetes, systemic hypertension, obesity, and so they do develop post-capillary pulmonary hypertension. And I think it's really under-recognized and really needs to be sought out because it does have impact both on treatment, theoretically, but also prognosis. There is data that's coming out that those patients actually do a little bit better than patients with pre-capillary PH. Now, this is a nice illustration from European Society of Cardiology Respirology guidelines that was published, and it sort of gives you an idea for prevalence of the disease. Now, I do have to caution you that there are a number of problems with the prevalence studies that have been published. One, hemodynamic definition has undergone significant change in the last decade. Two, many studies have used echo as a diagnosis of pulmonary hypertension and not right heart catheterization. And three, the populations that were studied are really all over the place, both with mixed obstructive restrictive lung disease together. There has been like various spectrum of disease activities, and disease phenotypes were really not well defined for those studies. Now, I just have a couple of slides on phenotypes because this is the subject that can be talked about probably in a separate lecture. So what we do know is in mild to moderate restriction in ILD, there is a change in mean PA pressure of about 1.8 millimeters of mercury per year. Why some people develop pulmonary hypertension and why in some people it progresses, we have no idea. There is absolutely no correlation between disease severity, either by fibrosis on a CT scan or by pulmonary functional test markers, so FVC, and severity of pulmonary hypertension. And at least there have been a couple of studies looking at mild interstitial lung disease, and somewhere between 8 and 15% of those patients cohort actually had pulmonary hypertension. Now, if you look at severe disease, and that was one of the studies that our center published, in patients who were worked up for lung transplant, who were referred for lung transplantation, again, there is a referral bias obviously there, 46% of patients had pulmonary hypertension at that time. And what we did is we actually had recath those patients right before they were being transplanted, and 87% of patients at the time of transplant had PH. Now, post-capillary PH, I already mentioned. Again, it's something that exists, something that is not talked about. So I already mentioned that there are various phenotypes of pulmonary hypertension in the setting of interstitial lung diseases. Why some patients develop a certain phenotype, why you would have a mild LD and severe PH, or severe PH and severe ILD and everything in between, we honestly have no idea. I know Marius Hooper mentioned that He can identify patients who have IPH with lung phenotype very easily. He's probably a better clinician than I am. I find myself having trouble with that. I mean, I think it's not clear-cut, and we really need to understand the phenotypes and study them in more detail. Now, PH and COPD may be a little bit better phenotyped. At least we know that there is this phenotype of patients that have really preserved pulmonary function tests. We don't know, by the way, how they look like on a CT scan, but at least they have preserved pulmonary function tests with very low DLCO. They tend to be males, they tend to be older, they tend to be smokers, and they have severe pulmonary hypertension, so PH lung. Now, if you think about natural history of mean PA pressure increase over time in moderate COPD, it's a little bit less rapid in comparison to interstitial lung diseases at 0.4 millimeters of mercury per year. Now, PVR was shown to be a driver of outcomes in patients with COPD and in patients with interstitial lung disease. Now, there is a wealth of data out there that mean pulmonary pressure makes a huge difference in outcomes. And again, this data came from registry trials, registries, not trials. And so you have to begin cautious about interpreting this data. And if you look at patients' populations very, very carefully, patients that were in those registries actually had a significant disease. So if you keep that in mind, so significant hemodynamic disease. So if you keep it in mind, then maybe it makes sense that the PVR cutoff is pretty high because, again, you're looking at patients who as a group, had pretty advanced hemodynamic impairment. Now, based on that registry data, there is a revised definition of severe pulmonary hypertension due to parenchymal lung disease with a PVR cutoff of 5. Again, we used to have a mean pulmonary pressure over 35 or mean pulmonary pressure over 25 with a cardiac index that was below 2 as a definition, but this is what we have to work with for time being. Now, why do we care about group 3 PH? So this is a study that was published at this point 5 or 6 years ago. It's a GISN registry outcome study. And what they did is they compared patients with different groups of pulmonary hypertension. And you can see patients with lung disease are represented by a purple line. They do horribly. So these patients die. They die very quickly. This paper separated patients with COPD and interstitial lung diseases, and you can see that patients with ILD really fare very, very, very poorly. What about the everyday activities? So this is a study that was published in 2021 by Dario Visa, and he looked at compared data and looked at the different parameters that separated patients with moderate and severe PH based on the old definition. Now, if you look at the hemodynamic profile, though, that I highlighted here, you'll see that patients with severe PH have severe PH based on the PVR cutoff. Everyone in that group had PVR more than 5. Now, in patients in moderate group, though, there are some patients who had PVR more than 5 there. So if you sort of reclassify these patients, the numbers would be a little bit different, with majority of patients falling into the severe group. Now, what is evident is that patients with severe PH walk much less, and many more of them have functional class 4 symptoms. So they really struggle in everyday life. So this is an elegant study that was published by Omar Minai at this point 15 years ago, but really one of a kind. So what they did is they looked at the 6-minute walk test distance along different mean PA cutoffs, and they used the severe PH here as a mean PA pressure over 40. And so what you can see here is that as pulmonary pressure goes up, 6-minute walk test distance goes down. And the distance saturation product also reflected increased desaturation with exercise in that study, which is what we see in clinical practice. Now, this slide attempts to summarize all of the data that we have from multiple trials or studies and sort of put together what findings you may use in your patients to suspect development of pulmonary hypertension. So I already mentioned the PFTs in themselves, so the lung volumes are not really helpful, but diffusion capacity less than 30% or worsening diffusion capacity correlates with presence of pH. On 6-minute walk test, you're looking at marked or worsening desaturation and distance. And then in ILD specifically, actually that study was done in IPF patients, decreased heart rate recovery at the end of the 6-minute walk test, less than 13 here was correlated both with pH and mortality. On a CT scan, there are studies both in COPD and IPF that looked at the pulmonary artery to aorta ratio, more than 0.9 in COPD and 1 in IPF that correlates with presence of pH. And while you're looking at that CAT scan, you can look at the RV to LV ratio as well. Now, echocardiogram is tricky. So RVSP in itself has horrible correlation with hemodynamically measured systolic pulmonary pressure. It can both underestimate it and overestimate it. So when you're looking at the echo, you really need to look at that right ventricle. And so that makes it more likely that someone with elevated RVSP has pulmonary hypertension. You also should look at the left atrium and left ventricle as well at the same time because, again, those patients can have diastolic dysfunction. And then elevated BNP, again, has been shown to correlate with presence of pH in the setting of parenchymal lung diseases. Now, let's quickly talk about right heart catheterization. The important word here is right. So the heart catheterization is a bit more tricky in patients who have parenchymal lung diseases. So it needs to be done by an experienced provider. It needs to be done in patients with stable lung disease. If you have an IPF patient who is being admitted with an exacerbation, please don't do right heart catheterization. A, it's probably going to be difficult to do because of the intrathoracic pressure variation. But B, the likelihood is that the mean PA pressure is actually going to go down when exacerbation has been resolved. Now, again, I want to mention again that the diastolic dysfunction is a thing in patients with parenchymal lung disease. So, echo, when well done, never lies. You really need to look at the left atrium, left ventricle. You need to look at the E to E septal ratio and lateral wall ratio. And especially if you have patients with risk factors for diastolic dysfunction, and you do right heart catheterization and you have a pre-capillary hemodynamic pattern, question it. Because these patients probably do not have pre-capillary pH. So these are the people that you should consider doing a fluid challenge with. Exercising those patients really doesn't work very well because they're so short of breath. Now, what about other predictors of outcomes? Diffusion capacity was looked at by University of Minnesota group in a mixed patient population and showed, so in their study, DLCO of 30% was a differentiator of mortality. And the same group looked at the RV function in a mixed patient cohort. And RV function is measured by fractional area change of FAC. In this study of 28% was also differentiator of mortality, which makes sense, right? Because people die of RV failure. They don't die of PH per se. Okay, treatment. So this is I think an important point, important topic, and the point that I want to make is it really needs to be a multi-dimensional approach. For patients with COPD, we have a number of inhalers that can be used. For patients with fibrotic lung disease, there are antifibrotics, and you really need to treat patients' underlying lung disease. I cannot tell you that by delaying disease progression of parenchymal lung disease, you're going to delay development of PH or progression of PH, but it sort of makes a little bit of sense that maybe it may be the case, but probably no studies will be done. Comorbidities management is very important for their quality of life. If you have a tight LAD lesion, patients are going to be more short of breath. So if you fix their coronary disease, then maybe they're going to be less dyspneic. I cannot talk enough about pulmonary rehab. There are multiple studies in PH, in ILD, in COPD that pulmonary rehab works. And so patients feel better, they walk further, their everyday activities are a little bit easier. Oxygen is very important. I cannot tell you how many patients who come in to see me with ILD PH do not have enough oxygen. They come in on 2 liters, you do their 6-minute walk test, and they descend to mid-80s. The same thing with nocturnal hypoxemia. Clinical trial enrollment is obviously obvious. Palliative care or dyspnea management is very important. These people are very, very short of breath. And finally, lung transplant in patients that are appropriate candidate for lung transplantation. And then let's talk about pulmonary vascular disease treatment. So this is just sort of a general algorithm on how you approach patients and work them up. Try to phenotype them to your best ability. Again, trial enrollment is very, very important. Volume status management is extremely important. I mean, if you diuresis someone who is in cor pulmonale, they're going to feel better. I'm going to give you a little bit of trial data for COPD. For patients with interstitial lung diseases, just 2 quick things. There was a RISE-IP study of riociguat that actually showed a mortality trend, or not trend, it showed increased mortality in patients with parenchymal lung disease PH, hemodynamically defined, that were treated with riociguat. So as of right now, don't use it. And there is actually data, a lot of data now in patients with ILD treated with ERAs, so bosentan and ambrisentan, and patients with PH due to ILD treated with ambrisentan that showed either no improvement or a trend to worsening. So again, it is recommended not to use these agents. European Society of Cardiology and Respirology recommended PDE5 inhibitors in patients with severe PH on an individual basis. Have no idea where that recommendation honestly came from. We can debate it for a long time. Data is mostly registry. And inhaled treprostinil was recommended to treat for patients with severe PH. And again, I cannot tell you why that recommendation was made, because patients that were enrolled in the study had mean PA pressure over 25 with PVR more than 3. There was an analysis that was made after the study that appeared to indicate that maybe patients with PVR more than 4 are better responders, but PVR more than 5, don't know. So, PH COPD. Spheric trial of sildenafil enrolled patients who have more severe phenotype. What I want to underline here is that patients who received sildenafil actually had a higher PVR and walked less. So they were probably in disadvantage. Despite that, sildenafil improved PVR, cardiac index, stroke volume, and different dyspnea and well-being indices. Now, there is not a lot going on in the research realm. Inhaled treprostinil study, perfect trial, ended up not being perfect after all, and it was terminated by a sponsor based on the recommendation of Data Safety Monitoring Board. What exactly happened, we don't know, and hopefully that data will be published to educate all of us and help us design other trials and maybe select our patients better, select our drugs better. Inhaled riociguat is being trialed in a phase 2A study, and there are a number of small phase 2 trials of inhaled nitric oxide that showed improvement in cardiac output and mean PA pressure. So there hopefully will be a study that will be recruiting for PH COPD. Okay, let's talk about inhaled treprostinil. So you already saw, I think yesterday, that inhaled treprostinil resulted in placebo-corrected difference, both due to improvement of 6-minute walk test in treprostinil patients and decrease in 6-minute walk test in placebo patients. And yes, the dose does appear to matter, so you really need to increase the dose to more than 9 breaths QID. It also appeared to have had an impact on the occurrence of clinical worsening, mostly driven by 6-minute walk test, but numerically hospitalizations as well. Just the numbers, are not super high. There was another paper that was published this year that looked at the decreased risk and time to first and second progression event, and patients on treprostinil did actually much better than patients on placebo. And finally, there was this a little bit of a crazy waterfall graph that was included in the paper by Steve Nathan, who's my mentor, in Blue Journal. And just to orient you, every rectangle is a disease progression event, and the color reflects a specific event. And what you can just visually see is that patients who were on treprostinil have less events than patients who were on placebo. And it stayed true for patients in the whole IIP group, for patients with IPF, for patients with CPFE, and for patients with CTD-related ILD who were thought to have a group 3 phenotype. Now, really quickly, inhaled nitric oxide in fibrotic lung diseases at risk for PH was studied and showed that there was a 20% placebo-corrected benefit in moderate or vigorous physical activity measured by actigraphy. It also showed that there was improvement in quality of life outcomes. Now, to finish up, this is a table of studies that are currently or maybe in future will be ongoing. Inhaled nitric oxide, I already showed you. The phase 3 trial is currently enrolling. Bardoxolone methyl, which is an antioxidant, was trialed in patients with different groups of PH, and there was a small cohort of IPF PH patients, which actually had a good 6-minute walk test distance improvement of about 30 meters, but it doesn't seem like the company is going to be pursuing that. There is a Stanford trial of hyperchromone, which inhibits synthesis of hyaluronone, which is has been implicated in both fibrosis development and their vascular or pulmonary vascular vasculopathy as well. And this trial is almost done with recruiting. So I think we're going to see data for that trial come out this year. And finally, inhaled imatinib is going to be trialed in a group 1 phenotype of patients, and hopefully there is going to be a study planned for PH due to interstitial lung diseases. So with that, I don't know whether I ran over time. I apologize if I have, but if there are any questions, I'm happy to answer them.
I think you could join us, please, in the podium, and we'll leave the questions until the end. It gives me a great pleasure and honor to present Dr. Majdi Idris, one of the pillars of this symposium in the region. He's a professor of pulmonology, the head of the pulmonary vascular unit in Prince Sultan Military Medical School. And we will be really excited to hear the talk today regarding pulmonary arterial hypertension and comorbidities. Thank you very much.
Thank you so much, Mr. Chairman. Assalamu alaikum wa rahmatullahi wa barakatuh. It's a great pleasure and honor to be with you here today, and thank you for the organizer to give me the privilege to be with you here. So that's my disclaimer. And let's start by talking about this now, the updated guideline, the last version, 2022. And in one of Mary's Hooper talk, he was saying maybe 1.1.3 item should be included, which is PH with cardiopulmonary comorbidity. And I'm going to show you or try to show you why I think this was a true statement. And I think that in the future guidelines, we're going to see that basically subphenotypes added to PAH group. So let's start by talking about what do we mean when we say there is a comorbidities. And comorbidities from the dictionary saying that it is the simultaneous presence of two or more diseases or medical condition in the same patient. And if you think about it, those comorbidities can coexist, two different diseases with no interaction between them. So the outcome will be an additive outcome. So really disease one with its own problem, disease two with its own problem, leading to a poor outcome based on the addition. But sometimes the comorbidities can really synergize in the way that they do interact together at the cellular level to really produce harm, leading to synergism, i.e. it's not simply 1 + 1 = 2, but 1 + 1 might be equal to 3 or 4 because of this interaction between the comorbidities. And when you look at what happened with PAH with comorbidities, it can interact at different level at the diagnostic issues, management issue, and risk stratification, and the outcome. This was a beautiful review article by Ari Lang trying to look at the different comorbidities that may coexist with pulmonary arterial hypertension that include all kinds of comorbidities, basically neurological, basically endocrine, cardiac, pulmonary, metabolic, etc. And sometimes we need to really make up our mind, are we dealing with comorbidities with an additive component or comorbidities with that kind of the really synergistic, basically worse outcome. So these were the data looking at what happened in the Western data, looking at patients with PAH and comorbidities. So this was the initial work by Maris Hooper looking at the comparer registry. They looked at 840 patients with really PAH, and they classified them into 3 clusters. Cluster 1 were those patients that they call eventually as typical PAH. So those were the young patient, mostly female. They have no comorbidities when it comes to the cardiac basically component, and the lung function were maintained with the DLCO more than 45%. In cluster 2 were those patients much older. They are basically mostly female, no smoking history, but a lot of cardiac comorbidities. And cluster 3 are those patients who were, again, older than the typical or cluster 1. They were predominantly male. They were smoker. They have both cardiac and pulmonary, basically comorbidities. And they were really classified as cluster 1, the typical idiopathic PAH, cluster 2, the cardiac phenotypes, and cluster 3, the cardiopulmonary phenotypes. And when you look at the really basic characteristic of those 3 clusters, you can see that basically the patients who were in cluster 1, they were able to walk longer distance, and they had basically lower biomarkers. Looking at the hemodynamics, again, cluster 1, they had higher really mean pressure compared to cluster 2 and cluster 3, and their PVR was even higher as well. Now, when you look at the outcome to those 3 clusters, the typical PAH with no comorbidities, the one with cardiac comorbidities, and the one with cardiopulmonary comorbidities, you can see clearly that cluster 1 showed the better outcome when it comes to change in the 6-minute walk distance in response to medical therapy and the drop in the pro-BNP compared to cluster 2 and cluster 3. And I think this slide was shown yesterday by Dr. Howard, showing that only cluster 1 patients showed good improvement and improvement in the risk stratification with treatment, while those who belonged to a cluster 2 or a cluster 3, they had much more blunted response to treatment or less responsive to treatment. And the post-hoc analysis trying to look at what happened when it comes to basically outcome mortality, for example, it was very clear that cluster 1 having better outcome when it comes to the survival compared to cluster 2 or cluster 3. Another Italian study trying to look at, okay, so it seemed that the presence of those comorbidities matter. But is it like if we add more and more comorbidities, would that make it worse? So they look at cardiac patients. Again, they divide them into 3 groups. They look at about 180 patients. About 50% belong to group 1, those who had no cardiac morbidities. About 30% had only 1 cardiac morbidities. And then group C had 2 or more cardiac morbidities. And what they found, when they look at what do they mean by the cardiac morbidities, those were the morbidity used in many studies, including the AMBITION trials, looking at systemic hypertension, hyperlipidemia, obesity, diabetes, peripheral vascular diseases, coronary artery disease, and atrial fibrillation. And when they look at what happened, are those patients behave the same? And the answer was no. So those patients with no comorbidities, the response to therapy was much better. There was significant drop in the pulmonary vascular resistance with treatment. While those who had 1 cardiac morbidity, they were somewhere in the middle between those and those who had more than 1 cardiac morbidity. So it seemed that the more morbidity the patient has, the worse the outcome. And even when you look at the changes in the risk stratification, both on REVEAL or the European guidelines, again, most of the improvement happened in the patient with basically no cardiac morbidity, the group A, and little bit in those who have only 1 cardiac morbidity. Those who have more than 2 or more had the least response to therapy. Then we look at, okay, then what about the lung basically phenotype? So again, Maris Hooper look at those patients, try now to look at the really pulmonary basically comorbidities. So they look at the patient and they were really classified into, again, 3 groups based on no lung morbidities, basically PH with lung, basically phenotypes based on DLCO, and those who have group 3 based on the physician basically diagnosis. So those are people who do not have group 1, but they have group 3. And then when they look at the difference in their basic characteristic, you can see that the one who had the classical PH were younger, more likely to be female. Looking at what happened, again, those patients with a typical PH, they had basically better 6-minute walk distance and better really biomarkers. Of course, lung function was entirely normal in those patients with no lung morbidities. They were kind of borderline in those who had basically PH with basic PH with lung morbidities. Mainly DLCO was low, and those with group 3, they have a very abnormal lung function. And again, when they look at the outcome among those patients, it was clear now this upside down. So basically function class 1 is the dark green, the really pale green is function class 2. So you can see that what happened, that most of the treatment response occurs in those patients who had no lung comorbidities. Those who have lung comorbidities based on low DLCO, but no significant abnormal lung function or CT finding, and those patients with group 3 disease, they did not show adequate response to the PAH treatment. And again, when they look at the 6-minute walk distance and the biomarker changes that follow the same outcome, it was much better response when it comes to patients with no lung comorbidities. And looking from the data from both COMPARE and the ASPIRE, looking at the outcome when it comes to the basically survival, again, it looks that only patients who have no lung phenotypes or do not have basically group 3 disease, they get significant basically survival advantage. And we kind of know that from the beginning, because we know that for example, in the setting of the scleroderma patient, those patients with scleroderma who have PAH scleroderma versus PH group 3 scleroderma, we know that PH group 3 scleroderma do much worse than those who have PH scleroderma. And finally, this was a German study trying to look at risk stratification. Are they really blunted in those patients with a comorbidity, or we can still follow them in the very similar way that we use with patient with a PAH or typical PAH. And here they look at, again, at their patient based on both cardiac phenotypes, if the patient fulfill at least 3 of the criteria, or the pulmonary phenotype, which are those patients who have kind of okay lung function, but they have low DLCO and they have basically hypoxemia. And when they found that, when you really follow the response to therapy, you can see that those patients with the typical PAH, it seemed that this risk stratification can segregate or can differentiate the outcome in a way that those patients who were at high risk compared to those who are at low risk, there was clear basically survival difference and time for first clinical worsening. While those patients who have PH comorbidities, you can see that they kind of lost a loss of that kind of clear segregation. So it seemed that even the risk stratification that we use for typical PH might not be applicable to patients with PH with cardiac morbidity. So what did the guideline tell us? And now we know that now the new guideline is talking about starting from the beginning to make that differentiation. And that's why I said that I think in the future guideline version that phenotype will appear in group 1 PH subclassification. So now the guideline saying that in those patients who have cardiac comorbidities, then the best thing is to start with only one drug, unlike the more aggressive basically recommendation in typical PH with really upfront combination therapy, and give that to basically a recommendation, and then to consider adding drugs if the patient is still at high risk at later stage, and that's at 2B. Both have a level of evidence C. So again, the guideline is trying to really tell us that be careful, these are not same diseases, although they are really basically lumped under PAH categories. So take-home messages. I think there is reasonable data to say that really cardiopulmonary comorbidity are common among PH patients, especially in the Western world, because now the average age there is about 50 to 60s. Data from Saudi Arabia is a bit different. We have Dr. Abdullah data and our data showing that our age group here is about 30, 32, 34. So maybe we do have less PH with cardiomorbidity compared to the West. We know that basically cardiopulmonary comorbidities may, I would use that carefully, synergizes, not only addition, with PH, basically pathobiology to really lead to different disease. It's not simply two diseases coexist. And I think that has been translated to more difficulties in really risk stratifying those patients and probably worse outcome at multiple levels. The guideline now is telling us this in really indirect way when they recommend different treatment regimen for both categories, PAH with no comorbidities and PAH with comorbidities. And I think the unanswered question would be still is, again, are we dealing with multiple diseases with an addition or multiple diseases that interact leading to brand new disease? That at the moment we call it PAH with comorbidities. We know that we have the same problem in the pulmonary medicine when it comes to asthma, COPD, and that's really ACUS. It's an unended basically discussion and debates among pulmonologists whether these are two diseases or the end result is a different disease. I think it's still the same here. What is the best way to risk stratify those patients? Still need a lot of work. And what is the best treatment strategy? Still need a lot of work as well. And with that, I would like to thank you very much for your attention.
Thank you, Majdi. Can you join us? We enjoyed your talk so much. Thank you so much. Now it's actually a very exciting part of the session. So it's going to be a debate about low-risk intermediate group, what to do, whether add a medication or switch from one class to another. So we have two debaters. Professor Nazareno Galli will start. He is a pro adding, not switching, and then will be followed by Professor Luke Howard, who is going to be with switching, not adding, and then we will have a rebuttal after that. So I think Professor Galli will be ready in a minute, and I hope you all enjoy the debate. Thank you. We hear you, Naz, we hear you. We're just waiting for the picture. Just 1 second, please. I think you can start. We can see the slides now.
Thank you very much. So let's start this debate about switching or adding patients. These are the 56 randomized control studies developed in PAH with a different configuration and different treatment strategies, and they allowed the approval of a different group of drugs interacting to three pathways: endothelin, nitric oxide, and prostacyclin. And also the drugs were utilized according to different treatment strategies: monotherapy, sequential combination, initial combination, and finally risk-oriented. These are the new guidelines, and this is the treatment algorithm of the new guidelines. And as you have seen several times in this Congress, there are two sections. The largest one is for patients without comorbidities, and the smaller one is for patients with comorbidities. The risk assessment has been changed because the three strata table like this has been only enriched with other parameters who are correlated with survival, but this is the table which is adopted at baseline when the patient is just diagnosed and we start the therapy. And for the subsequent evaluation, we have another table, a four-strata table with a limited number of parameters: functional class, 6-minute walking test, and NT-proBNP. And according to the fulfillment of these intervals and the utilization of numbers, we can achieve in a quite precise way the configuration of the patient. If he's at low risk, are intermediate low risk, are intermediate high risk, and at high risk. Now, when we started the treatment algorithm, there is the first part which is related to the correct diagnosis, to the vasoreactivity test, to the treatment with high dose of calcium channel blockers in responders. And then we arrive to the first stratification of patients who are treatment naive. And we have two possibilities. If the patient is at low or intermediate risk, there is a double initial combination therapy with endothelin receptor antagonist and PD-5 inhibitor. In patients with at high risk, you have double initial combination therapy, and in addition also an intravenous or subcutaneous prostacyclin analog. And then we have the first follow-up, and at the first follow-up, we may have another stratification: low risk, intermediate low risk, intermediate high or high risk. The four groups with the small table. And then if the patient is at low risk, this is the goal. No changes are needed. In patients who remain at intermediate high or they progress to high, or in this case, there is a triple combination therapy, including intravenous or subcutaneous prostacyclin analog. And what about probably the largest group, the intermediate low? There are two possibilities. There is the possibility of triple combination therapy with a prostacyclin receptor agonist, or switching, substituting a PD5 inhibitor to the with riociguat. And this is the topic of the debate, and how we can choose about adding or switching. There is, this is the table. You will see that at the end I will propose some amendment for this table, which report the level of evidence and the grade of recommendation. For combination therapy, the grade of recommendation is 2A, B, because theoretically only one study has been published in this area. If we go to the shifting, there is also a new study, which is the replace, only one. And the level of evidence, as you can see, is the same. The grade of recommendation is 2A for addition and 2B for the switching. Let's see if I can convince you that some of these figures can be changed. So first of all, the Griffon study. This is the largest ever study in PAH, almost 1,200 patients, testing the effect of selexipag, prostacyclin receptor agonist, in addition as monotherapy or in addition to monotherapy or double combination therapy. And as you can see, the addition of selexipag to patients already treated with monotherapy or combination therapy reduced by 40% the events where the primary endpoint of this study. However, someone forgot another study, which is with treprostinil, which is an orally available prostacyclin analog, which this is a randomized control study with a primary endpoint outcome, testing the addition of treprostinil to the patients on monotherapy or double combination therapy. And also in this case, there was an improvement of the outcome, probably less evident as compared to the Griffon, but in any case, there is a difference. And this is the replace study. The replace study is not a large study, 226 patients at intermediate group, randomized to continuation of the therapy or changing the PD5 inhibitor with riociguat. The endpoint is based on 6-minute walking test, functional capacity, and NT-proBNP, and is defined as the absence of clinical worsening and improvement in all other parameters. And when the data were analyzed, it was found that the probability of improvement was larger in patients with who shifted as compared to the patients who did not change the therapy. And I may anticipate a problem here, because probably in the study, if we want to do a comparison between shifting and combination, we need the combination arm. In this case, we have shifting against no change. So probably to get a convincing element on the superiority of shifting as compared to combining an arm with combination therapy should have been added. Another limitation is that being an open label study, obviously patients who knew that they got a new drug were probably more optimistic doing the 6-minute walking test, and the people who knew that they had to continue the same therapy were not so enthusiastic to declare an improvement of the functional class. But the most important element is that the NT-proBNP plasma level, which cannot be influenced by the knowledge of the treatment, is not changed. There is absolutely no change between patients who continue the treatment as compared to the patients who shifted to Priosiguat. And now let's go to the algorithm and to the table of grade of recommendation and level of evidence. It's obvious that for the combination, we need to add also the freedom study. So the level of evidence is not anymore B. The level of evidence is A. On the other hand, if we go to the replace cannot be a study which is similar to the other two studies. These are fully blinded randomized control trials, the true trials. And the replace study, it cannot be considered a registration study because no agency can accept a non-blinded study as the proof for the efficacy of a drug. So it cannot be B. It has to be a level of evidence C. It means expert opinion. Finally, this is the group of who is analyzing randomized control studies and giving suggestion and explanation why some characteristics of the clinical trials are important. For example, blinding. The term blinding or masking refers to withholding information about the assigned interventions from people involved in the trial who may potentially be influenced by this knowledge. Blinding is an important safeguard against bias, particularly when assessing subjective outcome. Exercise capacity and functional capacity are subjective outcomes. Thank you.
Thank you, Naz. So your opponent now is up on the podium. Luke, podium is yours.
Do I have to? Okay. At least Naz can't hit me. I mean, actually, probably he can. He's probably got one of you in the audience. So, look, thank you very much for asking me to do this debate. And it's certainly a very interesting one. And it's nestled right there in the bottom of the algorithm. And it was just asking for it, really, wasn't it? And so I'm supposed to be speaking in favor of switching. These are my declarations of interest. So you can see I've got a lot of interest in switching. Now, the object of the debate is basically to win at any cost. As Naz will know, I'm Oxford educated, which is the home of debating, and I will employ any tactic I possibly can to win. So this was us yesterday having some nice coffee and dates just before lunch, and I turned to my colleagues and said, look, I've got a problem. I'm debating NAS tomorrow on this topic. And they all looked at me and they said, you don't have any hope. Except one person, Sean, who's not in this picture, said, he was away getting me some help. He said, Luke, I've got something that might help. So it's just a pity that I need an extra long one to reach Naz where he is right now. So if you're not convinced by the arguments, then this is my only last weapon. So what we're really talking about is this bit at the bottom here. And I suppose to use an English phrase, are we looking at 2B evidence or not 2B? It's a bit weak, sorry. It's not my best argument, but that's the question. But I'll come back to maybe rephrasing that later. And it's interesting that Nazareno was looking at, potentially changing the recommendation level, because I think that really that's quite important in terms of looking at the data we have. So you're faced with a patient who is low intermediate risk. You put them on dual oral combination therapy and they're sitting in your clinic. And you're quite happy with where they are, but maybe you could do a little bit more. What do you want for that patient? You want them to feel better, okay? In order to do that, you might want to reduce their symptoms. You want those, whatever you do to have minimal side effects. You can see where this is going. You want them to function better, maybe exercise more, and you want them to live longer. Now, neither of us is here to claim that either of our strategies is going to make a patient live longer, but these are the metrics that you have and the things that the patient is interested in. So let's start with the REPLACE study. And as Nazareno rightfully pointed out, this was an open label study, randomizing patients who are not at goal to switch from PD5 to riociguat or to be maintained. The endpoints are studied at week 24. If we look at the patients going into it, the majority of these patients were already on dual oral therapy and functional class 3, 6-minute walk distance, 370, and a modestly elevated NT-proBNP. And what Nazareno showed was that in terms of hitting the primary endpoint of clinical improvement, this was achieved more often in the riociguat arm than in the PDE5 arm. And there was also this improvement in 6-minute walk, albeit in an open label trial. But clear separation there, I think you can see. And in terms of pure placebo effects, you might expect an increase and a drop-off, but here we're seeing a gradual separation of the curves. And so the improvements were made up largely of 6-minute walk test improvements and functional class improvements, no change in NT-proBNP. But I'm not worried about that, and I'll show you a little bit why a little bit later. There was also this significant time to clinical worsening difference between riociguat and PD5, so potentially building up a nice data set suggesting that switching may be an option for you. Now, if we look at the tolerability of it, excellent, well tolerated, very little difference overall in terms of adverse events between the two arms. I won't read them all out to you, but in terms of things like study discontinuations, et cetera, very little difference between the two. So, in terms of switching to Rio, what do you get? Albeit from an open label study. Feel better? Yes, they improve their functional class. Minimal side effects? Yes. So they function better? Yes. Do they survive more? No, but there is this signal of improved time to clinical worsening. What about adding selexipag? Okay, so we saw this slide from Nazareno looking at patients already on dual oral therapy with a 37% risk reduction in the primary endpoint of morbidity mortality. What we don't see here is the NT-proBNP data. You don't get the 6-minute walk data, but you do get the breakdown of the primary endpoint. And the thing you're really interested in at the bottom from your patient's perspective is time to all-cause death. So neither study shows any difference in time to death. Now, you might be I was thinking to myself yesterday, I'd really like something that was a study that showed what the impact of adding selexipag to somebody who was on stable dual oral therapy, a randomized study, blinded, but where on earth could I find that? I couldn't get anything from Griffin, and then I remembered this awesome study with this amazing first author and some pretty good characters there in the middle who are sitting here right in front of me now. This is a randomized study with a primary endpoint of actigraphy, with the intervention being selexipag. So prospective, multi-center, double-blind, placebo-controlled, phase 4 study looking at activity and quality of life. So the patients who went into this, the large majority of them were on dual oral combination therapy already, predominantly ERA and PD5, so nearly 100%, and about 60+% of these patients only had 0 to 1 or 2 low-risk criteria. So looking at a fairly similar population to the question that's being asked here. About 100 patients randomized with secondary endpoints of 6-minute walk, NT-proBNP, and functional class. Now, one of the things to notice is on the selexipag arm, there was a 17% discontinuation of treatment related to patient choice, AEs, and physician decisions, and fewer on the placebo side. If we look at the primary endpoint, not really a point for discussion today because we don't have comparative data with riociguat, but there was no difference between the two arms. If we then look at quality of life, no difference between the two arms. If we look at 6-minute walk, no difference between the two arms. If we look at NT-proBNP, no difference between the two arms. If we look at functional class, a bit cracked record here, aren't I? No difference between the two arms. Adverse events, well, okay, finally there's something different here. So we're looking at frequent events, more than 10% treatment emergent events, and there are differences across the board. Quite a lot in placebo, which is of interest, but quite significant differences when you run your eye down that selexipag column. And study discontinuations, as I've already said, 15% versus 2% study discontinuations due to AEs. So, what do we think of adding using the TRACE data? Nice randomized study. Do they feel better? No. Do they have minimal side effects? No. Do they exercise more? No. Thank you, you get the gist. Do they survive longer? No, but Griffin did show that primary endpoint, of course, and I have to acknowledge that. So finally, to be or not to be, should that be the question, or should it be 2A or not 2A? Now, okay, Nazareno and I have now kind of completely diverged. Replace was open label, so 2B, I agree. But in a study where you've got this quite long up titration process with quite a lot of symptoms while you're getting up to top dose, I would argue that maybe the blinding bit is not quite so obvious that the physician and the patient were blinded. So I think that last slide of Nazareno is really important to ask ourselves the question about whether or not it was a truly blinded study. So my final slide is just putting those two things up really side by side and saying, you see your patient, what do you want for them? Do you want them to feel better, minimal side effects, function better, and to live longer? So which are you going to choose? Thank you very much.
Thank you, Lou, so much. I mean, you made your points too. So I think Naz asked for a rebuttal, but he has also slides for that. So he prepared some slides for rebuttal. Yeah, sure. So you can go later on to the podium and answer.
Actually, it's not a new one. It's the last slide I presented. You see it?
Well, 1 second, please. Just 1 second. The slides will be up in a minute.
Okay.
Yep. Yeah, go ahead, please.
Okay, so as the discussion is becoming scientifically very complicated, I asked the support of the famous scientist Benjamin Franklin. Benjamin Franklin has been credited as being the first to use blinding in a scientific experiment. He blindfolded participants so they would not know when he was applying mesmerism. This is a popular healing fluid, very popular at 18th century. And in so doing, showed that mesmerism was a sham. Based on this experiment, the scientific community recognized the power of blinding to reduce bias, and it has remained a commonly used strategy in the scientific experiment. Why I'm outlining this? Because it's obvious that if we have well-organized studies with appropriate follow-up, you got very strong endpoints like morbidity and mortality or outcome, like for the Griffon study and the study with the oral treprostinil. It's very important that we are in some way on the appropriate scientific drug development, because otherwise when you have studies which are not performed in the right way, we don't find the solution. We may say that this is statistically significant, but at the end of the day, the advantage for the patients is limited. Thank you.
You have 1 minute if you want to say something, and then we'll open for discussion.
I graciously give this residual minute to my opponent.
So thank you very much for giving me the opportunity for rebuttal. Unfortunately, they wouldn't let me take the sword away. That's all I've got. I put everything in there. I've got nothing else to say. Thank you. I give it my best shot.
Thank you. Thank you so much. I think now we'll vote. We'll see who actually won. So for those who think that we should add a medication for this particular group, raise your hand, please. Okay. And for those who think that we should switch to Raisiguat, raise your hand, please. Yeah, I mean, you have to, guys. What do you think? Second? Yeah, okay. I'm sorry, Naz. I think Luke won this time. Good luck next time. Great.
Okay.
I think we had a very good session. We took about 10 minutes from the break, which is 30 minutes. We have a time for 2 questions, maybe max. If somebody has a burning question, I think Abdullah, you do? Go ahead, please.
Very much, very nice topics. My question regarding the management of Group 2. So a few years ago, Victoria trial was published in New England, and basically it tested Vari-Ciguat, which is quote unquote a cousin of Rio-Ciguat, in patients with mildly reduced LV function. And compared with placebo, after 10 months, it showed positive outcomes. The composite endpoint was positive, mainly reduced hospitalization and cardiovascular death. So my question is, are we looking at different things? That's why we're not seeing this from a pH perspective. What do you think the reason and rationale behind these findings? Thank you.
Well, thank you very much for your question. I didn't mention the heart failure trials using pH pathways, but you're right, Victoria was a positive trial. Now, I'm sure you've noticed that the population in Victoria was very peculiar in the way that there were patients with advanced heart failure who were included, and in most countries, Vari-Ciguat is available for patients who had intractable left heart disease. We do not know if those patients had pulmonary hypertension or not, but what we know for a fact is that for the treatment of the underlying disorder, this drug may have some effect to reduce the risk of hospitalization, but had no change in mortality, and there were very limited changes in other ancillary tests. There was decrease in NT-proBNP. So we're looking at two different things, or perhaps at two sides of a coin. One is the left ventricular function, and the other one is pulmonary vascular disease. There's probably something happening in those patients who really develop a precapillary component that is different from the others. We haven't picked up exactly what makes those patients being different than, let's say, the common heart failure patients. Perhaps they are younger, perhaps they have more lung disease, perhaps they have CTEPH. We haven't sorted that out yet. But I agree with you, this is giving a very different direction as opposed to what we do when we want to specifically target pulmonary hypertension in the context of left heart disease.
Yes, I have a question, Dr. Jean-Luc. I need your advice regarding when we look at patients who develop pulmonary hypertension secondary to left heart disease. They might look the same, but they present differently. Acute heart failure, secondary post-viral myocarditis, post-MI, whatever, and acute valvular, compared to somebody who's been having HFpEF. HFpEF has been diagnosed way late in the they've been going on around, lingering in the system until somebody. So the chances of them developing post-capillary, is it much higher compared to that? And because you treat them with diuretics, PA pressure goes immediately down, but doctors treat those HFpEF patients with diuretics, MRA, SGLT2, you have a modest reduction in the PA. So would you shed some light, please, on this?
Yeah, thank you very much. This is a very good question. And that, again, highlights that the real trigger for one of the main triggers for the increase in PA pressure is the increase in left atrial pressure. So that's the overarching mechanism. Then some patients derail and go on, pulmonary vascular disease or remodeling, whatever, despite the fact that you attempted to continuously or in a sustained way to reduce left atrial pressure. But the counterexample is, I like the example of left ventricular assist device, because even if patients at time of implant have pulmonary hypertension, you put an LVAD, the problem is not the pulmonary circulation, the problem is the left ventricle. And yeah, exactly, you suck it and then immediately you bring the pressures down, and pulmonary hypertension disappears. There's no remodeling. There may be vasoconstriction, but there's no remodeling. So I think within this group, there probably is a different phenotype of patients who are maybe common with the IPH.
So if I can just say something, again, in response to this, Jean-Luc and Roxana, I'm going to talk about those patients who have really combined pre and post capillary, and those who have very severe PH group 3. Are we really, or do you think that should be reclassified as PH with comorbidities? I mean, in the way that we're talking about a disease, that it has a lot of high PVR, there's a lot of changes at the precapillary level, but we're still putting them into really group 2 and group 3, although the treatment is different, the behavior is different, and the outcome is different. So are we misclassifying those patients? So I'll start with you, Roxana.
I don't think there is an easy answer, but I do think when comparator data was published, one of the things that was notable on when you look at patient characteristics is that there were actually very few people who had CAT scans. In Aspire, there were actually no CAT scans. In Compare, I think it was about 40%, and please correct me if I'm wrong. So I think when we look at that IPH lung phenotype, we have no idea who those patients are. And pulmonary, you take patients with scleroderma, they have FVC of 80%. Do you know how many of them have ILD? Like tons. Again, the pulmonary function tests only get you that far. I think in the future, looking at parenchyma with high-resolution CT scans has to be a part of trying to phenotype patients. Until then, I don't know.
Thank you. Well, this has been a very engaging and exciting session. Thanks to all the esteemed guests and presenters. We will adjourn and rejoin at 3:30. We already took some time, and it's going to be very exciting live cases, and we hope to see everybody here again. Thank you very much.
السلام عليكم. بسم الله الرحمن الرحيم والصلاة على المرسلين سيدنا محمد أجمعين. Welcome to the last session of today for the Saudi Pulmonary Hypertension Society. My name is Hatem Qutb. I'm a consultant intensivist pulmonologist at Imam Abdurrahman bin Faisal University in Dammam, King Fahd Teaching Hospital. I'm honored to share this session with my dear colleagues and sisters, Dr. Nawal Qusaybi. She is a consultant pulmonologist, pulmonary hypertension specialist, head of pulmonary division in King Fahd Medical Military Hospital here in Tehran. I would like to welcome you in Al-Khubar. I hope you enjoyed it. All the cities and the kingdom are beautiful, and we are very happy to host this time the meeting here. I would like to just start with a little introduction. I was honored to be a member of this society for the last 16 years. I published it. So I think it is very important, please, when you have a case which is found unique or it is really a few in the literature, take the urge and be honored to present it, that this is what presented in this society and now presented as a literature. And this is how the knowledge should be carried on. Needless to say, al-ulama warathat al-anbiya. So this is something that is very important to keep your knowledge and science on a profession like pulmonary and pulmonary hypertension. So without taking much of time, I will ask Dr. Anwar kindly to present the first speaker.
So now we are pleasure to present Dr. Ahmed Krimli. He's a Saudi national treasure, really. He's not only an adult cardiologist, he's an adult interventional cardiologist. He's also specialized in adult congenital heart diseases and pulmonary hypertension. And he is going to give us this talk about an interesting case. Go ahead, Dr. Ahmed. Thank you.
Bismillah ar-Rahman ar-Rahim. Salatu wassalam ala Rasulillah. So I have a very simple message. Right heart. So obviously this simple message is like selling water في حارة السقايين, or sending a call to Newcastle, for example. If you're from UK, you'll understand what I'm saying. But so right heart cath is a must, and it's easy. And you don't have to have a major reason or extremely difficult decision to make a decision to send the patient for right heart cath. So you should have a low threshold for right heart cath. So this is a case for about a 58-year-old gentleman presented to our ER with shortness of breath and generalized body swelling. He was just discharged 1 day ago from another hospital where he was admitted for more than 1 month because of similar issue. He was labeled with past medical history of rheumatic mitral stenosis, dilated right heart with presence of PFO based on a very old TEE. So that tells you that he's been undergoing evaluation for a quite long time, and ejection fraction was normal, according to his report. These are the list of his medication. He's in good dose of diuretics, furosemide, spironolactone, metalazone, and somebody put isosorbide dinitrate, indicating that could be coronary disease, and bisoprolol because of atrial fibrillation. So in ER presentation, blood pressure was on the soft side. He was tachycardic with a heart rate almost 160, and atrial fibrillation rhythm, and clearly he was in respiratory distress with clinical evidence of heart failure based on raised JVP, bilateral crackles, significant lower limb edema, and abdomen exam showed ascites with pulsating liver. So you know where I'm going with this. So anyhow, so the lab work showed an elevated BNP of 2,500, creatinine is 180, normal WBC count, trop was negative, and hemoglobin is 15 or was 15. ABG, pH, it was almost okay, 7.44, PCO2 36, PO2 75, and bicarb 24. Chest X-ray was reported to have cardiomegaly with associated pulmonary congestions and enlarged bilateral hila, and mild to moderate left pleural effusion. So he was managed with IV diuresis, and with that little bit drop in his blood pressure, which was soft to start with, and he was starting epinephrine infusion, and for his ventilatory support, he was put on BiPAP. Down the course of 10 days, he lost 12 liters, negative. That's negative balance. So without worsening of renal function. Actually, after a few days of diuresis, he came with creatinine of 180, it went down to baseline or normal. We don't have baseline for him because he's new for us, but went back down to normal in the 70s. This is his echo to show you the echo. And
you can appreciate the rheumatic mitral valve. This is okay, and how this is the right ventricle compressing the left ventricle. You can appreciate the flattened septum and very dilated or significantly dilated right ventricle, and you can appreciate that in the apical view with a huge right ventricle, huge right atrium, and very compressed left ventricle because of the size of and the pressure on the right ventricle. And this is to show you the significant TR comes with his dilated right ventricle. And again, just to show you the compressed. And this is the echo showed significant RVSP in the 63 RVSP. And if you add that 15 on top of that, so his RVSP is actually in the range of 80. Or systolic pulmonary artery systolic pressure is in the range of 80s. And this is to show you the mitral stenosis. So the mitral stenosis was reported here to be mean gradient of 5 millimeter mercury. So a small LV cavity with an ejection fraction around 45 to 50, D-shaped septum, a severely dilated right ventricle with moderate to severe RV systolic dysfunction, moderate mitral stenosis, and calculated mitral valve area, or the mitral valve area was traced to 1.5 centimeters square, or by pressure half time to be 1.8 square centimeter. Severe TR, severe pulmonary hypertension, and small pericardial effusion. So despite his multiple comorbidities, coronary angiogram was done and it was unremarkable. So he underwent right heart cath, which showed an RA pressure of 26, right RV pressure of 103, PA pressure of 97/44 with a mean of 64, wedge pressure of 36 and LVDP of 33, blood pressure, systolic blood pressure of 118/71/81. So just reading this, you'll assume the diagnosis of mitral stenosis, left heart disease causing pulmonary hypertension, obviously. So then comes this. And unfortunately, this is not an interactive session. However, you can appreciate that his SVC saturation is 56, and there is a significant step up of oxygen in the right atrium to be 82, and PA pulmonary artery saturation is 78, and aortic saturation is 99 on room air. PVR was calculated at 4 Woods units. QP was calculated at 7.8, and QS was calculated at 37, gives you QP QS 2 to 1. So the question is, what does he have? Simply, everybody will say this is case of ASD. True, not true. So this is his cardiac CT. Obviously, the diagnosis, we got it in the cath, but unfortunately, we don't have the diagnosis in the cath, images in the cath. So this is a CT. So basically, if you bear with me, this is, okay, when I need to stop it, but okay, it does not stop. So this is the SVC, sorry. So this is a pulmonary vein connecting to the right atrium, basically. So here has basically two upper pulmonary vein connected to the right atrium. And there is, you can appreciate once it comes back, over here, it has significant sinus venosus atrial septal defects. So this was cardiac CT, although the diagnosis was apparent from the cath pulmonary or SVC angiography. So two right superior pulmonary vein join and drain into SVC just superior to the cavo-atrial junction associated with large sinus venosus atrial septal defects. So basically, the significant pulmonary hypertension and RV failure in this patient is exacerbated by the presence of left side disease, and this is mentioned in Dr. Majdi lecture about comorbidities, why this patient has his SVC or anomalous pulmonary venous connection with sinus venosus led to significant RV failure and significant pulmonary hypertension, obviously because of the age and the presence of comorbidities. So what does the guidelines say about how to manage these patients? Basically, the guidelines talking about atrial septal defects, and they don't really, although they appreciate, they tells you that if the patient has gradient or PVR less than 5 Woods units, you can carry on with closure of the atrial septal defects. But however, this is mainly concentrating on simple secondary ASD and not really concentrating on such patients who is more complex patients, led to RV failure, severe TR, and he has mitral stenosis to start with too. So, and we know that patients with pulmonary hypertension secondary to sinus venosus, they're a little bit different from the usual secondary ASD. First of all, pulmonary hypertension present more with such patients, and raised PVR was noticed more with, for example, in this study, around 140 patients, noticed 16% of them will have high PVR compared to only 4% with secondary ASD. So usually these patients are, when they're sick, they're usually sicker than the rest of the other type of atrial septal defects. And they usually develop these complications at younger age, which been going on with this patient. He's been suffering for the last 10 years and underwent multiple evaluations, but nobody did the right diagnosis for him, although as I showed you, he underwent TEE, which showed the PFO. I'm not sure about what kind of PFO they're talking about. However, it was a simple diagnosis of right heart cath. Just when you see a step up, you will understand the anatomy. You did an angiogram, pulmonary angiogram, it was easy, and the cardiac CT, it was an easy diagnosis, actually. So they should be managed differently than patients with simple atrial septal defects. So our patient, because of the high filling pressure and the moderate MS, pulmonary vasodilator was not started. It's considered, but it's not started yet. He's being considered for corrective surgery. Imagine now patient with significant RV failure or dysfunction, undergoing 3 major surgery. You need to correct, or 4 major surgery. You need to correct the direction of the pulmonary vein into the left atrium, close the sinus venosus, repair the tricuspid valve, and do something with valvotomy or something with the mitral stenosis. Extremely big surgery for such sick patients. So unfortunately, he was not accurately diagnosed or managed despite long time of suffering, since his case was assumed to be pulmonary hypertension secondary to left heart disease. At the moment, the risk of corrective surgery is high and could be avoided if he was diagnosed earlier. It's important to have a very low threshold for right heart cath, especially if the RV, right ventricle, is affected. And unfortunately, again, this is not a new story. So this is a center showed that tertiary centers taking care of all the referral for a region for pulmonary hypertension. And you can appreciate that one third of the patients referred to PH center were initially misdiagnosed, leading to inappropriate treatment. However, from these patients, 59 patients underwent catheterization of the right or left side of the heart for the first time at the tertiary center. So basically, many centers start or diagnose patients with pulmonary hypertension without doing right heart cath to start with. And it's not, unfortunately, still, since 2013, we're talking about it. And again, in 2023, we're still talking about it. So right heart cath carries low complication and mortality rates. And this is just to show you about after almost 7,000 or more than 7,000 right heart cath in 15 centers in US and Europe, major complications around 1%. And for that reason, I usually have very low threshold of right heart cath, even if I have the diagnosis. Majority of, you understand that pulmonary hypertension is the number 1 cause, it's left heart disease, I understand that. However, any patient referred for right heart cath, I don't argue, I think it's a low, I have a very low threshold for right heart cath for such reasons, and obviously to make the life of my respiratory colleague much easier. Thank you very much.
Thank you, Dr. Ahmed. I think this talk illustrated the importance of right heart cath and why it's recommended, and it's not enough just to do echo and diagnose pulmonary hypertension, as there is more than that as a rule for right heart cath. Are there any questions from the audience? Yes.
Turn it on, I'm sorry. Thank you for this interesting case. Maybe you can tell the audience about the situation for closure, what is in the guidelines and what the resistance was. This was a dramatic pulmonary hypertension case with a very big pulmonary artery. I would have actually looked for a left main compression in this man, but maybe explain to the audience that how you justify surgery and point out to them that it's possible still.
Okay, so my slide was left actually. So basically, we have different strategy for such patients. All of the guidelines, when they indicate you still have a room for closure when they have elevated pulmonary pressure or pulmonary vascular resistance in secondary to atrial septal defects or other defects, shunt lesion, they're talking about sort of straightforward patient with no significant right failure or right dysfunction, RV dysfunction or other comorbidities. So for example, although the data is not great and usually the samples are small, but is almost agreeable number. There's Woods units of pulmonary vascular resistance of 5. And or the shunts are still, the patient has significant left to right shunts, indicating that, and is not hypoxic, etc., indicating that by closing the ASD or the shunt in general, that you are going to avoid progression and you will have no residual pulmonary hypertension and it will be resolved or semi-resolved after closure. However, there is another thing which is treat and close, which is another approach, but again, there is no strong data like randomized controlled trial for it. Like, for example, treat such patients, then to see improvement in their clinical data. Later on, you can, after 1 year or so, the patient can undergo permanent closure. So this is in general how we advise for such patients, provided that they are doing well. But as I'm saying, for such patients, it's a huge surgery, and we're discussing with the patients better approach, and we think down the road, I think if he's improved with diuresis, and we're considering starting him after improving his left side pressure, we're going to start him on pulmonary vascular treatment. We can offer him surgery despite the very high risk for such surgery.
Dr. Ahmed, I have a question here.
Okay.
Yeah. Thank you very much. Your last statement mentioning that you have to have, as a cardiologist, low threshold for doing right cath. Reality is not true. It's not really often we find it easy in different hospitals. Number one. Number two, not every hospital they have right cath facility. So looking at this poor lady, if she comes, what would be the advice being a congenital heart disease specialist? What would be your advice for general physician and the fellows when a patient comes to them, let's say, 10 years from now? I mean, without doing the echo, without doing the CT scan for both for MRI and the pulmonary angio, wouldn't really diagnose, and despite that have been doing an echo frequently. So it will be the clinical hitch which you want to give to the fellows in order to see such case where you think, I think I should refer her to place center where they can do 1, 2, 3, 4.
I totally agree. So each center, obviously, I don't know why. Personally, I don't do this, but I don't know why there is some resistance from cardiologists or intervention cardiologists to perform right heart cath. It's an easy procedure in my mind, obviously. Yes, we have comorbidities, we have obese patients, I'm not making it very simple, but the outcome or the results are great in my mind, actually. And from time to time, you pick up such cases and you see this patient has been suffering for the last 10, 15 years with no diagnosis. It's been just received diuresis and they assumed it's because of his smoking and the left heart disease and mitral stenosis. Although mitral stenosis, as I showed you, it's moderate. And even nobody tried to treat the mitral stenosis, so because everybody think it's moderate, but again, so he came up with this. So at the end, what I can advise, if you find one cardiologist, you can convince him to partner with you. This is a ultimatum, actually. So I think this should be, and you cannot call yourself a pulmonary hypertension if you don't have an easy access, not if you don't have access to right heart cath. If you don't have an easy access, you cannot call yourself or to have right heart pulmonary hypertensive service, especially when you know that we're not talking about diagnosis. So for right heart cath, for pulmonary arterial hypertension, we are repeating. For this is one of the reasons for escalating.
At King Faisal Specialty Hospital, Riyadh, he'll be presenting to us a case of PVOD, pulmonary arterial hypertension, and what is the whole treatment spectrum. Dr. Lay, the floor is yours. Tfadal.
Assalamu alaikum. Let me figure this out just a second. Perfect. Okay. Assalamu alaikum. My name is Loy Izzat. Thank you for the kind introduction. First of all, let me start by thanking the organizing committee for the outstanding conference so far. And let me also say that it's truly a pleasure to be presenting here in front of this great audience, in front of experts in the field, and in front of one of my personal mentors, Dr. Dalan. So moving on to the presentation. We already know from the title that this patient has PVOD. So I won't be going into great detail on how we diagnose it. What I will try to do is to take you through the journey of this patient from the time he was referred to our center until his treatment. So this is a 30-year-old Saudi male who has complained of shortness of breath on exertion for 12 to 18 months prior to presenting to our hospital. This was also associated with occasional presyncope, palpitations, and chest pain. He had bilateral lower limb swelling. His symptoms were progressive in nature. He is an ex-smoker. He stopped 2 years prior to presentation, and he has family history positive for pulmonary hypertension. So on examination, he looked well. His saturation was 94% on room air. He had clear chest on auscultation. His heart sounds were audible. He had a loud P2. He had an elevated JVP and had bilateral lower limb swelling as well. So we first saw this patient in 2015, and at that point he had already been through the initial evaluation and was labeled as pulmonary arterial hypertension, and this was outside the kingdom. However, since lines of therapy were available here, he decided to continue therapy back home. So when we saw him, he was already been labeled as PAH and was on monotherapy with sildenafil 20 mg TID and was on diuresis as well. So we decided to repeat the workup since we did not have access to it. So first of all, starting by the echocardiography, he had a low normal left ejection fraction of 50 to 55%. He had a severely dilated right ventricle, moderately hypertrophied, and severely reduced right ventricular function. His RVSP was around 60. He had a normal left atrium. He had severely dilated right atrium and a small pericardial effusion as well. So this is just a quick picture of his echo, and I think we can clearly see a small rim of pericardial effusion. We can also see how severely dilated the right atrium is and how reduced the right ventricular function is as well. So moving from the echo to his CT scan, and I'll go through the images from the top left. You can see the arrows pointing at a mildly enlarged mediastinal the mildly enlarged mediastinal lymph nodes. Looking at the second image, we can appreciate how dilated the main pulmonary artery is, and the ratio here is almost 2 to 1. And in the last image, we can also appreciate the pericardial effusion, and we can also appreciate how enlarged the heart chambers are. Now looking at the bottom row, we can also, looking at the parenchymal windows, I have some squares illustrating some of the findings. So we can appreciate some septal thickening, and we can appreciate ground glass opacities as well. So his parameters for pulmonary hypertension were as follows. His pro-BNP was 813. His 6-minute walk test, he had a saturation 94% prior to testing. He was able to walk a decent distance of 402 meters. However, he did have significant desaturation at the end of the test to 82%, and his Borg scale was 2. A right heart cath was done for him, confirming the diagnosis of pre-capillary pulmonary hypertension. We can see that the mean right atrial pressure was 28. The mean pulmonary artery pressure was 52. His wedge pressure was 13. His PVR was significantly elevated at 11.8. His cardiac index and cardiac output as well were severely reduced, and his PA saturation was severely reduced at 46% as well. So our impression after the initial workup, definitely high risk group 1 pulmonary hypertension. We considered that this may be PVOD, so we said he probably has PVOD. We definitely continued with sildenafil 20 milligram TID. We adjusted diuresis as necessary. And now we go to the difficult questions. Since we are entertaining the possibility of PVOD, will we add second-line therapy, dual therapy by adding macitentan? Will you consider parenteral therapy, given that he is high risk now? Will you refer him for lung transplant, since we are considering that he is PVOD? So what we did initially is adding macitentan 10 milligrams, so we kept him on dual therapy. And I'll discuss the prostacyclin and lung transplant in a bit. So the first 2 years after reaching the diagnosis and on dual therapy went very smoothly for him. He improved from functional class 3 to functional class 2. He remained clinically well, and we referred him to lung transplant. He was tolerating the medications very well. 2017 is where he started to have some progression of his symptoms. It was definitely gradual, but there was definite progression. He had a reduction in his functional class as well, given that he was declining on dual therapy, we discussed with him the possibility of starting parenteral therapy. However, starting a patient on parenteral therapy who has probable PVOD is always risky. This is why we had a long discussion with him on whether or not to start it. We explained the possible risk factors, including the possible pulmonary edema, and he preferred not to start it, at least at the moment. We did, however, add selexipag, so we kept him on triple oral therapy. However, he had significant headache and could not tolerate the medication. So back to dual therapy. With time, he became oxygen dependent, and what was initially a doubt was now confirmed by genetic testing. So he definitely has PVOD when we saw the genetic testing. At this point in 2022, he had completed his lung transplant workup. However, he had not been listed yet. So just to show you how progressive his disease is, this is an X-ray from 2022, and you can appreciate how enlarged the heart chambers are, and one would wonder what happened to that small pericardial effusion that we saw in 2015. His repeat echo in 2022 again revealed a low normal left ventricular size and function. The right side was, as we expect, severely dilated and severely reduced function. RVSP increased as well. Left atrium again normal, right atrium again severely reduced, and the pericardial effusion, which was once small, is now large. And I'm sure you can appreciate the pericardial effusion, which is circumferential and quite large in the image. Again, we can appreciate the same findings, but more severe and more pronounced in this image, showing the severely dilated right atrium and severely reduced RV function. So what about the other parameters? So his pro-BNP at this point was 4,500. His 6-minute walk test showed significant deterioration. And at this point, he was already on long-term oxygen therapy. He was only able to walk 107 meters. He had significant desaturation, and his Borg scale at the end of the test was 9. So a repeat right heart cath was done, again showing progression in all parameters. His mean pulmonary artery pressure is now 57, his PVR is 17, his cardiac index and output were severely reduced, and his wedge pressure was elevated. So at follow-up, in late 2022, he developed severe right-side heart failure, and we had to admit him for intravenous diuresis. At that point, he had also developed new onset atrial fibrillation, and his functional class had declined quite significantly. It was functional class 4 at this point. Of course, we started him on intravenous diuresis with some symptomatic improvement. At this point, he was already listed for lung transplant and was actually prioritized in the list. So at this point, the only other option is to consider starting him on parenteral therapy. So we discussed the risks and benefits with him again, given the recent decline, and he eventually agreed to start a trial of treprostinil parenterally as a bridge to lung transplant. So he was already admitted, we inserted a PICC line, and we started treprostinil infusion. And we started him on a very low dose of 2 nanogram per kilogram per minute. And not surprisingly, he developed significant tachypnea, shortness of breath, and an increase in oxygen requirement less than an hour after. He looked clinically ill, he was in distress, and therefore we immediately stopped the treprostinil, and a follow-up X-ray revealed worsening interstitial markings. So at this point, there is no solution other than lung transplant, and thankfully, a few days later, during the same admission, he underwent bilateral lung transplantation. He was started on veno-arterial ECMO prior to induction of anesthesia. The surgery was not complicated, apart from some blood loss. The pericardial effusion, which we were seeing on the imaging, was evacuated and was estimated to be 2 liters. So on arrival to ICU after the surgery, he was on veno-arterial ECMO, he was on norepinephrine, epinephrine, milrinone, and inhaled nitric oxide. And as any of you could imagine, the immediate post-operative period was quite critical. However, thankfully, vasopressors were gradually weaned off, followed by nitric oxide. He had frequent echoes during this period. Most of them were transesophageal echoes, which showed an improvement in the RV size and function, and the LV was also still working well. And he was eventually decannulated from ECMO at day 6. So echocardiography after decannulation from ECMO again showed the low normal left ejection fraction. RVSP still elevated, but definitely better. The right ventricle still dilated and still reduced function, but definitely better than where we were prior to transplant. So as we all know, transplant does not come without its own complications. He had a few infections. He had ventilator-associated pneumonia with resistant organisms. He had serratia and stenotrophomonas, both of which were thankfully treated. He actually also, on his bronchoalveolar lavage, which was done for surveillance, he was positive for Mycobacterium tuberculosis by PCR, and this is probably from the donor lungs. And he was treated with antituberculous therapy. He developed significant critical illness neuropathy, which was improving. Eventually, after a very long admission, he was discharged around 4 months later on room air. And if there is one thing that I'll highlight from this slide is the importance of the multidisciplinary approach, starting from the pulmonary hypertension team prior to transplant, our surgical team during the surgery, the transplant team post-operatively, of course, our colleagues in critical care. He was definitely not an easy case to deal with. Physical therapy, infectious diseases, and other services were also involved. And before I go to my keynote, to my messages, before I end, I'd like to show you the explanted lung pathology. So this is another way to confirm the diagnosis of PVOD. So in this image here, what we can see is one of the pulmonary arteries, and we can see how significantly thickened it is. This is not specific for PVOD. This is typical for pulmonary arterial hypertension, regardless of etiology. But what is specific for PVOD is what we see in this slide. So what we can see in this area here is the septal pulmonary venules, and we can see how thickened they are and fibrotic they are. And this is classical for PVOD. Another classical sign is an organized thrombus in the pulmonary artery, which we can see in this image here. So take-home messages from this case. So PVOD is currently considered as a subgroup of pulmonary hypertension. It's currently in the recent guidelines under pulmonary arterial hypertension 1.5. It's labeled as PAH with features of venous capillary involvement. Diagnosing PVOD might be difficult. It needs a combination of clinical, radiological findings and other ancillary testing, including ABGs showing significant hypoxemia, PFTs showing a low DLCO, genetic testing as well. Lung biopsy is very hazardous and is currently not recommended for PVOD. There is no consensus on targeted therapy, and if used, it should really be used with extreme caution and only in centers with extensive experience. And transplant referral is currently indicated at the time of diagnosis, since it is considered a subgroup of pulmonary hypertension with high-risk features. Another important point to mention is that PVOD is truly a spectrum. So patients will respond differently to targeted therapy based on the degree of precapillary involvement. Patients with a large precapillary component will benefit from targeted therapy. The literature suggests that the average time from diagnosis to transplant or death is 12 months. There are reported cases of patients living more than 10 years on targeted therapy. The patient we presented here had survived 7 years on dual therapy, but eventually progressed. And finally, lung transplant is the final and only effective therapy. Thank you so much, and I'm happy to answer any questions.
Thank you, Dr. Loay, for this excellent presentation. We really applaud you, and thank you for sharing this case. And we applaud the team who worked with you in managing this case. PVOD is a really challenging pulmonary hypertension disease, and as you have correctly mentioned, that it has a poor prognosis and poor response to target therapy, and you have illustrated the importance of multidisciplinary approach. Thank you for that, and if the audience has any questions.
For this very good reminder of PVOD. Did you do a perfusion scintigram?
VQ scan?
Yeah.
It was done in the initial evaluation, yes.
What was it like?
I could not mention all the testing we've done for this patient.
No, of course, but it's interesting because it looks like CTEPH, right?
It did
Many
look,
times, but not always.
The actual report was suggestive of CTEPH. However, we do have some of our radiologists who are expert in CTEPH, and after discussing the image and doing a CT angiography showing no PE, we decided that it was very unlikely that it is CTEPH. But the VQ scan was suggestive of CTEPH, absolutely.
Would be great to show for teaching.
Sure.
So I have an Inspector Colombo question. What was the time between the PIC catheter and the start of treprostinil?
Between what, sorry?
The insertion of the PIC and start of treprostinil.
The PIC line was inserted to start treprostinil, so it was...
Yes, but what was the delay between the surgery and the start of the treatment?
Between inserting the PIC line?
Yes, and this actual start of treprostinil.
There was no delay. He was started
That's
immediately
the problem.
after PIC line.
This is why I think you had the... maybe we involve Olivier. Is it likely, if you were a judge, that within 30 minutes of 2 nanograms per kilogram and minute treprostinil, you get pulmonary edema in a PVOD patient? I think it's impossible. But I think it's because you did the PIC. He was very ill, and I think this even minor surgery may have thrown him off. This is what I think. But you tell us what happened. It was a 30 minutes, 2 nanogram per kilo treprostinil. Is it likely to cause pulmonary edema?
No,
I don't think so.
I think pulmonary edema is due to maybe to the combination of all the drugs, because he was treated with 2 oral drugs plus IV treprostinil, and probably the combination of all the drugs.
So he was on dual therapy at the moment.
And this may induce quite rapid pulmonary, but 15 minutes or 30 minutes, we saw that with calcium antagonists, because some of those patients, they may respond to nitric oxide. It is potentially a mistake to consider that some of those patients are acute responders, and to give calcium antagonists in those patients, in that case you can have a dramatic pulmonary edema. But I agree, with 2 nanograms it seems very low dose.
What I'd like to point out is when patients are very ill, even the minor PIC implantation throws them off, you know, and it's very hard to make any judgments after this, what was the reason. So I just wanted to point that out.
Well taken, thank you.
Thank you. I think Luai has summarized a story for a man who has been with a complicated course for many years. So we had this man since 2015, and for 8 years, this patient was managed what we think appropriately. But for this point, patient can actually develop acute pulmonary embolism with vasodilator therapy, even with calcium channel blocker, and maybe immediately. But this patient had been on dual therapy, and he was just coming out from a stressful procedure, and then he had to the 2 nanograms, and there was a hesitation actually to start him on treprostinil to start with. So when he developed the pulmonary edema, whether it was related to the 2 nanograms or not related or additive effect, at that time it did not matter to us, so we stopped it, and the patient was already on the transplant list anyhow. Thank you.
Thank you, Dr. Dalal. We can proceed for the next case, please.
So Dr. Dalal Lanisi, he's a fellow in the Saudi board program for pulmonary medicine. He is presenting a case of connective tissue disease associated pulmonary hypertension. Go ahead, doctor.
Assalamu alaikum. Good afternoon, everybody. Glad to be here today to present this challenging case. This case is about a 67 years old lady complaining of progressive course of exertional dyspnea. On February 2021, she presented to our clinic complaining of progressive exertional dyspnea for 1 year. It was slowly progressing over this time, and it was defined according to WHO function class as class 4 upon her presentation. Her symptoms was associated with orthopnea, and she had palpitation and chest pain on moderate exertion too. She had history of finger discoloration to white, blue, and red, which is typical to Raynaud's phenomenon. She had history of facial rash. She lost her appetite and some weight too. She denies any history of cough, hemoptysis, wheezes, no paroxysmal nocturnal dyspnea, lower limb swelling, or syncopal attack, no fever or night sweat, no symptoms suggestive of rheumatological disease like joint pain or genital ulcers, no history of bleeding or thromboembolic disease, and no history of cardiac or lung diseases too. Her past medical history is hypothyroidism controlled on levothyroxine 50 mic, and past surgical history of left kidney resection 20 years ago for unknown reason. Socially, she is retired, lives in Riyadh, active history of secondhand smoking. She has a family history of SLE in her nephew, and no history of allergy. On examination, vitally temperature was 36.7, heart rate normal, borderline blood pressure. She was tachypneic, and she was desaturated in room air to 87%. Conscious and oriented, she presented on wheelchair and not in respiratory distress. On examination, cardiovascular system was normal, JVP not raised, normal first and second heart sound, no lower limb swelling, respiratory system showing normal breathing sound and no added sound. On the skin examination, there was, as we see, around 1 to 2 millimeter discrete red popular telangiectasia on the cheeks, which is going with telangiectasia, and no other oral skin ulcers. Musculoskeletal system, there was normal, no nail abnormality, skin thickening, no joint tenderness or swelling, and no myopathies. On investigation, the CBC and coagulation was within normal limits. The chemistry, the renal function test was normal. Also, the hepatic profile was within normal, and the proBNP was around 1300 picogram. Other investigation also was within normal, including ESR, CRP, CK, and troponin. The autoimmune profile was significant with elevated ANA 1 to 2,560 with homogeneous pattern, and the others was negative. Spirometry was normal with FVC within 85% of predicted, FEV1 90% of predicted. The 6-minute walking test, she was able only to walk for 2 minutes and 35 seconds, and she walked 133 meters, desaturated to 85% in 2 liters. This is her chest X-ray, which was unremarkable at the time, normal cardiac silhouette and clear lung fields. This is the CT chest. It was showing borderline pulmonary trunk compared to the aorta and diffuse mosaic attenuation, which was going with the diagnosis of pulmonary hypertension. Also, this is the VQ scan, which was unremarkable. The echo is showing normal left ventricle size and wall thickness, normal left ventricle function. There was a flattened septum consisting with the RV overload. The right ventricle was mildly to moderately dilated, and also the RV function was mildly to moderately reduced. There was moderate tricuspid regurgitation, and the right ventricle systolic pressure at the time was estimated more than 60 millimeter mercury. There was no pericardial effusion. The right heart cath confirmed the diagnosis of precapillary pulmonary hypertension with the mean pulmonary artery pressure of 43, capillary wedge pressure of 10. The right atrial pressure was 8. The cardiac index was 2, and the cardiac output was around 3.5. The PVR was 9.5 Wood unit. So our impression at that time was severe pulmonary arterial hypertension secondary to autoimmune disease. We elected at that time to start the patient on dual BH targeted therapy with sildenafil 20 milligram TID and macitentan 10 milligram daily. And we referred the patient to the rheumatology to get their assessment, and they labeled the patient as undifferentiated connective tissue disease, giving the presence of elevated ANA, rhinoids, telangiectasia. But there is no clinical evidence warranting initiation of immunosuppressive therapy at that time. So the next follow-up of the patient was on July 21. The patient reported improvement in functional capacity to class 3. proBNP went down to 96, but she reported a frequent episode of epistaxis since she started the sildenafil. Her 6-minute walking test, also she was able to walk to 3 minutes and 45 seconds. She walked for 130 meters and desaturated to 70% on 3 liters. The plan at the time to switch sildenafil to riociguat, giving the history of frequent epistaxis. Next follow-up was in November 21. Her functional capacity was stable at class 3. proBNP went up to 423. There was no sign of right-sided heart failure. On 6-minute walking test, she walked 207, desaturated to 60% on 4 liters. So we discussed at this time with the patient the option to start a parenteral therapy. She refused at that time and preferred oral agent, adding another oral agent, so we initiate Selexipag. 1 month later, on December, she presented to the emergency department complaining of worsening exertional dyspnea, function class 4, increased oxygen requirement to 4 liters, and orthopnea. She stopped Selexipag because she didn't tolerate side effect. Actually, she used 1 or twice. Her pro-BNP went up to 1600. On examination, there was bilateral fine crackles, no lower limb edema. The X-ray was showing bilateral pulmonary edema. The echo was showing severely dilated right ventricle, progressed from the previous one, was in April, and moderate right ventricle systolic dysfunction. RV systolic pressure was estimated to 85 to 90, and she developed a small pericardial effusion. So we discharged the patient after her volume status has been optimized. Selexipag stopped, and we continued her on macitentan and riociguat. Again, we requested rheumatology assessment, as we believe that immunosuppressive therapy may play a role in her management. They're still insisting that there is no evidence warranting initiation of immunosuppressive therapy, but on February 2022, they saw her again, and they prescribed a course of prednisone 40 milligram for 5 days for presumed left-hand pseudogout. After that, she presented to our clinic on March 22, and she reported an improvement in her symptoms after the steroid course. Oxygen requirement has been reduced to 1.5 liters, and functional class improved to class 3 from 4 last time. And based on that, we elect to start her on a trial of a steroid, as we believe that her pulmonary hypertension is CTD related. So over the following 6 months, there was a steady improvement in her condition. Till September 22, she presented to the clinic walking without assistant for the first time. Significant improvement in her functional capacity to class 2. There was no sign of right side heart failure. Pro-BNP went down to 145. On 6-minute walking test, she walked 291 meters, desaturated to 60% on 1 liter. The echo was showing improvement on the right ventricle size from severe to moderate dilatation. There was severe right ventricle systolic dysfunction, and RV systolic pressure was estimated at 50 millimeter mercury and very small pericardial effusion. So this is the pro-BNP trend of the patient. We can see here at this time here where the trial of steroid we began. At the beginning, this is the patient where she presented. She saw an improvement at the beginning, then worsening in her case. Here we start the course of trial of steroid, and we can see the improvement in her BNP afterward. Also, this is 6-minute walking test trend. At the beginning, she was able to walk 133, improved after initiation of duality therapy, then decline in her 6-minute walking test, and here we start the course, the trial of oral steroid. And before I conclude our case, I will just go through pathophysiology of pulmonary arterial hypertension and connective tissue disease. As idiopathic PH, endothelial dysfunction play a key role in the pathogenesis of connective tissue disease, pulmonary arterial hypertension. Impaired production of vasoactive mediators and the increased production of vasoconstrictor and proliferative mediators affect the vascular tone and promote vascular remodeling. There is a growing evidence suggesting that inflammation and autoimmunity may contribute to the onset and progression of pulmonary arterial hypertension, especially in connective tissue disease. Infiltrating macrophage and lymphocyte ANA, rheumatoid factor, and complement have been detected on the pulmonary vessels of patients with connective tissue disease-related pulmonary arterial hypertension. A histopathology study conducted on CTD-BH patient showed a deposit of both immunoglobulins and complement on the pulmonary arterial wall in SLE-related pulmonary hypertension. In undifferentiated connective tissue disease, we were unable to find a literature or case report describing a case of pulmonary hypertension in such entity, but just explaining a little bit, the patient presenting with incomplete expressed rheumatological disease with non-specific autoimmunity designed to have undifferentiated connective tissue disease. The difficulty of making a diagnosis of definitive systemic rheumatological disease is that this patient usually shared several clinical features and serological abnormalities. There will be an evolution from undifferentiated CTD to a definitive rheumatological disease is more common than a resolution. It's estimated around 10 to 35% of these patients will evolve to a definitive connective tissue disease. In one study on 213 patients with early undifferentiated systemic rheumatological disease for at least 1 year, most patients developed lupus at 5 years, and when they described the predictor of evolution to the discrete disease, one of these factors was elevated ANA homogeneous pattern. So in conclusion, we believe that in this case, the pulmonary hypertension is part of a discrete rheumatological disease that will evolve later, but it presented early and preceded the common rheumatological manifestation. Thank you so much.
Thank you, Dr. Talal, for a very nice, complicated case. Any question to Dr. Talal? So can I ask you a particular question? We knew in rheumatological literature that you may have a lab result and then sign might evolve later. And opposite is true. So I wonder, the decision is taken by your team and Prof. Abdullah to start an steroid based on MTD meeting and able to convince him, because one of your slides, they start just by the way, she developed pseudo-gout, let's give her a steroid. Well, this is in reality and legality, it has to be clearly defined. So you take the lead, yourself and the Prof and the team, to start on a steroid. The question will come to you based on what? Number one. Number two, what is your take-off follow-up of this? And number three, were you able to meet with them and show them that since you last showed that the homogeneous ANE was 2,000 plus and it was able to come down? Or the MTD groups, they decided that we need to wait for certain things, for example, resolution of telangiectasia, other symptoms we're suffering from. So I congratulate you for taking the gut to take the decision, but it has to be ready that, mind you, a steroid is not a simple drug, especially for 67 years old lady, which has to be clearly defined when and how and what we're going to continue in the future. So do you have an answer of this? Okay, in discussion with multiple time with rheumatology, they said in undifferentiated connective tissue disease, they may evolve, they may persist, they may resolve, but there is no data supporting the initiation of immunosuppressive in such patient. The decision to start the steroid wasn't based on MDT, but was based on the patient improvement on the course of 5 days course of a steroid. Since then, we start a trial with the patient with a close follow-up after the steroid initiation. She showed a dramatic response to it. For over the 1.5 years she is following with us. For the first time she presented to the clinic without a wheelchair. We give her the benefit of doubt. At that time we elect to start her on immunosuppressive therapy, steroid-sparing therapy.
anything Dr. Abdullah to add يعني
Well said, Talal. Thank you so much. I just wanted to take the burden from your shoulders, but you already answered. So, you know, clinicians have also a sense. They have to use this clinical sense when they see their patients, especially complex patients like this. Remember, this patient has also these atypical telangiectasias. So one of even the differential diagnosis whether this patient has some variant of hereditary hemorrhagic telangiectasia. And this, remember, this patient can be also having pulmonary hypertension. But the fact that she has extremely high ANA level and the fact that she has significant Raynaud phenomenon and skin involvement, to us as a pulmonologist, this is a rheumatological disease. So we had actually consulted them 2 times, and we wanted really to convince them to start some immunotherapy, suppressive therapy for this patient. Because, by the way, in literature, connective tissue disease associated PAH can be also improved in addition to the vasodilator therapy with immunosuppressive medications. So, and they made our life easy because they gave her this 50 milligram 4 or 5 days for pseudogout, and she showed some clinical improvement. So we actually took the best, what we think the best clinical decision for that patient based on knowing her for some time. And to our surprise, the patient next visit, actually Talal brought her back in September, but we saw her actually even closer in the clinic sometime without appointment. She actually for the first time comes to the clinic walking, having no oxygen therapy on, with her, and her proBNP normalized on 40 milligram of prednisone beside her dual pulmonary vasodilator therapy. So, of course, we cannot ignore this, so we continue the course of the steroids. And down the road, we also started, tapering it and putting a steroid-sparing agent. But also remember, this patient is not out of the woods yet. So her 6-minute walk test is only 270 something, and proBNP is still normal, but she is not, she's functional class 2-ish, sometimes 3. She's also not completely normal. She, of course, most likely will need prostanoid therapy. But the reason we brought her up and Talal wanted to present her is just to give you the flavor of how these patients with connective tissue disease can present, and maybe the role of immunosuppressive therapy in these patients, if they have active disease, will help and augment the pulmonary vasodilator therapy in these patients. And I think while looking at her picture again, it came to my mind, we might need to do a genetic test for this lady. Maybe there is a variant also of some sort of telangiectasia in this. So this is our message, simply connective tissue disease can be associated with really bad pulmonary hypertension. And from the literature, survival for these patients when they develop pulmonary hypertension is much worse than those without pulmonary hypertension, and immunosuppressive therapy can help in some patients.
I would do the same, Dr. Prof. Abdullah, but I wonder what will be the message of biomarker follow-up for such cases. We have a clinical follow-up, yes, which is very important based on documentation and subjective or objective, and also biomarker. Needless to say that you have a multidisciplinary approach in such treatment.
She, in fact,
so if the ANA was improved,
she has a follow-up, close follow-up now with them, and I think now after them seeing her improving, they may be finally convinced that there might be a need for close with augmented immunotherapy, immunosuppressive therapy.
Yes, Prof, please. Thank you. Microphone again.
Microphone, yes. 2 brief notes. It's not a new recommendation of the guidelines. Green, treat underlying CTD in PAH. Thank you for showing this case. And my second note is stopping selexipag. I think it's not easy. And your patient is a good example for, if you take it out, they get much worse. I have had another personal experience with another case, and I think we should educate patients to talk to the physicians first.
Yeah, actually she was barely on selexipag. She used it once or twice. So she didn't tolerate its side effect. We educate her, we told her that she may tolerate it with some symptomatic relief medication. She couldn't tolerate it. So she was barely, from the beginning she was on dual therapy.
Okay. Thank you, Dr. Talal. It was very amazing and challenging to all of it. And this is again emphasize the issue of MTD. It's very important to have multidisciplinary approach in the cases where you have multidiscipline managing such cases. It's my privilege now to present a dear brother of us, Dr. Shai Al-Shai'. He's a consultant pulmonologist, pulmonary hypertension. He is the program director of pulmonary medicine and internal medicine and King Fahd Medical City in Riyadh. And he's the chairman of this beautiful scientific committee, science and topics we are dealing with. He's going to talk to us about a complex pregnancy process, which is a real challenge for the pulmonary hypertension group. Dr. Shai, the floor is yours.
So, Masar Khair, thank you so much for everybody who stay to this time of the end of the day. So before I start, actually, I'm trying my best to make it more interactive session. So I have four colleagues who is going to join me in this session. So Dr. Abdullah, if you don't mind, you can join us there and the podium, as well as Dr. Ghalia as well. I have also behind the screen another two colleagues going to be with me. Dr. Amal Srehi, she's a consultant maternal fetal medicine, and also Dr. Khalid Douais, he is a cardiac anesthesiologist consultant in King Fahd Medical City, as well as Dr. Abdullah Al-Khair, he's a cardiology and an interventionist and PH specialist, and Dr. Ghalia Bakhshi is a clinical pharmacist in our center. So a bit complex case, so I will share with them our perspective and sharing with you as well our opinions. So in pulmonary hypertension, when the patient comes to you, tell you I am pregnant, actually it's a nightmare. So I will be happy for them or you will be sad. So as you know, in normal pregnancy, there is a lot of changes at level of physiology. So there is decrease in systemic venous resistance, a change in cardiac output, increase coagulabilities, increase the oxygen consumption, and increase of blood volume. A normal pregnant lady, these things can be adjusted and can be adapted. But unfortunately, in pulmonary hypertension, it cannot be and can lead to worse outcome and death, unfortunately. So in addition to hypoxia, acidosis, pain, hypovolemia, hypervolemia, and maybe there is another contributing factor like pulmonary embolism during pregnancy. This makes things worse in pulmonary arterial hypertension ladies. All the current guidelines suggesting, either if you are talking about AAC guideline 2022, 2015, AAC guideline on management of cardiovascular diseases in pregnancy, and also the statement of pregnancy in pulmonary hypertension, Pulmonary Vascular Research Institute. All of them talk about avoidance of pregnancy during pulmonary, if the patient has pulmonary hypertension, and also therapeutic early termination. And you have to stick on early termination is supposed to be done. Also, if you go look for another article and people who have patients and case series talking about how we can manage patients in pulmonary hypertension and pregnancy, all of them, they mentioned we have to avoid pregnancy, even if you are you have all the facilities to deal with such condition in pregnancy. However, sometimes this is not the story. So sometimes you have a patient pregnant and unknown history of pulmonary hypertension can present at this time. And maybe sometimes unplanned pulmonary hypertension, unplanned pregnancy. And sometimes some people like to take the risk to be pregnant even with the high risk of mortality in pulmonary hypertension and pregnancy. And it looks like 178 cases per million of deliveries have pulmonary hypertension. So there is multiple case series and studies done before looking for pulmonary hypertension and mortality. It's like there is between 36 to 56% maternal mortality during pregnancy. And this is like the first one is just before starting all oral pulmonary hypertension targeted therapy. You are talking about 1996. The only medication approved at that time it was ibuprofen. Then the last one here is like from 1979 till 2007. You can see the mortality rate goes down. However, the mortality can be during delivery or even one month after. We can see the differences between the older days where there is no medication for pulmonary hypertension and after. Maybe the mortality goes down. However, all the cases, all the literature talk about you should avoid pregnancy, even in that 2022 guideline. So let's start with the case. So we have a lady, she is 34 years old. She is non-Saudi. She is not known to have any medical illness in the past. She was presenting to us at 16 weeks of gestational age. Her first pregnancy, it was ectopic, and there is like a ruptured laparotomy was done, salpingectomy. The second one was 2 months missed abortion. The third one was spontaneous abortion. So she has 3 times got pregnant. Fortunately or unfortunately, she got a car accident, and then it was like a minor car accident, not this one, by the way. So they called the ambulance because she feels short of breath at that time, and the tests, they check her vital signs, including the saturation, and she was severely hypoxic, like 70, something like that. So everybody was getting scared. She's pregnant and she's hypoxic. Let's go take her to the hospital. So she presented in other hospital, not our center, after this minor accident, severely hypoxic. All the workup has been done, including CTA, looking for PE, looking for all the possibilities. It turned to be like a pulmonary hypertension case. No right heart catheter has been done that time. And the team there decided that you should terminate this kind of pregnancy. You have to keep in your mind, it is like this is the fourth pregnancy. So taking some information from the patient, she does have like short of breath even before pregnancy. She said even at age of, started like 15, something like that, she feels some shortness of breath. She cannot climb all the stairs. She has to stop for a while to catch her breath. So this is not something like happened all of a sudden. So she refused all the advices for terminating her pregnancy, and she asked for a second opinion. So those people contacting us because we have a center for pulmonary hypertension, and we said, okay, let's bring her. So we did all the important workup, and you can see it's like during the time of COVID crisis and issues like that. So she has a large ASD. It looks like 3 centimeter. She has severe dilated RV, at least mild to moderate RV dysfunction. She has like RVSP of 100, so and severe pulmonary arterial dilatation. So we are talking about at least from behind, this is most likely goes with severe pulmonary hypertension. 6-minute walk test, she required 3-liter oxygen to walk like 282 meters. The first right heart catheter has been done for her shows like it's almost systemic pulmonary hypertension. The PA is 122/40, the diastole, and the mean pulmonary artery pressure we are talking about 74. Her cardiac output and index 4.1 and 2.2, and the BVR is almost 15. So we are talking about severe pulmonary hypertension. We get back to her, and her husband talked again. This is severe pulmonary hypertension. We have to take a clear decision regarding continue or termination of pregnancy, and they are clearly stated we need to continue this pregnancy. So we initiate phosphodiesterase inhibitors, and we are going to talk about it later on. At age of 22, gestational age, we need to make sure we are doing, like we are monitoring this patient. So another right heart cath has been done, shows almost similar numbers with mean of 74, 73, cardiac output 3.7, and the BVR still at 16. With monotherapy, we are expecting at like later stage of pregnancy that the cardiac output should be increased, and she's the opposite, a bit lowered compared to the previous like 1 month ago right heart catheter. So a bit looks short of breath, requiring more oxygen. So we start her in ileoprost plus oxygen plus sildenafil. So at this stage, I have to share with you that the obstetrician point of view opinion. So I would like to ask Dr. Amal, I think she's with us, to give you an insight about her opinion regarding pregnancy and pulmonary hypertension at this time of period. So
with the pregnancy with pulmonary hypertension. This patient, in the beginning, she was 34 years old, a Saudi patient, gravida 4 bara 0, and plus 3 low living babies, and she was at 15 weeks, and according to the criteria, she was referred from our other tertiary center for the second opinion regarding termination of pregnancy. At that gestation, this patient still in early stage of pregnancy. So after the assessment, really having the same opinion regarding to recommend termination of pregnancy because of her status at that presentation. So we sat in as a multidisciplinary team and we talked about the risk and the high mortality with this pregnancy on her life. And we thorough discussion done and the couple opted to continue with the pregnancy. It's really a high risk pregnancy with all this monitoring and close monitoring. It's a challenge for us. So we set to go to see how the progress of pregnancy, and this patient was admitted and all the examination assessment done for her. And she showed New York classification of 3 and with exertional dyspnea and chest pain, which went smoothly and intentional during pregnancy. And this baby showed really a normal growth centile according to the gestation. So at the time of the presentation, the baby, it was intrauterine fetal active fetus viable size equal 16 or equal date. And in follow-up ultrasound, the patient showed her requirement for oxygen. Other than that, she's having on and off oxygenation. With the support of the BELMO and the team, we are keep doing following this patient and we set for another plan for the time of delivery. So according to the patient status, we decide to go maximum for 34 weeks. At that time of the patient, we can interfere for medical reason without any compromise on the fetus, which is all with the mortality and morbidity going to be equal to 10. So we keep looking for this patient with our colleague. And at 20 weeks, we've done an ultrasound which showed no evidence of any congenital anomaly, and baby again growing in the normal centile according to the gestation, with showing all the signs, normal signs of viability and activity. The only things at 28 weeks, patient showed one attack of UTI, which was treated, simple UTI, treated without any complication. We kept the patient in the hospital with monitoring until we reached 32 weeks. Again, another follow-up ultrasound showing this baby growing in a normal centile of growth with normal signs of viability. Again, we are doing this serial growth scan just to make sure the chronic illnesses are not affect on the growth of the baby and not compromise with the patient signs of activity at that time. So we set another meeting just looking for when we deliver the patient, as the plan of delivery was set for 34 weeks. We consult our NICU just to make them on board with us. Then,
okay.
Go ahead, Dr. Shaya, and then we'll just have the other part.
Thank you, Dr. Amar. Thank you so much. We are going to proceed with the presentation. So at age of, not yet. So at age of 22, 28 weeks, we have done a couple of multidisciplinary discussion with multiple people and specialties, make sure everything doing great in regard of follow-up and make sure everything under monitoring. So at age of 22, we decided to go to pregnancy at 32 to 34 weeks. We discussed the ECMO, we discussed the mode of delivery, and also what is the team contributions. So I would ask Dr. Abdullah about his opinion, why we think of ECMO.
If you can show my slides, please. So we know that delivery is a very stressful event and is associated with significant changes in the hemodynamics, especially in someone with a very low cardiac reserve like this patient. And this may lead to acute shock state. So that's why VA ECMO has been shown in multiple case reports to be helpful in patients with this condition. But again, we're only seeing the positive cases. We rarely see the negative ones, so that's reporting bias. We don't have any stronger evidence to suggest routine use of ECMO in such patients. In addition, it should be well known that vascular complications can be catastrophic in VA ECMO and can lead to probably worse conditions than the initial one. If you can show the next one. So in this particular patient, the planning was the key. So first of all, she has a bidirectional shunt, and we had to be extra careful about the any unintentional introduction of air, as this could lead to air embolism in the arterial side of the body. So before she goes into the delivery room, we did an ultrasound of her femorals to get an estimation of the cannula size in case she needed to go for ECMO. We made sure that the perfusionist and the ECMO machine was in standby, and we did insert a small venous sheath in her femorals just to anticipate, you know, sometimes when they collapse and you do the CPR, it will be difficult to introduce sheaths in that fashion. So in this particular case, we put in a venous sheath. We left the arterial. We did not put it because it was probably straightforward. So take-home messages, you have to plan this carefully, especially you have a lot of time before she goes to delivery, and you have to involve the whole team. So the whole ECMO team was aware of this lady condition, and we were on standby for probably not just the delivery time, but for a few days after, as they can also decompensate, not during delivery, but probably a few days after. So we did not have to insert VA ECMO, but we were ready, and there are some reports to show good outcomes when you implant ECMO or when you insert ECMO in such patients. Thank you.
Okay. So the idea is that we are anticipating the worst case scenario, and we have to keep in our mind that something can go south. So we have to prepare our patient for any possibilities during delivery. So one of the important things that to keep in our mind, the ECMO. So even during pregnancy, we insert that the lines just in case of preparation for anything can happen. So one of the challenges that we face, especially this during COVID time, is the medication. And so we have our clinical pharmacist, Dr. Ghalia, maybe she can talk about it. So go ahead, Dr. Ghalia.
Thank you, Dr. Shaya. So in terms of the pulmonary arterial hypertension specific medication, when it comes to these patient population, unfortunately, we have a limited data about what to use and what is recommended. Generally speaking, in the guideline, it was recommended that endothelial receptor antagonist and guanylate cyclase stimulator should be avoided because it has been proven that those medications are teratogenic, and they are both under the REMS program. When it comes to the options that they mentioned, they briefly mentioned that the phosphodiesterase inhibitor as well as the prostacyclin can be an options to use in those patients' population. Generally speaking, these medications, we have to look into benefit versus risk. And also I found a systematic review that looked into the sildenafil in those patients' population. And the results was that there were no fetal adverse event had been observed.
Okay, so go ahead.
So here I'm just going to talk briefly about our patient, what we did in the beginning, approaching delivery and postpartum. So upon diagnosis, as Dr. Shaya mentioned, we started the patient on sildenafil 25 milligram 3 times daily, and then we initiated iloprost 2.5 microgram, starting with 4 times daily and titrating it to up to 8 to 9 times daily. During or approaching the patient's delivery, the team decided to transition the patient from the inhaled iloprostanol to IV epoprostanol, and we did a plan for tapering down the inhaled iloprost to the epoprostanol, and we initiated with the lowest dose of 1 nanogram per kilogram per minute, and we reached to a 9 nanogram for this patient. In terms of postpartum, we did the opposite, where we tapered down the ibuprostanol IV and reintroduced again the iloprost inhalers. DVA prophylaxis, furosemide was all given during her full pregnancy.
Okay, so let me talk about some challenges here. Actually, during COVID, we have problem with the shipment to bring the ibuprostanol. So we have only 50 vials in the hospital. We don't have no more than 50. So we have to play it carefully. So we have to decide when we have to introduce the ibuprostanol. So we do have all the medication except the 50 vials of ibu. So at age of like 31 weeks, we meet together again, all the teams involved in this condition, pulmonary, PH, obstetricians, cardiac anesthesiology, cardiology, ICU, ECMO team, congenital heart disease, clinical pharmacists, and pediatricians. I bring them all together to make sure everything is clear, everyone know how we have to do. You know, after 31st week, you don't know what will happen in any time. So from pH point of view, we put her in a monitored bed. We start her on ibuprostanol. We titrated up gradually, as mentioned by Dr. Aghalia. There is one thought about maybe a discussion for another day. Should we add a Posentan at this stage or not? There is a big discussion. Maybe it's not for today. We didn't do it. And keep in mind that at COVID crisis, we have a 50 vial. We have to measure exactly how much vial we are going to consume. So at 33, we are all prepared. This is Dr. Khalid and Dr. Ahmed. Sunday AM, everyone is ready there at 6th of March 2022. And I will leave the mic for Dr. Amal to be with us to talk about what is her opinion regarding the mode of delivery and what should we do in terms of pH in this condition. So Dr. Amal.
Again, thank you. Again, we decide to go for 34 weeks. Unfortunately, this patient, like week earlier, start to have labor-like pain and ruptured membrane. So we call the team again. We're gonna do the cesarean or delivery at that is earlier than what we decide. So we give the steroid for lung maturity, and then we choose to go for safest mode of delivery, where as this patient really a high-risk patient, we are not liable to be in stress with the induction of labor or augmentation of labor. So cesarean section, of course, again, she's not in a normal presentation for the fetus, so again, she's not liable for the another indication for intervention by cesarean section due to breech presentation. So we planned the cesarean section to be at 33 weeks. And after we give the lung maturity and we talk to the patient, explain all the procedure, the team was in board as Dr. Abdullah and Dr. Shaya. They are in board with Dr. Khalid Dwais, our cardiac anesthetist. It went with smooth cesarean straightforward cesarean section with good outcome handled to the pediatrician. And the weight, it was reasonable weight, which was around 1.7 kg, with cried immediately, active baby, admitted just because of prematurity and further assessment. And the patient then, during the cesarean section, he will take about the anesthesia part, and after that, patient was shifted to CCU for further observation and monitoring.
Okay, thank you, Dr. Amal. So what we are talking about is the antenatal period. So our job as a pulmonologist, pulmonary hypertension, we sit multiple times with other teams like ECMO team, cardiology team, clinical pharmacists, and also the gynecologist and obstetrician. So what we have to do during the procedure itself. So actually, it's really challenging even for me to attend this kind of challenges during procedure. So I would like to introduce Dr. Khalid. He's our cardiac anesthesiologist. So Dr. Khalid, what do you think? What do we need to do?
Thank you, Dr. Shaya. Actually, unfortunately, about all cardiovascular disease during pregnancy, pulmonary hypertension carries the highest risk of death. And the most Critical period is postpartum period because it's high the risk of acute right heart failure and death due to increased pulmonary vascular resistance and delivery-associated acute volume overload. Actually, what we did during that time, we had a discussion, a multidisciplinary discussion about the case, and we know anesthesia carried the highest risk and effect of outcome of the pregnancy during this severe heart disease. Both regional or general anesthesia have typical adverse effect that can severely affect the outcome of our patient. Therefore, we have to be cautious either to use regional or general anesthesia. Actually, the patient had shortness of breath. She cannot lie down at the end of day. That's why we decided to go with general anesthesia. Everything is under control, and we prepared for that. Our hemodynamic goal was to decrease pulmonary vascular resistance with avoiding the pain, hypoxemia, all participating factors like hypercarbia, acidosis, and we try to maximize pulmonary vasodilatation. And we have to support the right ventricle inotropy, and we keep the ECMO as standby with Dr. Abdullah Khudair. We have to control the volume status because we know the third part of pregnancy will increase the risk of volume overload, and we have to maintain our maintenance, and we have to replace any bleeding with blood, not with the crystalloid. We decided to have the advanced monitor plus the SA monitor. We used non-invasive and invasive blood pressure, central line for inotropes use, and for monitoring also the central venous pressure. We introduced also sheet for pulmonary artery catheter for postoperative monitoring, and we use the transesophageal echo plus bispectral index to manage our level of sedation. Our access was venous, peripheral, and central, and we keep an access for venous for backup of ECMO with micropuncture catheter. It was 4 French, and we cannulate right femoral. Before patient came to OR, we actually prepared her psychologically and mentally to make sure she is understanding and take care of her surgical part, the psychological part. We try to convince her. We describe all what we will do inside the OR. We take care for her. We insert the lines in awake situation and the local anesthesia because we want to avoid any medication go to the baby. We want an Apgar score of high Apgar score. We insert central line and arterial line awake. We insert the femoral micro catheter for ECMO standby. After we are ready and patient draped, we start our general anesthesia. We induce the patient with general anesthesia, and we use nitric oxide as inhalation. We start milrinone inside the OR. We'll continue our medication that started before. After that, baby delivered, and we start to give her some opioids. The baby was in good condition, high Apgar score, he was crying, moving. Till the end of the procedure, we extubate the patient and give her regional anesthesia for block. We give her a tap block, and we use BCA fentanyl for her to control postoperative pain. After that, patient delivered to the ICU with vitally stable and with minimal inotropic support of epinephrine 0.02 mic per kg per minute. And alhamdulillah, procedure was succeed. Thank you.
So thank you, Dr. Khalid, for illustration of what we have done and during the OR. So you can imagine how many lines there for certain lines, one gans, PIC line, 2 femoral lines, intubations, inotropic support, just to make sure everything is perfect. So this is her monitored, and we have the pulmonary artery pressure is like almost equal to the systemic pressures, and this is on top of all what I've mentioned from the inotropic support plus the ibuprostanol. We finished the surgery, all the team, plus there is some team behind the scene. So everybody is happy after listening to the baby when he's crying. So we are okay, we are a bit relieved. So it was baby is good, take it to an ICU, in good health, no complications happened. Weight is like 1.8, something like that, and discharge in good condition after a week of delivery. So is the story is ended here? Unfortunately, it's not. So we shift the patient to the ICU. You can see her Swan-Ganz is there, so the pressures is almost still equal from the systemic and also the pulmonary pressures post C-section. After extubation, she is requiring higher flow of oxygen up to 60%. She was like in 2 to 3 liters before delivery, and after that we cannot wean down for a week. She's requiring higher flow of oxygen, and then we just questioning ourselves, are we doing something wrong? So we cannot wean her from 60%. Do we have a PE? Do we have like a worsening of pulmonary hypertension? Do we have something else going on? Do we have like aneurysmal dilatation of something? So multiple workup has been done, including, as you shown here, the pressures. Nothing is conclusive. We don't know why she is requiring this high flow of oxygen. One of the important things that we have done is the CT scan. And you can see how huge of pulmonary artery and segmental and subsegmental arteries. You can see the down here, the picture, how the pulmonary trunk is dilated. So all workup it shows that she looks stable overall. For whatever reason, we don't know why she was improved gradually over like a week. I don't know even to this point. I remember I talked to Dr. Abdullah and Dr. Majdi. In addition to other group like Dr. Hussam, she is requiring high flow of oxygen, and we didn't know why. And what happened over like 1 or 2 days, she's from 60 to 2 liters. What's happened, I don't know so far. I asked a couple of colleagues to give me their insight, but we couldn't find any clear answer for that. However, we titrate down the ibuprostanol. Thanks, alhamdulillah rabbil alameen. When we titrate, when we stop the ibuprostanol, we have only 3 vials at the shelf. And we switch back to Elioprost, and we add Bosentan in addition to sildenafil. We kept her around 4 weeks. She's
risk group, like from low to high risk patients, and thank you for showing the approach. Dr. Qutb advised earlier at the beginning of this session he encouraged you to publish these cases. I, as a pulmonary hypertension practitioner, I feel very grateful for every physician who published his experience with pregnancy and pulmonary hypertension. As you have mentioned, we don't have concrete data about the outcome of these cases, so we refer to this case series. So the whole world will be grateful for you if you share this experience and publish it. Thank you. And the floor is for questions. Dr. Grimley.
Thank you very much. Very interesting case, and this is reflect the usual care of unusual patients, pregnant patients, when they are diagnosed with pulmonary hypertension. And the beauty about this case, not only the complications and the multidisciplinary approach, was the diagnosis. She was not known to have the problem. So and this is, by the way, a shift in the guidelines in the recent pulmonary pregnancy, European Society of Pregnancy guidelines, that they are not encouraging people to get pregnant, but the wording is less than the previous, or softer than the previous guidelines, and they are suggesting to perform right heart, actually encouraging to perform such patient right heart cath during pregnancy and start treatment during pregnancy. So a few points actually regarding this case. First of all, although the delivery itself and pregnancy is high risk for such patients, but majority of them statistically die afterward, actually. So that's one, and up to 1 month their risk still. So obviously we don't keep patients during all this period. One of the key approaches if for such patient, you try to optimize their situation. And I personally, and based on anecdotal evidence, and you can see that in the conference, if you go to conference, people tell you about their experience, is Lasix. And aggressive, to be a little bit aggressive with diuresis after monitoring and all of this. And even if she's doing well, I think diuresis is key in managing these patients. So that's second issue point. Third is hemoglobin. or anemia level. So I don't know what's her baseline oxygen saturation, but I assume with that RV and the presence of chance, she's been hypoxic for a while, although she was admitted in the hospital multiple times during their missed abortion, etc. So I don't know what's her underlying oxygen saturation, but this is a problem taking care of such patients when the patients are cyanotic and you see their hemoglobin are 12, you assume that's normal. Actually, it's not. For a patient with oxygen saturation in the 80s, high 80s, their hemoglobin level should be in the 19s, 20. So when their hemoglobin level is 12, that's severe hypoxia, and they're not going to do well. So that's one thing. Last, about your point, why she went into, you are trying to explain the sudden drop in her oxygen saturation, then improvement. So in congenital patients with the shunt, it's a little bit different than pulmonary hypertension, pure pulmonary arterial hypertension, because it's a delicate balance between a left and right side, systemic and pulmonary vascular resistance. So any change in the clinical situation, like let's say hypovolemia or sepsis, minor infection for some patient, the patient, without you noticing it, the shunt will be more right to left and patient going to hypoxia. So that's why they are very sensitive. Simple thing with them will change or tip them off their usual balance.
Yeah. Thank you, Dr. Ahmed. Actually, we try to entertain all the possibilities of why she is hypoxia. One of the things we give her blood, just to make sure we are not missing the increasing
blood volume,
everything was
aggressive antibiotic, all of them.
And believe it or not, I remember it was in the weekend. What I have to do. Everything looks perfect, but I don't know why she's requiring high flow of oxygen. I wake up in the morning, she told me she's in 2 liters. Oh, okay, what happened? I don't know.
So that's good. Blood help, obviously.
Yeah, actually we did a couple of things, but we try to exclude things as well.
Thank you, Dr. Shaya and the team. Great work. So, short question. So, why about the parenteral therapy? Why it was not considered earlier, and why it was stopped after delivery?
We have only 50 vials. It's needed 3 months to bring another vials, and that's the only answer. We didn't have much. For some reasons or technical issues, logistic issues, it was like during COVID. We call our partners from J&J told I need it urgent. Actually, 300 vials came after 2 weeks after we finished or stopped the evaprostinol.
Yeah, because I just want to stress in the point with Dr. Grimley, the most important periods is as you know, the second trimester and post-delivery. So it's a really tricky period.
Actually, we wasn't prepared to have evaprostinol on the board all the time.
Thank you, Dr. Shaya. I think it reflects how the teamwork can come with a good outcome by Allah subhanahu wa ta'ala. And second point is that this is the beauty when you're under crisis like COVID, where you cannot do anything. So you have to use all the benefit of facility you have and how to get really the benefit of the medication. Thank you very much, Dr. Shaya,
thank you so much,
Dr. Haida, Dr. Khadir, for Dr. Amal, and Dr. Khalid for an excellent illustrative. I insist that if you could really publish the case, let the people learn from us in such experience, which is very important.
Yeah, actually, I think we have to collect all these cases together, and we can discuss it and try to publish it. I would like to thank all people when you are stuck, you will find all the people around. We have 6 people, 6 teams working together just to make things perfect and professional.
Thank you, Dr. I think we still have one case.
Okay.
Yes, please.
So while we're preparing for last case, about publications actually, but we have to be aware of publication bias, because if you're only going to publish your good cases, if successful pregnancy cases, that's going to bias later on.
Okay.
So even if you want to publish, even the patient who doesn't do well.
Also. Okay, well noted. Thank you, Dr. Grimley. So now we introduce Dr. Nof bin Hamid. She's a fellow of the Adult Pulmonary Medicine Program, and she's going to give a talk or a case about familial pulmonary arterial hypertension.
Bismillah. Thank you for the kind introduction. I know this is the last case, but it will be quick, inshallah. So mainly my presentation consists of 2 parts. So the first part will be the event leading to the primary diagnosis. Then the second part, inshallah, will be a follow-up for the case. So, Bismillah. Our case study is an 18-year-old female patient who was referred with a history of exertional dyspnea. Been treated before as a case of bronchial asthma with no improvement and had been on some sort of growth hormone treatment due to poor somatic growth and poor secondary sexual characteristic and no menarche. She also reported a family history positive for pulmonary hypertension. Two of her sisters passed away due to disease severity and complication at the age of 13 and 25 years of old. Also, both of the sisters had reported symptoms also suggestive of poor somatic growth and secondary sexual characteristic. So this is the family pedigree. We can see our patient was 18 years of old. Her elder sister, who died or passed away at the age of 25, received the diagnosis of pulmonary hypertension and underwent atrial septostomy, and her cause of death was reported to be right ventricular failure. And the youngest sister, at the age of 13 years of old, again received the diagnosis of pulmonary hypertension, and the cause of death was post-right heart cath cardiac arrest. So in examination, the patient looks patient looks small for her age with BMI of 21, vitally stable, no clubbing, and her cardiovascular and respiratory examination were normal at that time. There were no clinical signs suggestive of right heart failure. So this is her first transthoracic echo. It showed normal intracardiac anatomy with mild TR with estimated pulmonary systolic pressure gradient around 50. Right ventricular inflow and Doppler tracing was suggestive of mild diastolic dysfunction. There was mild dilated and hypertrophied right ventricle there, and no major valvular abnormality and good biventricular systolic function and no pericardial effusion. So the patient been treated conservatively. However, her follow-up echo showed similar echographic finding with elevated pulmonary systolic pressure gradient up to 45 millimeter mercury, dilated right ventricular, right atrium, and main pulmonary artery, and still there was no pericardial effusion, yet she had good right ventricular function. So the decision was to take her for right heart cath, giving her persistent symptoms despite treatment. So this is her first right cath on November 2010. At that time, the patient had hemoglobin of 13 and her heart rate showed sinus rhythm around 95 beats per minute. We can see that the mean pulmonary artery pressure was 33, wedge pressure around 5, and cardiac output 4.5. And her pulmonary vascular resistance calculated at 5.1 Woods unit. So the patient received the diagnosis of idiopathic pulmonary artery hypertension, started in combination therapy, namely sildenafil 20 milligram PO 3 times a day, and later on March 2011, bosentan was introduced. So fast forward to follow up, patient currently is 25-year-old on sildenafil and bosentan, same doses, received the diagnosis of partial empty cell syndrome, in addition to pan-hypopituitarism, giving her a history of amenorrhea and adrenal insufficiency, central hypothyroidism, and hypogonadism. So her workup for pulmonary hypertension was undertaken again, showed pro-BNP of less than 10. Her basic autoimmune workup was negative. HIV serology were non-reactive. So this table summarizes the patient from endocrinological point of view. So from the top, patient received a partial empty cell syndrome, which is a radiological diagnosis based on MRI of the pituitary. Adrenal insufficiency received it based on hormonal study, and patient was clinically stable and adequate hormonal replacement therapy. Central hypothyroidism based on, again, hormonal study, and clinically and biochemically she achieved euthyroid status. And central hypogonadism based on positive withdrawal test and planned to be committed on hormonal replacement therapy. At that time, her medication was changed from bosentan to ambrisentan due to drug-drug interaction. And we know that the patient reported history of growth hormone deficiency and received growth hormone injection pre-pubertal. So her repeated echo still showing echographic findings suggesting of pulmonary artery hypertension with estimated right ventricular systolic pressure at 47 millimeter mercury, and previously it was 34 millimeter mercury. Her right and left ventricular diastolic ratio was around 0.8, and TAPS is around 18 millimeter. So this is her chest X-ray. There is no major abnormality other than radiological findings suggestive of right ventricular enlargement. Her CT showed bilateral non-specific ground glass opacity and no feature suggestive for underlying interstitial lung disease. VQ scan was done. It was non-conclusive or showed low probability for PE or CTEF, and some findings consist with an element of airway disease with no segmental or lobar mismatch perfusion defect. So this is her PFT. It showed a ratio of 78 with proportionally reduced FEV1 and forced vital capacity. Her residual volume is around 147% predicted, and the fusion study showed 76% predicted, corrected to her hemoglobin. So this is a table showing a 3 years worth of follow-up. So in year 2016, the patient was on sildenafil and bosentan with functional class of 1. Her BroBNP was not available. However, her 6-minute walk test, she was able to walk more than 400 meters. 2018, this is where the patient shifted from bosentan to ambrisentan, yet she was kept on functional class 1 to 2 and scored intermediate low risk group, and she was able to score more than 400 meters in her 6-minute walk test. So again, reintroducing her family pedigree. So we get a family with 3 daughters diagnosed with pulmonary arterial hypertension, younger than 30 years of age. All of them have clinical signs suggesting an underlying endocrinopathy, with our patient diagnosed as a case of partial empty cellular syndrome and panhypopituitarism. So the next decision was to do genetic testing. So the PMPR2 sequencing showed no pathognomic variant. So the next step we did whole exome sequencing, again showed no clinical relevant variant with significant phenotypic overlap. So after which we thought the patient, she had endocrinopathy requiring hormonal replacement, whether the hormonal replacement will affect her hemodynamic or show improvement in her previously measured hemodynamic. So she was underwent right heart cath again in 2017. Into your right, this is the diagnostic heart cath, and the left, it's the follow-up right heart cath. We can see that her mean pulmonary artery pressure didn't change that much, and her PVR went from 5 to almost 7.4 Woods unit. So currently, the patient now is around 35 years old on combination therapy, sildenafil and ambrisentan. She is at an intermediate low risk group with functional class 1, her BroBNP less than 50, and last 6-minute walk test scoring 370 meters. So thyroid gland and pulmonary hypertension, what is the link? So we know from the guideline that to identify associated condition, all patients should receive a thyroid function test during the diagnosis of pulmonary arterial hypertension. Yet we know from the REVEAL registry that thyroid disease were reported in patients, in particularly female patients with idiopathic pulmonary arterial hypertension compared to other subgroup of pulmonary arterial hypertension. This table summarizes clinical trials and case report looking into hyperthyroidism diagnosis in patients with pulmonary hypertension, whether the treatment of hyperthyroidism will improve their hemodynamic. So they looked into their pulmonary artery systolic pressure by echo before and after treating hyperthyroidism, and we can see that there is reported improvement in their hemodynamic after treatment. So also this study looking into high prevalence of autoimmune thyroiditis in patients with pulmonary arterial hypertension. It's a single center prospective observational study including 63 patients with pulmonary arterial hypertension. And out of the 63 patients, 31 patients received the diagnosis of thyroid disease. And out of the 31 patients, up to 40% of these patients actually diagnosed with Hashimoto disease. So, up to our knowledge, we couldn't find any case report elaborating or showing a familial pulmonary arterial hypertension with empty cellular syndrome, with panhypopituitarism, with a strong family history showing gene negative study. And could it be a de novo pathognomic variant that the patient is still, we don't know what type of gene mutation the patient and her family have. And with that, I conclude
enough for this case. Thank you for the audience for staying with us until now. If there are any questions? If not, then I think Mr. Hassan, you would like to make an announcement.
السلام عليكم واسعد الله مساكم بكل خير. شكرا يا اخوان على for staying this late. The buses will leave to Ithra at 6:20 sharp. So please, I know it's a short time from now until then, but 6:30 the 3 big buses at the parking lot. Please join us for dinner, and we are going early for about 1.5 hour tour. The place requires more than that. And then 8:30 the dinner will start, and it will be served type dinner, not a buffet. So all are welcome. Thank you.
Thank you very much, and see you tomorrow, inshallah.